Hi, Shanta, welcome.
We have to go to live.
Thank you, madam.
Should we start, madam?
Yes.
Hi, Shanta. How are you? Good afternoon.
Assalamu alaikum, madam. Hello, madam.
Let me start the program, please. Dear participants from country and abroad, Assalamu alaikum and very good afternoon. Me, Professor Sheikh Zinnat Nasreen, International Secretary of Endometriosis and Adenomyosis Society of Bangladesh, welcoming you all in this pre-Congress workshop of first virtual International Scientific Conference 2021 organized by Easb. Endoscopic surgery is so promising and essential that it became now the backbone of all the gynecological surgery. Therefore, you all need to be very competent and safe surgeon as well in this regard. And that is why we have chosen the theme of our workshop is tips and tricks of safe gynecological endoscopy surgery for endometriosis and adenomyosis. I'm happy to announce that this is a very short but very significant inaugural session, which will be chaired by Professor T. Chodri and Professor Samina Chodri. We're extremely delighted to have a Dr. S. Shanta Kumari and Dr. Juan Tiago as chief guests of this occasion. Also, it is our honor to have Professor Saleh Begum Chodri and Dr. Dilip Bhomik with us. Now, ladies and gentlemen, I would like to call upon Professor Samina Chodri, the founder president of EASB, to have her valuable remarks from the desk of president. Professor Samina Chodri, madam, please.
Assalamu alaikum. Good afternoon to you all. Respected chairperson, distinguished guests, resource person from home and abroad, and my dear participants. I welcome all of you for your presence in this pre-conference of Endo Bangladesh 2021. You all know that globally 1 in 10 women are suffering from endometriosis, which is a severe life-impacting pain during mens, during intercourse, and also defecation, micturition, and sometimes anxiety and depression, and sometimes it is infertility, and even malignancy, though it is rare. There is a knowledge gap existing in this field, so we need more research. There is diagnostic delay, which complicates the process, so early detection and treatment, which may halt the disease process. The modalities of treatment, both medical and surgical, the medical methods, mainly hormonal, that prevents ovulation. But we want such drug that enhance the pregnancy and also alleviate the symptoms and less side effect. So researchers should come forward. When medical methods fails, then comes the surgical methods, the aim of which is alleviate the symptoms, prevent recurrence, halt the disease process, maintain the future fertility, and prevention of rare occurrence of malignancy. Surgery can remove the endometriotic lesion, adhesions, and scar tissues. World authorities on endometriosis says that don't touch the ovaries unless it is very much required. This surgery must be done by very skillful hand, maybe once in the life of women. Multidisciplinary approach is very important. For this reason, the theme of this conference is tips and tricks of safe gynecological endoscopic surgery for endometriosis. There are 5 sessions in this conference and which are enriched by our world-renowned surgeons. They will give us the future direction and tips and tricks of safe surgeries and rethinking of surgery, what to do and what not to do. We will listen to them and learn from them. Thank you very much. Welcome again.
Thank you, madam. Thank you very much for your very precise but very commendable remarks. Thank you very much. Now it's my pleasure to call upon the Secretary General of EASB, Professor Saleh Begum Chodri for her remarks and the welcome address. Professor Saleh Begum Chodri, madam, please.
Thank you, Professor Jina. Assalamu alaikum and good morning and afternoon to everybody. On behalf of Endometriosis and Adenomyosis Society of Bangladesh, we welcome you all to a first international virtual conference and pre-conference organized by Easb. We feel delighted with large number of world-renowned speakers, chairs in the conference and pre-conference workshop. This is first international conference solely on endometriosis and adenomyosis in Bangladesh. Honorable Chief Guest, Dr. Juan Diego Vilezes Egberis, Chair, Minimal Invasive Surgery, FIGO, and Professor Shanta Kumari, President FOXY. We are very much grateful to you for your kind presence and grace this occasion enormously. We are honored to have Professor T.U. Chodri, National Advisor Easb, and Professor Samina Chodri, President Easb, as a chair of the session. The theme of the conference is Combat Endometriosis Together, focusing collaboration and collaborative work at national and international level to combat endometriosis. The theme of the pre-conference workshop is tips and tricks for safe gynecological endoscopic surgery in pelvic endometriosis, expressing essentially education, re-education, training, retraining, learning, understanding, and use of tips and tricks to make the endoscopic surgery safe in pelvic endometriosis. Dear participants, we have 28 sessions in conference and pre-conference. In conference, 23 sessions on 15th and 16th October, and 5 sessions in pre-conference. Today, all sessions are on gynecological endoscopic surgery from basic to advanced laparoscopy. Total 121 faculty we have in the conference, 50 international, includes speaker 39 and chair 11, and 51 national faculties includes speakers, chair, panelists, moderator, and reputier. Dear audience, Society started its work since January 2020, extending its work collaboration with World Endometriosis Society, Asian Endometriosis Society, European Endometriosis League, and National Society in the country. Throughout the last 1.5 years, Society continuously has been working on scientific and educational aspect of the disease involving national societies, medical colleges, universities, and other institutes and facilities in the country to standardize the treatment and care for women suffering from endometriosis adenomyosis in the country. Organized many awareness creation programs throughout the year through different media, mass media, electronic media, social media, to aware women about the classical symptom of the disease. Observe month of endometriosis twice, organizing different scientific program, talk show, and other awareness program. Organize several voice raising program through Pratham, Jamuna TV, Rajtv, and RTV. Involve gynecologists, senior and junior, school teachers, adolescents, parents, guardian, patients of different age group, representation from civil society to make understand the need of early diagnosis and treatment to halt the disease process and its subsequent consequences. Organize different school-based awareness program, including all teachers and students. Society have developed support group in the name of information team. Started school-based research on adolescent endometriosis. Ladies and gentlemen, accordingly, this is first international conference and pre-conference organized by the society. Dear participant, your presence, participation, presentation, talk, interaction, all are very important for us. Hopefully, all this endeavor will make this conference exceptionally rich and successful. My heartfelt thanks to the committee for the conference and a special thanks to the scientific committee for their hard work, continuous effort to make the conference successful. Welcome you all again. Please enjoy the session.
Thank you.
Over to Professor Jina.
Thank you, madam. Thank you very much. And rightly, you have mentioned all the remarkable activities you have done. It's a really wonderful job. Thank you, madam. Now it's time to go to our chief guest. But first of all, I'd like to call upon Dr. S. Santakumari. Santakumari madam is very, very well known and our beloved friend and well-wisher of the OGSB. She is rightly now president of FOXI. She was a FIGO member of Committee of Human Rights, Refugee, and VAW, that is Violence Against Women, during 2018-2021. She was the chairperson of FOXI and ICOG, and she was the secretary of TCOGS. She was awarded FOXI Start Award during 2017. Welcome, madam. Welcome for your kind remarks for this webinar. Professor, Dr. Santakumari, please.
Thank you very much for your kind words. Good afternoon to everyone, and welcome to Dr. JD, who has visited this part of the world on behalf of India and Bangladesh.
Now, we can't see your video, ma'am.
I am there, no?
But we can't see your, yeah, now we can see. Thank you.
Okay. Because I'm on the road, in fact, I just got on from the flight. Now, can you see me?
And gone, madam.
Okay. Yeah. Thank you very much for inviting me. Indeed, a pleasure. And yes, as rightly put by Madam Samina Chodri, endometriosis is such a it's real painful problem, not only to the patient, for even us as gynecologists. And definitely, yes, we look forward to the best of the surgeons whom we have, the world-renowned surgeons, to be able to impart that small techniques and tips and tricks to make everyone competent to manage this problem. So I think this is a wonderful initiative, and it's lovely to be here. And thank you very much. And my regards to everyone who is there. Almost all my friends are here in this program, right from Samina Chodri madam to Dr. Chodri, Professor Chodri sir, and Fauzia, Laila Arjuman Banu madam, and so many others. Really, it's difficult to mention each one by name. I think I heard even madam's voice also, though I can't see her. So I wish you all the best. Let's hope that very soon that we'll be in a better position to do physical conferences, and we look forward to visiting Bangladesh, and we invite you also to come to Hyderabad again. All the best to all of us.
Thank you, madam. Thank you for your inspiring and hopeful talk. Thank you very much for being with us. Now it's time. I'd like to invite Dr. Juan Diego. He's popularly known as Dr. JD. Dr. JD is a very well-reputed and world-renowned endoscopic surgeon. We're very much honored by having you, Dr. JD. He's the chair of Minimal Access Surgery, FIGO. He's the chairman of FIGO's World Laparoscopic Committee. He has been an active member of different associations and organizations at national and global levels. He has published a lot of different medical journals and textbooks, as well as he is a teacher at different universities at national level. Welcome, Dr. JD, please.
Salam alaikum. Good morning, good afternoon, good evening to all of you. It's a pleasure and an honor to be here in this international scientific conference for the Endometriosis and Adenomyosis Society of Bangladesh. It is a pleasure and an honor to be joining you all today in this meeting. You really have an amazing meeting together with lots of topics that are going to be touching not only doctors, but also patients around the country. I thank you for the invitation in my name and from the Committee on Minimal Access Surgery of FIGO. I'm sure this is going to be really useful for doctors and patients. Just to say that worldwide, a vast number of benign gynecological surgical procedures are performed via laparotomy, despite the overwhelming benefits that we all know about the minimal access surgery and the benefits. For example, hysterectomy is one of the most common operations performed in women worldwide. And while laparoscopy and other minimal access surgery techniques have become the most common approach for the hysterectomy and other benign gynecological surgeries in high-income countries, laparotomy is still frequently used throughout the world. This is despite the fact that minimal access surgery approaches to surgical procedures are associated with decreased morbidity and mortality. So FIGO and our minimal access surgery committee is willing to work that all women should have access to high quality, safe and affordable minimal invasive gynecological surgery. Information regarding minimal access surgical techniques should be given prior to every surgery for women discussing surgical treatment for benign gynecological conditions. Women need to be empowered to ask their healthcare providers for less invasive approaches to the surgery, and women should be provided with knowledge and guidance to help them become advocates for the gynecological surgical needs. So in FIGO and our minimal access surgery committee, we work for advocate for minimal access surgical techniques, promote and undertake activities to build surgical capacity and expertise, provide women with the knowledge that make them aware of their options, increase access to high quality minimal access surgery, and decrease barriers and disparities in quality of gynecological surgical care worldwide. So that's why these kind of meetings and the amazing program that you put together is so important. We need to give better quality of care of patients with endometriosis and adenomyosis. And the only way is to keep giving doctors the tools to approach these women and give them a better way to take care of their health. So thanks again for the invitation. It is an honor to be here with you all, my friends and colleagues. And from Colombia, I give you a big hug, and I hope this meeting is gonna keep a great meeting for everybody. Thank you.
Thank you, sir. Thank you very much. But we would like to request you to inaugurate by 1 or 2 lines for this pre-conference workshop, sir. Your inaugural remarks, sir, please.
This is a really great and amazing pre-conference. We're gonna have 5 sessions, including tips and tricks for safe gynecological endoscopy surgery and pelvic endometriosis and adenomyosis. The first session is gonna be about basic principles of laparoscopic surgery for pelvic endometriosis by my good friend and fellow committee member, Professor Laila Banu. Then we're going to be talking about fertility sparing endoscopic surgery in pelvic endometriosis by Professor Cantrell. The third session is going to be about what to do and not to do in adenomyosis surgery by Professor Zuppi from Italy. Then we're going to be discussing about gynecological endoscopy surgery for deep infiltrating endometriosis by Professor Alain Stefan Constantin. And finally, the last session is going to be about how to approach laparoscopic hysterectomy in the frozen pelvis by Professor Rahman. So this is a great program that I'm sure everybody is going to be happy to get, and is going to help not only doctors but patients.
Thank you. Thank you, sir. Thank you very much for inaugurate our session. Thank you, sir. It will be memorable for us. Okay, thank you. Now, I'd like to request, and it's my proud privilege to call upon Professor T.A. Chodri, who is a national advisor of this EASB, and actually serves the teacher of teachers, mentor of mentors. Sir, would you please give your valuable opinion today?
Thank you very much. First of all, I'm extremely glad that I have been invited to join this workshop. Now, endoscopy has actually changed the whole picture of minimal access surgery. Or laparoscopy has changed the whole picture of endometriosis, diagnosis, and management. Now, up till now, most people believe that in laparoscopy is the gold standard for the diagnosis of endometriosis, though this is being challenged somewhat nowadays with the advent of newer modalities for imaging. Laparoscopy has got its inherent problems. It looks very easy when you see a video. Most of these videos are edited videos, and you do not see the actual picture where the surgeon was in problem. But in any case, it is much safer than open surgery that all of us will agree. So this is quite important. But the important thing is that don't overstep your capabilities. Because if you go to treat a person endoscopically in a case of endometriosis, you must have clear in your mind that what you are going to do actually, and try to do that the best possible way. The result of repeat surgery in endometriosis is not very promising, not as regards pain relief or as regards fertility improvement. So fast is the best. Whatever you do, have a clear focus in your mind, how much you can do, and there is no shame in taking the help of a colleague if you think that it is beyond your capability. And this applies particularly for deep infiltrating endometriosis. So my first caution is that you must know your limitation. Endoscopy is by far the best surgical approach, but it is not necessary in all cases. And if you do it with the best of your ability. Half-done job is bad for the patient because repeat surgery always gives more damage to the ovaries, particularly, and also the results are not very good. So I hope that from this workshop, which has divided into 5 sessions, attending to various aspects of endoscopic surgery in endometriosis will be very useful. But do not lament or get disappointed if you think that you will not be able to do what our current experts are doing. Time will give you the opportunity to improve your skill, and you must continue your skill to improve it. The only thing is that I have already said, and I'll say repeatedly, don't overstep your capabilities. So that is the only thing, because the first concern of us as a surgeon is the safety of the patient and the need for the appropriate surgery. So please watch these videos carefully, learn as much as you can from their talk and their videos, but don't think that you can do it overnight. It will take time, patience, experience, mishaps also, in order to make you a very good laparoscopic surgeon. So I hope those who are attended have got interest in this subject, and everybody will be benefited by attending this workshop. So thanks again to the Endometriosis and Adenomyosis Society for gathering this eminent person from all over the world to give their presentation today. So thanks again to our guests who have been participating and all the participants of this country or abroad who will be listening and watching their presentation. Thank you very much.
Thank you. Thank you very much, sir. Your advice, your opinion is always like advice, guide, and direction. Thank you, sir. And definitely you said rightly, the time will give us skill and improvement. Thank you, sir. So we are just at the end of this inaugural session of the workshop, and we'll be just finish this and go to the scientific session. I'd like to request Professor Dilip Bhaumik to give the vote of thanks as formally. Professor Dilip Kumar Bhaumik, please.
Thank you, Professor Jinnath. It's my great pleasure and honor to propose the vote of thanks on behalf of the organizing committee on this very memorable pre-conference workshop. My heart fills with lots of gratitude and respect for our distinguished chief guest, Dr. J.D., Chairman, Minimal Access Surgery FIGO, and Dr. S. Santa Kumari, President Foxy, for not only their sparing invaluable time for us to grace the occasion, but also for enlightening us with their commendable talk on the subject. It's my immense pleasure in expressing my humble thanks and gratitude to honorable chairpersons of this session, Professor T. Chodri Sir, National Advisor, Easb, and Professor Samina Chodri, Chairman, Organizing Committee and President, Easb, for leading and inspiring us in working to goal of success of this program. I would like to express my sincere thanks to Professor Ferdusi Begum, President OGSB, and all the past President and Secretary OGSB for their valuable support. I am running short of words to express my sincere thanks to our valued speakers from home and abroad of all the sessions of this conference. I do believe you will indeed put the best of our efforts to make this conference unforgettable one, and we are really highly obliged. No event can take this shape without hard-working leaders. It was the dedication and enthusiasm of torchbearer of this conference, Professor Samina Chodri, President ESB, and Professor Saleha Begum Chodri, Secretary General ESB, who made this dream a reality. We extend our heartfelt gratitude for them. Thank you so much. My sincere thanks to all the respected chairpersons and panelists and moderators of different sessions. It's my privilege to acknowledge the outstanding contribution of Scientific Committee under the guidance of Organizing Committee of ESB. This vote of thanks would be largely incomplete without expressing my gratitude to the participants. Lastly, but not the least, our sincere thanks to the scientific partner Renata Limited for their wonderful and outstanding support throughout the program. Thanks once again to all. Now, over to Dr. Ashim Kumar Shah, moderator of the next session. Thank you all.
Hello.
Yes, you are audible. Dr. Ashim, you are audible.
Thank you. Now we are going to the session number 1. Ladies and gentlemen, participants from home and abroad, good day to you all. I am Dr. Ashim Kumar Shah. Welcome you all to the pre-conference virtual workshop of first virtual international scientific conference of Endometriosis and Adenomyosis Society of Bangladesh. This is the session number 1. Our session is on the topic Basic Principles of Laparoscopic Surgery for Pelvic Endometriosis. Dear audience, in this session, we have eminent speaker, Professor Laila Arjuman Banu from Bangladesh. We are honored to have Professor Roshanara Begum, Vice President EASB, and Professor Ferdosi Begum, President OGSB and National Advisor EASB as chairperson. And we have two learned panelists, Professor Ruqayya Begum, Vice President EASB, and Professor Farhana Dewan, President-elect OGSB, with us. Here, in this session, the speaker will have 30 minutes time for her presentation. If you have any question, please give it to the chat box, which would be discussed later on at the end of the session, if the time permits. Now, it's my great pleasure to introduce honorable speaker, Professor Laila Arjuman Banu. Dr. Laila is one of the pioneer gynecological laparoscopic surgeons of Bangladesh. She is the Secretary General of Gynecological Endoscopic Society.
Recording in progress.
Can you see it? I think
No, madam. Naim mone hai help koruk, madam. Eta dekha jaচ্ছে.
হ্যাঁ আমার মনে হয় নাইম হেল্প করুক।
Naim share করেন।
আমি আগে তো শেয়ার স্ক্রিন দেওয়ার কথা ছিল।
এই তো কোয়াড তো ভেঙে ভেঙে আসতেছে।
ভেঙে আসতেছে, হ্যাঁ। আমিও সেটা বলছি।
আমি তাহলে
ছোট করো, ছোট করো।
টাইম বললো নেটের প্রবলেম, ভেঙে আসছে, নেটের প্রবলেম।
সেটাই
না, স্ক্রিনটা একটু ছোট করলে ভেঙে আসবে না।
ম্যাডাম আপনি শেয়ার করেন। হচ্ছে পারফেক্ট।
হ্যাঁ হচ্ছে। ওকে পাইবে, ঠিক আছে।
থ্যাংক ইউ সো মাচ। আচ্ছা, so respected chairpersons, chief guests from actually Dr. Shanta Kumari and JD, whom I have requested so many times to join this webinar. Thank you very much for joining, and all the faculties, speakers, moderators, and especially the participants and Renata. Good afternoon. And my topic is actually the basic principles of laparoscopic surgery in endometriosis. First of all, I should pay my gratitude to the organizing authority for inviting me to present my paper in this August gathering. Endometriosis and laparoscopy is interrelated because after the invention of laparoscopy, diagnosis of endometriosis became more accurate. And before that, that was only the syndromes or the pains and the symptoms and signs one can diagnose the endometriosis. 176 million women worldwide are suffering from endometriosis. Now, what is endometriosis? We all know the presence and growth of functioning endometrial glands and the stroma outside the uterus. And you can see the picture here. And the prevalence is 5% in reproductive age group, 15 to 90% chronic pelvic pain, 20 to 65% infertility, and 25 to 40% of the infertility patients have endometriosis. Here, the blue marks are all, these blue marks are the endometriosis. Now, this pie chart showing the endometriosis diagnosis correlation, where the peritoneal involvement is 43%, and the deep endometriosis 27%, and ovarian is 27%, and extrapelvic 3%. Symptoms of endometriosis mainly the painful menstrual cramps that get worse over time. Lower back pain, actually all types of pain are here. Abnormal bleeding or spotting between menstrual periods, pain during and after sexual intercourse, painful bowel movement or urination, and diarrhea, nausea, and blotting, whatnot. Now the diagnosis, how we diagnose the endometriosis, because diagnosis confirmed after laparoscopy. especially during the investigation of infertility. And incidence in infertile patient is 5 to 48%. In mild endometriosis, for surgical treatment, laparoscopy is preferable to laparotomy, already stated by JD. In moderate to severe endometriosis, restoration of normal pelvic architecture is the primary goal of laparoscopic surgery. So the three main goals of treatment of endometriosis is reduce pain, increase pregnancy rate, and to delay recurrence for as long as possible, which is very important, especially embarrassing for the patient and also for the surgeon. The only way to diagnose endometriosis is by laparoscopy or other types of surgery with lesion biopsy. The diagnosis is based on the characteristic appearance of the disease and should be corroborated by a biopsy. And surgery for diagnosis also allows for surgical treatment of endometriosis at the same time. The possible locations of endometriosis you can see here and here. Now, the main types of my topic is the basic principles of laparoscopy in endometriosis. The laparoscopic endometrioma, that is stripping, offers an effective option for ovarian endometriosis treatment, not only to puncture, but stripping or peeling off is the main aim. So reducing recurrence, reproducible by gynecological surgeons, especially after proper training, ultrasound mapping of the pelvic endometriosis, or you can do MRI, severe abdominal pain, laparoscopy for endometriosis is a low risk and minimally invasive procedure. So if pain persists even after hormone therapy, endometriosis interfering with the bladder or bowel function, or sometimes there is encroachment of the endometriotic tissue into the bowel or bladder. And if it causes infertility, ovarian endometrium, of course, and empty stomach, patient should be in empty stomach before operation for at least 8 hours. And most laparoscopies are outpatient procedures and patient released on the day of operation. So after operation, she should not take shower or bath at least for 48 hours. General anesthesia is better. Counseling to the patient is very, very important because about actually the procedure and the chance of conversion. Sometimes there is so much addition that sometimes we have to convert the operation from laparoscopy to laparotomy. And during the discharge, the patient should be given the advice that the treatment plan in future. When non-invasive methods are unable to help with the drug, and the surgery should be as complete as possible because the recurrence rate is quite high, about 20 to 30%. Now, before doing the surgery, the patient have some questions like this. How long will the operation last? Especially to her treating doctor. How long will I be in hospital? She should be in hospital. What will happen if there are complications? What symptoms will she have after the operation? Is the surgeon fully trained in laparoscopy? And what will she feel when she comes down from surgery? What sort of stitches will she have? And how should she look after herself after surgery? So many questions, and treating surgeon should give answer to these questions. Types of surgery, we know the removal of implants, lysis of adhesion, and excision of endometriosis. Now, treatment, we all know that the medication versus surgery. Surgery is associated with significant decrease in pain during the first 6 months following surgery. Approximately 40% experience recurrent symptoms within 1 year post-operative. So quite high, the recurrence rate. And cumulative 5-year recurrence rate of pain is done after DNRH treatment is about 50%. So again, the surgical management, there are some recapitulation of the subject because I have taken the message from different topics, like indications, pain, if there is failure of the medical management, infertility, of course, endometrioma, we know that the endometrium, if untreated, it damages ovary, and pelvic adhesion, moderate or severe disease distorting anatomy. Hysterosalpingography or hysteroscopy alone cannot replace laparoscopy in the evaluation of infertility before going for IUI or IVF, respectively. Now you can see the pelvic anatomy by laparoscopy. This is the laparoscope. This is the gas-filled area in abdomen, uterus, bladder, and here is the rectum, you can see. Now the laparoscopic diagnosis, laparoscopic is the neuro navigation, like central pelvic endometriosis, about 100%. Lateral pelvic endometriosis is about 75.6%, and deep lateral pelvic endometriosis is 27.7%. So before doing the surgery, especially for the endometriotic surgery, the surgeon must be capable of he or she should know the pelvic anatomy vividly, because it is the pelvic anatomy which he or she should know very good. Because internal iliac artery, we can see here, external iliac artery, this is internal iliac artery, round ligament, it is the point, the deep inguinal ring, ureter, and superficial inguinal ring. Now, laparoscopic treatment of minimal or mild endometriosis improves pregnancy rates regardless of the treatment modality. And the laparoscopic treatment like ablation or excision of implants and adhesions via mechanical electrosurgery or laser surgery. There are so many modalities of treatment. Now, surgical management, the conservative managements like excision, cauterization, and evaporation. Surgeries for pain, if the patient, adolescent girl is suffering only from pain, we can do the uterosacral nerve ablation if the medical treatment is failed, and presacral neoectomy. And radical surgeries like hysterectomy, with or without bilateral salpingo-oophorectomy, and surgeries for endometrioma, cystectomy, drainage and coagulation, and fenestration. And the surgery for treatment of endometriosis-associated pain. Surgical treatment has long been an important part of the management of endometriosis. And examination of endometriosis may be achieved by excision, diathermy, or ablation or evaporation. And division of adhesions aim to restore pelvic anatomy. Surprisingly, sometimes only restoring the pelvic anatomy relieves the patient's pain and also good for the future fertility. This is the pathophysiology in different organs. I am not going. And also this, there is a very busy slide. I am not going into details. Now, this is the real picture of it is the gallery picture. This is a real picture of the endometriosis. You can see the dense adhesion with the surrounding structures here and here. Sometimes it distorted the normal anatomy of the pelvis. So indications for surgical treatment of endometriosis, again, we can say that pain in the pelvis minor area, infertility in endometriosis, deep infiltrating endometriosis. I think my following speaker will tell about this deep infiltrating endometriosis briefly, and endometrial cyst of the ovaries. I will show the removal of the chocolate cyst in a young girl of 13 years age, but her weight was 110 kg. You can see the bilateral ovarian cyst, as her C125 was more than 500. So we opted for the frozen section biopsy, and we took a small piece of the tissue of the ovary, the whole thickness, and sent it to the histopathology department. And here we don't use the coagulation, electrocoagulation, because it might distort the anatomy or histology. Ultimately, the result was a benign tumor. So then we give the incision on the cyst. You can see a huge amount of chocolate colored fluid has came out, and we use the suction irrigation, and you can see the cyst and the ovarian tissue separately. So we should remove the cyst or stripping of the cyst, and it was done gradually. Sometimes it could not be done properly, but in this case, we could do it successfully. You can see the stripping is very important, because if you leave the endometriotic tissue, then again there will be chocolate cyst like this. And ultimately, we could do the stripping. Yes. So it is completed, and the extra ovarian tissue and the cyst wall was trimmed by the monopolar coagulation, and the specimen was removed through the lateral pores. The 5 millimeter port were made 10 millimeter, and then we removed it. This is on the left side. On the right side also, there the cyst wall was incision was given, and surprisingly, there was a small cyst inside the cyst. It's very interesting. And again, we gave incision, and then huge chocolate colored fluid came out. Then again, the same procedure is done. The cyst wall was separated from the ovarian tissue, and the extra tissue was cut and ligated, actually the coagulation done by the bipolar diathermy, and the excess tissue was removed. In these cases, actually the suction irrigation is very important, but you know, the endometriotic surgery is always a messy surgery. The tissue are removed. Actually, during this surgery, we should always think about the conservation of the ovarian tissue or ovarian reserve. Next, this is also the chocolate cyst, but it is smaller than the previous one, and it is a single cyst. But there is extensive adhesion with the bowel, you can see. So during the adhesive lysis, the cyst ruptures and chocolate colored fluid came out. So it was sucked out, and we again tried to peel out the ovarian tissue from the cyst wall, and we could do it. But in this case, we could not do it completely. There was some tissue with the ovary, and we cut it. And bipolar diathermy was used for coagulation. The extra tissue was trimmed off, and it was removed through the port. And the other ovary was normal. There was no cyst. This is the 5 millimeter port. It is converted into 10 millimeter. So to deal with the ovarian endometrioma, we should look at these following points, like symptoms, that is mainly the pain, patient's age, the ovarian reserve status, infertility, the pregnancy desire, the size, unilateral or bilateral, previous surgery status, and cancer risk. So how is endometriosis treated? While there is no definitive cure for endometriosis, excision surgery, where all lesions are removed, is recommended. The skill and knowledge of the surgeon is paramount in the ability to recognize and remove all lesions. Hormonal medication might help temporarily with symptom management, but it cannot be used to diagnose or cure, like cleanup or prevent progression of the endometriosis. So endometriosis can persist after hysterectomy or menopause, and it is a tragedy. So again, the pelvic anatomy, I have again showed it because the great vessels in the pelvis, we should know before doing surgery. The obturator nerve is here, the external iliac vessels, internal hypogastric artery with the divided distal end of the uterus like this, and the left ureter. It's a very good picture. I like it very much. Now it is also a gallery picture. The endometrial implant on the left ovary with the surrounding dense adhesions, you can see. So is there any real contraindications? Severe endometriosis or frozen pelvis, a distorted anatomy, uterine size, if it is more than 16 to 18 weeks, then safe access to the uterine vessels and extensive morcellation. Sometimes the uterus is so big that manipulation becomes difficult, and pelvic malignancy. But ultimately, whatever the size, we can do it laparoscopically. So this is another gallery picture, the extensive radiation with the surrounding pictures, and the anatomy is totally distorted here. So next, this is the last video. It is the lap hysterectomy for the endometriosis. You can see there are so many inflammatory cysts here. And the pouch of Douglas was completely obliterated. You can see during the separation, the left ovary was, there is chocolate color fluid from the left ovary. And you can see the adhesion on the posteriorly, which was actually separated very carefully. Even we used to leave some uterine tissue with the bowel. You can see. So it is, first it looks inoperable, but ultimately we could do the hysterectomy here. The posterior wall, we cut the posterior wall of the uterus slightly, and then as usual, the round ligament is ligated and coagulated, cut-in and coagulated. And I use always the harmonic scalpel. I like this instrument very much. And then the infundibulopelvic ligament also is cut and divided. You can see the endometriotic operation is always messy. This is on the left side. And on the right side, the same procedure is done. First the round ligament, and then the infundibulopelvic ligament was divided. And this is the retrovesical fold of peritoneum, which cut with the monopolar diathermy. And the bladder is pushed in front, and you can see we have done the anterior colpotomy, and you can see the uterine manipulator. It's very helpful for us during hysterectomy. And on the left side, almost we did the separation. You can see the space here already that is separated, and same thing done on the right side. And nowadays, I actually don't do the posterior dissection in case of hysterectomy. Only the anterior colpotomy and both sides after ligation, the uterus is separated and it can be removed through the colpotomy. Next, so thank you very much. And now we can say that the March is the Endometriosis Awareness Month. So we are looking forward to see all of you in the March, I think in presence, and we will share some new technology and new informations from you. So thank you very much. This is greetings from Bangladesh. You can see our next generations. They're very much delighted. Thank you very much for patience hearing.
Thank you, ma'am. Thanks a lot. It's a wonderful evidence-based presentation. You have perfectly described the basic principles during laparoscopic surgery for endometriosis. I believe the juniors will be immensely benefited from your lecture. Now, madam, now the question answer session. So some questions are coming from the audience, and definitely we have also some questions to you all. Madam, my first question to you: what steps will make the laparoscopic surgery for endometriosis more safe for the patient? Is it using the advanced electrosurgical devices like harmonic, Ansel, or Shearer, or the good pelvic anatomy knowledge of the surgeon? What's your opinion, ma'am?
Thank you very much for the question. Actually, whatever you said, everything is essential, because first of all, the knowledge about the pelvic anatomy, it should be there. And also not always I use the harmonic scalpel, but sometimes I have to use the harmonic or the device, the modern devices. But usually I use the monopolar and bipolar diathermy if the cysts are not so big. So, but we should be careful about the ovarian reserve. So we should not disturb the ovary as far as possible. We should remove the cyst only. And also below the ovary, there are the ureters. So also you should be cautious about not to harm or not to injure the ureter. I think so.
Thank you, madam. Madam, another question from the audience. One big issue in endometriotic surgery is the recurrence of endometrioma, for which most often the surgeons are blamed.
Yes.
What to do in such a situation? How to prevent recurrence of endometriosis? Although you have mentioned lots of things in your lecture, but still will you highlight on this?
Yeah, thank you very much. Actually, this is very true, because after doing the chocolate cyst, when I usually do the ultrasonography after 1 month of operation. So when they come with again the cyst, so they become embarrassed and they become depressed, and also me also. But we can't do anything for this because the recurrence rate is so high. But I use nowadays that after operation, I give them OCP sometimes the other hormones like the Diagnose the progesterone hormones, and also some they state that you can also use the progesterone copper-T like this. But for young, most of the patients are young and just after 6 years to 13 years, all my patients are like this. So we can't use the copper-T, but I usually give the progesterone hormones for them. After 3 months, again, I do the ultrasonography, and sometimes it becomes smaller, and so they are now happy. Further operation is not done.
Madam, if I want to add something, especially I think counseling should be done very accurately regarding the recurrence. Let them know first that every chance of recurrence is there. So that might prevent us in some medical legal problems. Madam,
yes, counseling is very important. Another thing is there, because still in our country, they are believed in the laparotomy, not in the laparoscopy. So they think that due to laparoscopy, there is a cyst recurrence, but it is not true, because the laparoscopy is much better than the laparotomy, because there is less lesion to the ovary and the surrounding structures.
Thank you, madam. Madam, another 2 questions are from the audience. So Dr. Afroja Kutubi was asking, is there, if we use the use of vasopressin to reduce the bleeding during the ovarian cystectomy in case of ovarian endometrioma, so do you think it is beneficial?
No, actually, I never use the vasopressin.
It's 16 hours.
Vasopressin in case whatever the size is this, it does not bleeds too much, and you.
Unmute yourself, please. Unmute yourself.
Sorry, because I never use the vasopressin in cystectomy operations, because of whatever the size is. Because if you have any bleeding, you can control it by the bipolar diathermy, or you can use the harmonic. Only I use the vasopressin in case of myomectomy operations, but not in the cystectomy operation.
Thank you, madam. Thank you. Now, I want to take some expert opinion from our panelist. My first question to Professor Ruqayya Begum, madam. Madam, here is a scenario. A 23 years nulliparous lady, para 0+1 abortion, having moderate dysmenorrhea, recently diagnosed as bilateral ovarian endometrioma, small size. She also wants to conceive. How to solve her issue? Should we go for medical management or should we go for surgical intervention? Madam, please.
Hello. Hello.
Yes, madam, you are audible.
You are audible.
এই প্রশ্নটা উত্তরটা যেটা হলো যে ট্রিটমেন্ট অফ এন্ডোমেট্রিওসিস depends on 6 factors. 6টা factor উপর depend করে। একটা হলো age of the patient, একটা হলো size and extent of disease, location of disease, severity of the disease, and desire for fertility. আর একটা হলো result of previous therapy, অন্য previous therapy পাইছে কিনা। তো এই পেশেন্টের বয়স 23 years, নালীপেরা 0+1, তার মানে she had a pregnant before. There is a potentiality of fertility is good, and moderate dysmenorrhea, and bilateral small endometrium, that is less than 3 centimeter, less than 3 centimeter or 3 centimeter in both ovary, and she wants to conceive. তো আমার মনে হয় যে এন্ডোমেট্রিওসিসের ট্রিটমেন্ট এই 6টা জিনিসের উপর ডিপেন্ড করে, এবং ট্রিটমেন্ট মোডালিটি অ্যাসপেক্টাল ম্যানেজমেন্ট, মেডিকেল ম্যানেজমেন্ট, সার্জিক্যাল ম্যানেজমেন্ট এন্ড কম্বাইন। তো এই পেশেন্টটাকে মেডিকেল ম্যানেজমেন্ট না দিয়ে অ্যাসপেক্টাল ম্যানেজমেন্ট ইজ এনাফ ফর ট্রিটমেন্ট। তো অ্যাসপেক্টাল ম্যানেজমেন্টের প্রোটোকলটা যেটা, সেটা হলো যে বিকজ শি ইজ ডিজায়ার ফর প্রেগনেন্সি, আর এন্ডোমেট্রিওসিস ইজ ডিজিজ হুইচ ইজ অলমোস্ট কিওর বাই প্রেগনেন্সি। তা আমার উদ্দেশ্য কি ওকে প্রেগনেন্ট বানানো। তো আমি প্রেগনেন্ট বানানো তো ইজি, কারণ ওর বয়স 23, ওরা একটা বাচ্চা হয়েছে, আর এন্ডোমেট্রিয়ামের সাইজও ছোট আছে। তাহলে আমি করব কি, ওকে এনকারেজ আর প্রেগনেন্সি। আর ওর একটা বাচ্চা যেহেতু হয়েছে, তার হাজবেন্ড ঠিক আছে, ওদিকে কোনো ঝামেলা নেই। তো ঝামেলাটা আমার কোন জায়গায়? ঝামেলাটা হলো আমার এন্ডোমেট্রিওসিস 2 ওভারিতে, আর এন্ডোমেট্রিওসিস ছোট আছে, অত বেশি বড় সড়ো কিছু নাই। তো এখন যেটা করতে হবে, টু এক্সক্লুড টিউবাল ফ্যাক্টরস অফ ফার্টিলিটি এক্সক্লুড করা লাগবে। তো টিউবাল ফ্যাক্টর এক্সক্লুড করার জন্য তো ল্যাপারোস্কোপি করা যায়, কিন্তু ল্যাপারোস্কোপি না করে ইট ইজ বেটার অ্যাভয়েড ল্যাপারোস্কোপি অ্যান্ড ডু দ্য স্যালাইন ইনফিউশন সোনোগ্রাফি, যে যেটা পারে। হিস্টোসালফিঙ্গোগ্রাফি ওর এই পেশেন্টকে করা যাবে। যদি দেখা যায় আলট্রাসোনোগ্রাফি করে যে ওভারি দুটা কিসিং ওভারি নাই, এই সাইজে কিসিং ওভারি হওয়ার কথা না, বা পাউচ অফ ডগলাস অবলিটারেট হওয়ার কথা না। এটা 2D আলট্রাসোনোগ্রাফি 3D 2D তেই ভালো দেখা যায়। দেখে নিয়ে দেন প্রসিড ফর, কেউ যদি সোনোসালফিঙ্গোগ্রাফি চেক করুক, আর হিস্টোসালফিঙ্গোগ্রাফি ও করতে। আই এম মোর কনভার্সন অন হিস্টোসালফিঙ্গোগ্রাফি because it is documentary and anybody see the tube is pattern. Then proceed to ovulation induction drug and time intercourse টা ওকে শিখাই দিতে হবে, এবং ওকে ovulation induction দিলে she may becomes a pregnant and আমার goal of treatment achieve হয়ে যাবে। এতটুকুই আমার বক্তব্য। থ্যাংক ইউ।
To your opinion, the medical management is the better option for her, and if not responding to other treatment, then we can think about of surgery.
May I comment something? Yeah.
Yes, madam.
So
yes, madam.
These patients like these, I usually do the C125. If it is normal, then I give her the medical management. That is the medical hormones like this, Diagnose or anything. Then it works better, and then she can go for the modalities Professor Roke has told for the fertility.
Yes, madam.
Sometimes, because sometimes the small ovarian cysts sometimes have the C125 high, and sometimes it comes as malignant. So you must, it should be documented that you must do the C125 first. If it is normal, then you can go for hormone therapy.
Madam, I want to add something. When we will go for surgical management in these particular cases, should we wait for 3 to 4 months or 6 months? Or if the surgery, that is, if the size of the endometrium is increases, then we will go for surgical management or anything else? Okay,
now, what I have already told that before surgical management, I counsel the patient and give some and advice for C125. If it, because 3.1 into 2.4, some patients, they are very much eager for surgery. So I have to do them counseling. Then I do the C125, it is normal. Then I counsel them, you take some medicine and wait for 3 months. And then after 3 months, you do the ultrasonography. And if it becomes less, decrease in size, then you can have the treatment for conception like this.
Madam, 3 centimeters.
But if the size may remain same, and if she has some pain, there is moderate dysmenorrhea. But if the pain becomes more, then we can do the surgery. because for endometriosis, surgery is the best treatment.
Madam, another thing I would want to share with you is the severity or the pain will dictate us to go for surgery or the size of the endometrioma.
Nah,
if you want to choose anyone.
Medical management, and if there is a pain is less than before, then you can wait.
Sometimes
it works with the medical management. But if there is no improvement of pain, then you must go for the surgery.
Sometimes the endometriomas are small, but they are deep. There is deep infiltrating endometriosis is there. Pain is there. Then I think even after small endometrioma, we can think about surgical intervention if the patient's pain is
because I got one patient, the small only 3 centimeter cyst was there, but she had terrible pain, and she actually did not agree with the medical management. So I had to do the surgery, and ultimately it came as papillomastoid cyst adenocarcinoma. So you can't
definitely we have to exclude the ovarian.
It cannot be a malignant one.
See,
so it should be documented, and documented treatment, evidence-based treatment.
Thank you, madam. Thank you, madam. We are now going to our next panelist.
Hello,
madam. We will come again after a few questions after the question with Professor Farnadhan, madam. Just wait, madam. My question to Professor Farnadhan, madam. Madam, after laparoscopic endometric surgery, sometimes we get foresight infection. How to prevent this type of infection? And is there any way to minimize the chance of scar endometriosis? Is there any way? Madam.
Thank you, Dr. Ashim. Respected chairs and dear audience, good afternoon to you all. Actually, I'm really honored to be present here as a panelist, and I would like to thank Professor Samina Chodri and Professor Sadar Begum Chodri for giving me this opportunity. And also, I would like to thank Professor Laila Adwan for an excellent, very practical presentation and also her answers. Well, foresight infection is a type of surgical site infection, but limited to laparoscopic surgery. And this infection is limited to superficial and also the deep surgical site also. And the presentation will be a seropurulent discharge from the foresight, and also there may be inflammation of the surrounding structures. And this is usually common from the umbilical port, but there also may be some other ports also, that is the port from which the specimen is taken out, etc. I'll come to that later on. So foresight infection are preventable if appropriate measures are taken preoperatively, during operation, and also after surgery. I will discuss in 4 points about this. The first point will be related to the instruments. And the second point, I'll talk about the avoiding the spillage. Third, I'll talk about the specimen. And lastly, I'll talk about the how to dealing with the specimen. So firstly, the instruments, the trocar, and the use of trocar, we can use the disposable trocars and also reusable. If reusable trocars are used, they must be properly sterilized. Number 2, use of autoclavable hand instruments may also be used. Thirdly, use of good instruments with good ergonomics. That means that if there are instruments which have joints, limited joints are good, and also when they are clean, they should be done very properly, and the debris should be cleaned very meticulously. Number 4, advanced technology of sterilization may be there, such as the use of instruments, that is ultrasonographic technology. It's not in our country, so we don't know, but it can be used, that is ultrasonographic technology, and autoclavable water for cleaning. That we all don't know very much because it's not available in our country. 5, proper guideline of the liquid sterilization liquid, that is the glutaraldehyde, which we commonly known as Sidex. That is how much concentration of the Sidex, what will be the contact time, and what cycle for use of the instrument, that should be mentioned very much spelled out clearly. And number 6, we can use the plasma sterilizer or ethylene oxide. It may be also used for the instrument. And one instrument should be avoided using in the interdepartmental sharing of instrument. That should be avoided. Regarding the avoidance of spilling of the content, it's very important that while the specimen is being removed, it should be very importantly, it should be mentioned here that infection depends on when the specimen is being retrieved, it should be used in a non-porous bag, and it will depend on the port through which the specimen is taken out. It should be the endobag can be used, and also to avoid spillage, so that, for example, if accidentally it comes out to be malignant, in that case also that can be prevented. I think those are the points which we should remember regarding the avoidance of the port site injury. Now, Dr. Ashim, coming to your second question, you have asked where scar endometriosis we can minimize. Actually, when we talk about scar endometriosis, we also always think about cesarean section, but scar endometriosis can also follow the endometriotic surgery in laparoscopy. And it is also in the confined to the superficial layer, but also it may occur in the deep layers as well. And these are, it follows among all the scar endometriosis, 14 to 26% are following the endometriotic surgery. Regarding the treatment, we all know about the treatment. We have to do a wide excision of the endometriotic tissue, but I'll not go into that, but I just mentioned 4 points regarding the prevention of scar endometriosis. Number 1, thorough isolation of the surgical site, incision. And number 2, abundant lavage of the pelvic cavity with saline before closing the wall. Number 3, we should repair. We know that many surgeons don't repair the peritoneum, but it's good to repair the peritoneum at the time of closure. And lastly, instrument, that is the needle replacement. When we do the closure, a new set of instruments should be used. And that will help in prevention of minimizing the scar endometriosis. I think that that's all from my side, and thank you so much.
Thanks a lot. You have described elaborately and very nicely. Madam?
One thing that because we
yes,
actually don't get the patients with the port site infection, because this is small incision and it is said that usually infection does not occur. But
Madam, in your center in Dhaka, it might not be, but in periphery and other things, there is port-site infection is much more, madam.
But number 1 is we should remember about the apical tuberculosis. It is very distressing, and I got 2 of my patients got the tuberculosis, and it is there was a big sinus, and it was very it took a long time to cure. So that is one, and the other comorbidities should be cured before the surgery. Thank you.
Thank you very much.
Our colleagues are also asking how to tackle the TB infection, atypical TB infection after the laparoscopic surgery.
It is actually if you do the autoclaving of the instrument properly, then it does not occur. But sometimes due to the hurriness, they don't autoclave the instrument properly, then we get the.
And I think also, I think Dr. Ashim, the in between surgery, 2 cases, if the instruments are reused, then they should be very properly processed. Otherwise, there is the risk. The risk will remain. Thank you.
Problem is that
actually
after
now
the
there is a sterilization material. You can re-sterilize the instrument in 10 minutes. We have this liquid. So sometimes it is a tablet one. Yeah. So you should have this type of sterilizer in your center.
Another thing that in most of the cases we are not using ethylene oxide or the proper sterilizer. Yes, madam.
আমি দুইটা পয়েন্ট অ্যাড করতে চাই।
Yes, madam. Please say.
একটা হলো পোর্ট সাইড টিবি, সেটা সবচেয়ে বেশি কমন হলো বিকজ অফ নন স্টেরিলাইজেশন, হারিনেস। একটা করার পর আরেকটা করে সার্জন অপারেশন করতেছে, ওই ইনস্ট্রুমেন্ট ঢুকাচ্ছে, ওটার জন্য হয় সবচেয়ে বেশি পোর্ট সাইড টিবি। আর পোর্ট সাইড এন্ডোমেট্রিওসিস এখন পর্যন্ত দেখি নাই, 30 বছরে দেখি নাই পোর্ট সাইড এন্ডোমেট্রিওসিস। Scar endometriosis more common in following cesarean section. আর পোর্ট সাইড এন্ডোমেট্রিওসিস দেখি নাই 30 বছরে। আরেকটা জিনিস যেটা স্কার পোর্ট সাইড এন্ডোমেট্রিওসিস, এটা ইনস্ট্রুমেন্টাল হ্যাজার্ড, যেখানে স্টেরিলাইজেশন হয় না সেজন্য হয় বেশি, হারিনেস অফ সার্জন। আচ্ছা, নেক্সট যেটা আমি বলতে যাচ্ছি, ম্যাডাম তো অনেক বড় না ম্যাডাম, তো ম্যাডাম আমরা দেখছি কি পেট্রিসিন যখন আমরা এখন আজকাল ইউজ করতেছি ফলোইং ডিউরিং এন্ডোমেট্রিওটিক সার্জারি, দেখা যাচ্ছে কি পেট্রিসিন দিলে কিন্তু ভালো স্ট্রিপিংটা ভালো করা যায়। দেখা যায় কি স্ট্রিপিংটা দুইটা লেয়ার সেপারেশন হয়ে যায় খুব তাড়াতাড়ি এবং স্ট্রিপিং বিকামস এন ইজি অ্যান্ড ব্লিডিংও কম হয়। ব্লিডিং কম হলে কর্ডারিটা কম করা, বাইপোলার কর্ডারিটা কম করা লাগে, তাতেই ওভারিয়ান রিজার্ভটা আমার মনে হয় একটু কম, লেস ড্যামেজ হয়। আরেকটা জিনিস সেটা হলো কি আগে এন্ডোমেট্রিওসিস অপারেশন করার পরে কটারি করতাম, কিন্তু এখন দেখতেছি কটারি না করে যদি স্টিচ দিয়ে দেওয়া যায়, সুচার দিয়ে দেওয়া যায়, তাহলে দেখা যায় কি ব্লিডিংটা একটু কম হয়। তা এতে কিন্তু ওভারিয়ান টিস্যু একটু কম ড্যামেজ হয়। ঠিক আছে, এটা আরেকটা পয়েন্ট ইউজ করতে চাই।
there are some side effects, সেজন্য আমি শুধু পিট্রিসিন খুব কম ইউজ করি। মায়োমেক্টমিতে ইউজ করতেই হয়, কিন্তু
হ্যাঁ মায়োমেক্টমি তো করায়। এখন আমাদের দেশে পিট্রিসিনটা পাওয়া যায়, এর জন্য ইউজ করি। আগে
না পাওয়া যায়, প্রথম থেকে পাওয়া যায়, very beginning it was available.
Madam, we are running short of time.
এক মিনিট আরেকটা যেটা যে অনেক এন্ডোমেট্রিওসিস স্পিলেজ না হওয়ার জন্য এন্ডোমেট্রিয়ামটাকে আগে পাঞ্চার করে দেন ইন্ট্রোডিউস দ্য সাকার দিয়ে সাক করে পুরাটা সাকশন এন্ডোমেট্রিয়াম টিস্যুটা ব্লাডটা নিয়ে তারপর দেন ওয়াশ উইথ নরমাল স্যালাইন, দেন প্রসিড ফর স্ট্রিপিং। তাতে সয়েলিংটা অ্যাবডোমিনাল ওয়াল স্পিলেজটা হয় না, ব্লাড ম্যাটেরিয়াল। এটা প্র্যাকটিস করে দেখছি, খুব ভালো
করি আমরা, ডার্মোয়েডে করি, কিন্তু
হ্যাঁ আরেকটা করতে হয় কি ওই যে
কোনো প্রবলেম হয়
এটা দেখছি কি পোর্ট সাইড যেটা আমরা 5 মিলিমিটার ইন্টারন্যাশনাল উইথ আস সরাসরি ঢুকাই দিই।
I think that
সরাসরি এন্ডোমেট্রিয়ামের মধ্যে ঢুকাই দিলে ওই ট্রকার দিয়ে সাকারটা ঢুকাই দিয়ে বা সাক করে নিয়ে আসা যায়।
Madam,
thank you.
Before going to the remarks from the chairperson, there's a small question from for the speaker: how to avoid the injury to the ureter? Some audience ask. Madam Lala, madam, would you or any other panelist to make?
If you do the hysterectomy, then always you should be with the uterus. Always, your direction will be towards the uterus. And for the beginners, you can sometimes do the stenting of the ureter, but I never did it. But you should always see that what are you doing, and this is and you should know the pelvic anatomy very good, and don't go to laterally, only to medially. You should stay with the uterus. This is the main trick.
Thank you, madam. Thank you, madam, and thanks everybody. Thanks to the panelists and the speakers for their active participation in the question answer session. Now, I would like to request our chairpersons. Professor Roshanara, madam. Madam is here.
Yes, madam with us. Madam with us.
Right,
madam, just unmute yourself and talk, please, madam.
Professor Roshanara, madam, would you please make any comment on this session?
Madam actually went to the village and back on the way. Madam, just unmute yourself. We allow your audio. Just unmute yourself and just give some remark. Madam.
Okay, if madam is not available now, then Professor Ferdowsi Begum, madam, our next chairperson. Professor Ferdowsi, madam.
Assalamu alaikum.
Yes, madam. Madam, please make comment.
Basically, খুবই মানে কি বলবো, খুব মনোযোগ দিয়ে শুনছিলাম এবং অনবদ্য প্রেজেন্টেশন, মানে লাজবাব বলা যায়, খুব সুন্দর স্ট্যান্ডার্ড, এবং ইট মেন্ট ইট, মানে যেখানে যেটা আমাদের পারপাস ছিল, টিপস এন্ড ট্রিক্স, খুঁটিনাটি বিষয়গুলো, টেকনিক্যালি হাইটেক যেগুলো জিনিসগুলো আছে সেগুলো, সুবিধা কেমন হবে, অসুবিধা, একদম মানে গল্প করার মতন, যে দিস ইজ এন সার্জারি এটসেট্রা, এবং এইভাবে করতে হবে, এইভাবে করতে হবে, পেশেন্ট টেনে হবে, মানে ইটস রিয়েলি ফ্যান্টাস্টিক প্রেজেন্টেশন। এন্ড লাইলা কত অনবদ্য বলেছেন, অন্য স্পিকার যারা পাঠানা যেগুলো বলেছে খুব সুন্দর, অসীমের পরিচালনা সুন্দর হচ্ছে। And we are proud of our guests, especially in the inaugural session, our senior teachers who were there. This is very encouraging, you know, and this has to be come up. Our youngsters should be knowing the surgery laparoscopic endometriotic surgery, which is the mainstay of treatment of endometriosis. So this session, I should say, a successful session. And we learned a lot and we'll continue to learn a lot. And I'm especially Sharmik ekta dhonnobad dicchi, tobe ekta chotto advice, you are becoming too tired. You have to take some rest. You are awake. So in between rest niye nite hobe. This is important. Day and night thik nai okhane. Anyway, Samina appa, Saleh appa, the whole team, I congratulate for the wonderful Pre-Congress workshop and especially for this session. And the organizers, যারা support করছেন সবাইকে ধন্যবাদ দিচ্ছি. Thank you.
Thank you, madam. Thank you for your kind words for us. The Roshanar madam is available? Not yet.
When madam will join, we will take remark from madam.
Then we have some more time. So we are 8 minutes time to left. So by this time, I think
বিদেশি বলতে বল না, বিদেশি একটা হেরাল্ড কি একটা কাঁচা থেকে বলতে বলেন, ম্যাডাম রাইট ওটা কিছু বলতে বলো, যে হেরাল্ড কি জানেন।
He is our second session speaker, madam.
Oh, acha.
And there are lots of international participants with us.
Oh, acha.
Just now a moment.
The JD is here.
আচ্ছা, আমি কি একটা কোয়েশ্চেন জিজ্ঞেস করতে পারি?
Madam, definitely, madam.
Hashim, can I ask you any question?
Yes, madam. Yes, madam. You are most welcome, madam.
To the speakers, they were thinking that they never saw a scar endometriosis following a laparoscopic surgery. Do you have any experience of because we have to pull out the cyst wall? Sometimes there can be spillage of the cyst wall. So is there any possibility that there can be recurrence in those scars? Because you have to bring if the cyst is very big, when you do the cystectomy, you have to bring out that cyst wall. When you try to bring it out intact, at that time, there is a possibility that there can be some implantation of these endometriotic cells, which can be viable. Do you have any experience on that?
No. For the last 25 years, I have done so many cystectomies, but I had your atypical tuberculosis in the port, but in no scar endometriosis.
But there are published documents that it can happen.
So we are better surgeon.
Madam, another questions came from the audience regarding the first questions. Madam, madam. Yes, madam. Yes, madam. Please. Please make it.
Yes, tuberculosis after scar is very common. I don't know how much common. I cannot give the incidence. But one lady came to me after cesarean section for the first time, and she has gone so many surgeons. And after that, she was admitted in BSMU. Then they find out that as a TB. So TB after cesarean section or laparoscopy everywhere is very common. So protect the woman from TB and take the test for TB is very important. I like to say this much only. Thank you for giving the chat.
এখানে আমি ম্যাডামের কথার পরে একটা ছোট্ট কমেন্ট করতে চাচ্ছি, সেটা হচ্ছে যে কয়েকদিন আগে few days back we had a national conference where me and Gulshan Appa were called in for extrapulmonary tuberculosis. এবং সেখানে we have seen the importance of laparoscopic tuberculosis. আমার মনে হয় আমরা যারা কাজ করি তারা এটা খুব খুব সমীহের চোখে দেখতে হয় আর কি জিনিসটা। এটা কমন ম্যাডাম, এটা নট ভেরি আনকমন and difficult.
ঠিক কমন বলা যাবে না, because only 2 cases I have been I diagnosed 2 cases.
Not very uncommon also. Not very uncommon.
টিবিটা খুব কমন হয়ে যাচ্ছে এখন।
The problem is that if the patient party medically claims that I am responsible, the surgeon is responsible for this type of Foresight atypical mycobacterium, then how to tackle them? opinion from the expert.
Give the evidences. You should give the evidences. Actually, daughter of a doctor, she has been undergone cystectomy under I have done surgery, and she had this portal tuberculosis. And still she's blaming me. Madam, your center, I got this tuberculosis. So blaming is something else. We continue. But so many cases I have done, only 2 cases I got the tuberculosis. I don't know the other center.
Comment here, Dr. Ashim.
Yes, madam. Yes, madam. Yes, madam.
Actually, I want to say that tuberculosis is so common that it should be kept in mind when there is infection. It should be tried to prevent, and of course, when it occurs, it should be kept in mind. It is common in our country. That's what I want to say.
Ashim, we have to, Dr. Ashim, আমি একটু বলি, আমি last 3 months এ 3টা পেলাম। একটা হলো আপা ovarian cyst, laparotomy করে বড় করা হয়েছে, তারপর incision শুকায় না, তখন দেখা গেল এটা আবার আমি সার্জনকে নিয়ে করেছিলাম, ওনারা তো টিস্যু করে পাঠিয়ে দেন, তো সঙ্গে সঙ্গে টিবি ধরা পড়লো। আপা 3টা কেস last 3 months এ পেলাম, incision এর টিবি।
আমি ল্যাপারোস্কোপিতে পাইনি, সেটা বলছি। ল্যাপারোস্কোপিতে আমি খুব কম পেয়েছি, বললাম না 2টো কেস পেয়েছি। তবে টিবি তো আমাদের দেশে কমন, ইন্ডিয়াতে আরো কমন, ইন্ডিয়াতে কিন্তু আরো বেশি কমন, ওদের টিবি বেশি কমন।
অসীম, আমি একটা কথা বলতে পারি? অসীম,
যে কোনো ইনফেকশন হলে, রিপিটেড ইনফেকশন হলে টিবি টেস্টটা করা উচিত।
অসীম, আমার কিছু ম্যাডাম, আসসালামু আলাইকুম। লায়লা ম্যাডাম, আপনার প্রেজেন্টেশন অনেক সুন্দর হয়েছে ম্যাডাম, অনেক এক্সিলেন্ট প্রেজেন্টেশন। আরো কম করে বলবো, আমার মানে বিটার এক্সপেরিয়েন্স আছে ম্যাডাম, 5 থেকে 6টা কেস, কিন্তু দেখা গেছে যেগুলো আসলে খুব মানে বিজি সেন্টার, তারা হচ্ছে ল্যাপারোস্কোপির একটা 2টা সেট থাকে, ওইগুলোকে আসলে স্পোর কিল করতে যে সময়টা ইমার্জ করে রাখতে হয় সাইডেক্সে, সেই সময় ইমার্জ করে রাখে না, যার জন্য একটা হচ্ছে বেশি। আরেকটা আছে যে আনডায়াগনোসড টিউবারকুলোসিস এরকম করে হয়, পেশেন্টের খুবই ভোগান্তি হয়, বড় বড় একদম পাস্টিউলস হচ্ছে পেটে থাকে। এবং আমার একটা রোগী আছে 2 বছর ধরে ওই রকম ওঠে আর অ্যান্টিবায়োটিক খায়, ওই রকম ওঠে আর অ্যান্টিবায়োটিক খায়। তো এই জন্যই ম্যাডাম আসলে আছে, কিন্তু মানে এ ব্যাপারে আমাদেরকে আসলে সতর্ক থাকা প্রয়োজন, যারা ল্যাপারোস্কোপিক সার্জারি করি তাদেরকে।
খুব ভালো করে স্টেরিলাইজেশনটা খুব ভালো করে।
থ্যাংক ইউ ম্যাডাম।
আমার একটা টেকনিশিয়ানের কাছে আমার 2টা কেস হলো যখন, তখন আমি টেকনিশিয়ানকে বাদ দিলাম, আল্লাহর রহমতে তারপর থেকে আমি আর পাইনি। তো কাজে তোমার স্টেরিলাইজেশনে যদি তোমার ঝামেলা থাকে সেটা দেখো।
আমি একটু বলি, আমরা তো ওটিতে নেওয়ার আগে অবশ্যই সব ইনভেস্টিগেশন করি, সেখানে টিবি সন্দেহ হলে সেটা এক্সক্লুড করি, কিন্তু তারপরেও আমি আমার পার্সোনাল এক্সপিরিয়েন্স বলি যে আমি বাংলাদেশ স্পেশালাইজডে যাওয়ার আগে আমার নিজের পেশেন্টেরই 4 টিবি হয়েছে। ইট ইজ ভেরি ডিফিকাল্ট টু ডায়াগনোজ আফটার সার্জারি, ইট টেকস টাইম। প্রথমে কিন্তু সন্দেহ হয় না, পরে বায়োপসি করে বের হয়, কিন্তু বাংলাদেশ স্পেশালাইজডে আজকে 2-3 বছর ধরে একটা কেসও হয় নাই। কাজে লাইলা আপা যেটা বললেন, ইট ইজ ভেরি ভেরি ইম্পর্টেন্ট স্টেরিলাইজেশন ইনস্ট্রুমেন্ট।
Thank you madam, thank you all the panelists and all the seniors for participating in the
we need to end the session 1 because our session 2 speaker is waiting.
For a long time.
Madam, we are near the end of the
session,
session.
please.
My thanks to the speaker for her excellent deliberation, and also to the panelists, the chairpersons, and all the dignitaries. For you, this session has become more successful and colorful. Now over to the next session. I am hand over the mic to Dr. Samina Abbasi, Scientific Secretary, Easb, for moderation of the next session. Dr. Samina Abbasi.
Thank you, Dr. Ashim Kumar Saha, for the excellent session, and special thanks to Professor Laila Juman Banu, Madam, for your excellent presentation, Madam. Thank you very much. Respected Chief Guest, Chairperson, panelists, and world-renowned speaker, and valuable participant from home and abroad, good evening from Bangladesh. I am Dr. Sharmin Abbasi, Scientific Secretary, EASB. It's my great privilege to welcome you all in one of the important sessions of this Scientific Fest of EASB. Our session on very challenging and very important topic, that is the fertility sparing endoscopic surgery in pelvic endometriosis. Dear audience, in this session, we have world-renowned speaker, Professor Dr. Harald Krentel from Germany. We are honored to have legendary, renowned fertility specialist of our nation, Professor Parveen Fatima, the Honorable Vice President, EASB, and Professor Rashida Begum, Deputy Secretary General, EASB. We also have two expert panelists with us, Professor Maliha Rashid, Joint Secretary, EASB, and Major General Richard, Professor Lisa Chodri, the member of EASB. I would like to state that the honorable speaker will get 30 minutes for the presentation. If anyone have any question, just put it in the chat box, we will take the question. And I'm very much honored to introduce our today's world-renowned speaker, Professor Harald Krentel. Professor H.K. is the Director of Clinic for Gynecology Obstetrics, Gynecological Academic Teaching Hospital, University, Germany. Interim President of European Endometriosis League, Member of Advisory Board, SEF, Member of ESG, Special Interest Group Endometriosis, President to DSGGG, German-Spanish Society of Obstetrics and Gynecology, Mentoring Program, World Endometriosis Society, co-founder of the Endometriosis Masterclass Program, invited speaker and live surgeon at national and international congresses. Please welcome Professor H.K. And Professor H.K. will talk on fertility sparing endoscopic surgery in pelvic endometriosis. Please welcome, Professor.
Yeah, good evening to Bangladesh. Here it's just noon, a sunny day, and thank you so much for the kind invitation and your kind words. I am very honored to be with you today, and it's my pleasure to talk about endometriosis surgery and especially about the aspect of fertility in these patients. I think it's a wonderful opportunity today to merge our ideas of treatment of endometriosis from European side and Bangladesh, Asian side, and I'm very, very happy that we can be together this evening. So I will share my screen and start my presentation. Most of the patients that we see with endometriosis for endoscopic surgery are patients with both subfertility or infertility problems and pain. In some cases, the fertility or subfertility is the only problem and the patient have no pain, but and in other patients, it's just about pain, but in many patients, it's the combination of both. So what we need to do is not just go for fertility sparing treatment, but also for pain management and endometriosis resection. And I would like to show you our approach to those patients. And I will go through the steps that I think are important. And as you can see here, I would like to start with a classification of endometriosis, the one that we are using currently. It's the new hashtag Enzian Classification, which is a complete classification system of endometriosis. And I would like to explain why I think it's important to classify endometriosis in patients. Then I would like to talk about the role of hysteroscopy, which I think is very important, especially when we talk about fertility sparing surgery. Then, of course, a big point is ovarian tissue preservation in these patients. And then we will see what is important in laparoscopic surgery for peritoneal or deep endometriosis. And just at the end, I will just mention a few words about adenomyosis, as it is a very important factor in those patients with subfertility. And I know that Professor Zuppi from Italy will talk about adenomyosis, so I will not talk a lot about it, but I will just mention some aspects. So first, I think we need to talk about the classification, and I will explain you why. When we see our patients, we need a very clear idea about the extent of the disease. So what we first need is really to confirm diagnosis and the stage of the disease. That's what we also do in oncologic surgery. So when we treat cancer by surgery, we will not enter to do the surgery without having an idea and a plan for the surgery. So for example, in endometrial or cervical cancer, we have a clear idea about the extent of the disease. And then we take a decision how we do the surgery, if we do surgery or not. And of course, in endometriosis, it should be the same. It shouldn't be like, okay, there's a patient, maybe there's endometriosis, let's see. No, we have to have a clear idea, a clear vision of what extent of disease we will find in this patient, and then we can have a clear protocol for the surgery, for the pre-surgical and post-surgical treatment, especially in patients with the desire to become pregnant afterwards. And that also includes the specialist for reproduction. So what we do is we use the new hashtag Enzian Classification, which has been published this year in February. And it looks at first sight a bit complicated, but it's really recommendable because this is a possibility to classify the extent of the disease. And it includes the peritoneal endometriosis, the ovarian endometriosis, and the endometriosis and the adhesions of the fallopian tubes. So this part gives you a clear idea about the peritoneal and adhesion extent of the disease. And then in this part, you have the deep endometriosis. And you can classify deep endometriosis of the rectovaginal space, of the vagina, of the uterosacral ligaments, of the pelvic side walls, of the rectum, the ureter, the uterus, or for example, nerve infiltration or entrapment. And now what is important is that this is not just a surgical classification. You can start to classify your endometriosis patients before surgery. You can classify by transvaginal ultrasound or abdominal ultrasound, and you can also classify by MRI. And of course, there are some patients that need ultrasound and MRI in the pre-surgical situation, and maybe they also need an assessment by a reproductive specialist. So then you have a clear idea and you can start to do your surgery. And of course, then you can have also the same classification by surgery, and maybe you can add something. But when you are very good in pre-surgical classification and diagnostics, then your pre-surgical and post-surgical hashtag Enzian classification, of course, will be more or less the same. And that means that then you are really good in pre-surgical diagnostics. And that's the idea. So the parameters for decision-making in our patients with endometriosis are, of course, symptoms. That means that we need to listen to our patients and listen to their complaints and symptoms. Then we can have a more or less clear idea where we can find endometriosis lesions. Then, of course, age plays an important role. The family planning, of course, the question if there is additional deep endo, if there is adenomyosis, if there are previous surgeries, and maybe some assisted reproductive techniques in the history of the patient. So all this is important. For example, the fact of previous surgeries is very important because, of course, there are many patients that we see with 2, 3, 4 laparoscopies in their history, and this might cause a damage of ovarian tissue. So these patients might already have a very poor AMH level or a poor antral follicle count because the ovaries may be destructed by surgical procedures in the past. So this is also important when you start to talk about fertility sparing surgery. So the first thing that we need is a clear diagnosis by step-by-step approach with anamnesis and symptoms, gynecological examination. The palpation is very, very important because some lesions are invisible to ultrasound and MRI, and we just have our fingers to detect them by palpation. Then you have your 2D transvaginal ultrasound, some also 3D transvaginal ultrasound, and we can use MRI, hysteroscopy, and laparoscopy also as diagnostic tools. And then we have a good idea. And I give you an example. This is a patient with pain with a prior surgery 1 year ago and with infertility. So her wish is to become pregnant and to get rid of the pain. And this is the start of the examination. And what you see here is a vaginal deep endometriosis. And that means for sure that this will not be the only finding. And you can classify just with a clinical gynecological examination that here is a deep endometriosis, which includes the rectovaginal septum and which most probably will also affect the rectum, the uterus, and maybe more locations.
Please unmute. Please unmute. Please unmute, sir.
Then here you have ultrasound, and the ultrasound is the next tool, and you can clearly see the rectovaginal nodule. It's really simple to see the rectovaginal nodule. You can see here the rectum attached to the uterus at the end of the vagina, and this is the nodule, and you have your clear idea. That means that when you start surgery, you already know that you will have bowel involvement. Here's another case, a very young patient with this finding just in the bowel. And now this is the laparoscopic view. So this is the deep endometriosis nodule. And when you see this by laparoscopy, you might even miss this finding, but it's a large rectal nodule of about 2.5 centimeters. And that means that in this patient, also for fertility reasons, but also for pain management, we do a rectal resection in this case. But you see that the finding is almost invisible by laparoscopy, but it's clearly visible by transvaginal ultrasound. So in the pre-surgical setup, we already have the idea of the extent of the disease, and we have only one surgery with a complete resection of endometriosis, which is the best option for the pain management of the patient, but also for future fertility aspects. This is another example. It's the same finding, a deep endometriosis nodule, and you will see more examples and surgical approaches by Arlene Constantine later today. But I just want to give you examples in order to show you that the pre-surgical setup is very important. Here's the uterus. This is the rectovaginal nodule. Here's the rectum. The rectum is attached to the uterus. And without any laparoscopy, we know that this will be a difficult case. The same for the bladder. You can do kidney ultrasound. You see obstruction of the ureter. You can do ultrasound of the ureter. You can see if it's affected or not. Of course, you can see this nodule in ultrasound of the bladder. So there are many, many possibilities to have a clear vision of the extent of the disease. This, for example, is a transvaginal ultrasound of the bladder. You can see the ureter here, and with a distance of 5 millimeters, you see the beginning of a deep endometriosis nodule just here in the trigonum of the bladder. This is another case. Here you can see the bladder nodule. It's a large nodule in the bladder. The patient presents typical symptoms like dysuria, like hematuria. Then here you have the uterus with adenomyosis. And in the posterior part, behind the uterus, you have a rectal infiltration. So this means when we want to do surgery on that patient, we have to focus on the rectum, on the bladder. And if she wishes to perceive in the future, then we might have to think about adenomyosis too. But I will mention this later. And of course, the ovaries also play an important role. And if you see something like that, you know that it might be helpful to have an idea of AMH levels, maybe talk with reproductive specialists before doing surgery and have a clear idea for the patient. And of course, we use the IOTA criteria in order to distinguish endometriomas from other ovarian lesions. You can use MRI too. In our department, we use more ultrasound than MRI, but in some occasions, we also use MRI as an additional diagnostic tool. MRI is more expensive, of course, but there are some centers, like for example, the center of Professor Roman in Bordeaux in France. He's using MRI and he is happy with that. So in my opinion, it's not important if you do MRI or ultrasound or a combination of both. It is important that you have a setup that allows you to have a good pre-surgical diagnosis. And that is the most important factor to understand the extent of the disease. And in many patients, I do this small drawing. So this is what I explain to the patient. I explain, this is your nodule, rectovaginal. This is a nodule. We will resect this tissue and it looks like this at the end. And then you can classify it and everybody understands this formula of endometriosis. This means that there is a large nodule of the rectovaginal septum of both uterosacral ligaments and of the rectum, and it's done by ultrasound. So in this patient, I have a clear treatment strategy. I know the surgical approach. I can set up my OR and all the instruments that I need. I can ask the visceral surgeons if they have time that day because I need to do a rectal resection, and maybe urologists. We can have a much better informed consent with the patient. And we can go for only one surgery and not a combination of more than one surgery, 2 or 3, which is a problem for the ovarian tissue. So let's see about the hysteroscopy. Hysteroscopy is something that we always do in all patients that we do surgery on endometriosis. Why? Because it is important to see whether the uterus from inside looks good or not. I mean, you cannot do a laparoscopy for endometriosis and then there is a septum or something and you don't know it. So if a patient comes with endometriosis and subfertility, just have a look to the uterus and then you can say, okay, everything looks perfect inside. This is a very young patient. You see a wonderful endometrium. Everything is healthy. It costs you 5 minutes and you can tell her your uterus is beautiful, everything perfect, you will have no problem with perception. If there is adenomyosis, the hysteroscopy might also help in determine these lesions, and Professor Suppi will talk about that later. But of course, hysteroscopy also plays an important role in the management of these lesions, and it might also play a role in obtaining biopsies in patients with a suspicion of adenomyosis or other findings in the uterus. So I think hysteroscopy plays an important role, and in our setup, it's always included. In most cases, we do hysteroscopies, and here you can see a patient with adenomyosis and a small mini hysteroresectoscopy, bipolar, and we just take some biopsies in order to have an idea about the uterine tissue. And it might also play a role if you have patients with larger cystic lesions of endometriosis or adenomyosis. And as you can see, we need to include our hysteroscopy to the management of our patients in endometriosis, especially in fertility-sparing surgeries. Then the ovarian tissue. How can we save the ovarian tissue? Do we always have to resect endometriomas, or can we just let them where they are? You know that when an endometrioma is not big, maybe 2 centimeters, the repro specialists will tell you that it's not necessary to resect it. But if it's the first surgery, it might be a good idea to resect it. But if it's the 3rd or 4th surgery and there have already been done surgeries on ovarian tissue, it might not be a good idea to resect a small endometrioma, because this might cause even more harm to the ovarian tissue than let the endometrioma where it is. And in assisted reproductive techniques, we know that the presence of an endometrioma, of course, is not the best idea for an ovary, but the resection might cause even more harm. So this is just a slide to show you that we need to think about the reproductive aspects as surgeons too. And I believe that a person who is doing endometriosis surgery also needs to have an idea about the possibilities in reproductive techniques in order to counsel the patient appropriately. So what we need to do is be careful with the ovaries and have a control management, especially in young patients, and preserve fertility. What we sometimes see are young patients with a resection of, for example, 1 ovary for endometriosis, and this is not necessary, and it shouldn't be like that. So this is a recent review, and the careful ovarian cyst excision with goal of ovarian tissue preservation is the most important factor, and this can be done by trained surgeons. And there are some tools that are helpful. For example, here you can see the movement of the uterine manipulator. This manipulator makes it easy for you to reach the posterior part of the female pelvis. And as you can see, we attach the ovary by just a simple suture to the pelvic side wall. And this means that during the surgery, the ovary is just safe. We do not need to touch it. It's just there. And at the end of the surgery, I just need to cut the suture and everything is okay. So I don't need to grasp it. I don't need to touch it, and it's safe during the procedure. Now some examples. Here you can see the beginning of the surgery. You see the uterus, the bowel. Now let's see if the bowel is attached. Here you can find already endometriosis. Now we do the Trendelenburg position. You can see a large ovarian lesion here. There's a small fibroid. And then in this part of the surgery, you can see that it was a very severe deep endometriosis of the posterior part. You can see the nerves. We did a nerve sparing surgery. You see the ureter, and you see that we did a complete mobilization of the rectum. And during this procedure, the ovaries are just sutured to the pelvic side wall in order to save them and in order to have a clear and simple access to the posterior part. In these cases, of course, it's more difficult. You can see that it's impossible to not touch the ovary, and you need to liberate it first and then try to continue. But also in this surgery, where we have to detach the rectum from the uterus, the ovaries are sutured to the pelvic side wall in order to save them during the rest of the surgery. And this is the end of this surgery. You can see that the posterior part now after rectal resection looks good. And yeah, this is what you can do in these patients. So there's a complete resection of endometriosis. The ovaries are more or less safe. Of course, they do not look quite good because this was not the first surgery in this patient. And the uterus might be a uterus with adenomyosis. And of course, this is also a negative factor in these patients. So let's see laparoscopic approaches. Just some more slides before I will finish. This is another example. There is almost any peritoneal disease. Yeah, it's difficult to see. It looks like a small, not very severe endometriosis, but then you can see that it's a deep endometriosis nodule, a very large nodule, and we did a complex resection of rectum and nerve sparing surgery on the right pelvic side wall. And we are also using the manipulator, and you can see that the access to the nodule is much easier with the manipulator. This is a case on the left side. It's a patient with a severe pain, with infertility, and this is just the laparoscopic finding. But as I told you in the beginning, these findings you can see by ultrasound because this is a 4 centimeter large deep endometriosis nodule involving the rectum, the vagina, and the pelvic side wall, including the ureter and the pelvic nerves. And this is what you find when you open the peritoneum. So there's a very, very large deep endonodule. This is the vagina. Here's the nodule. This is the rectum. And at the end, it's a complex surgery with peritoneal lesion, with rectum lesion, and also pelvic nerves involved. Another example, a fertility patient. The pelvis looks quite normal, but when there's just a very, very small peritoneal disease, the fallopian tubes are patent in both sides, but there's a large nodule in the retrovaginal area. And maybe this is a disease that not affects fertility for pelvic inflammation. But in this patient, the pain is important because she cannot have any relations for pain. And so here we do the resection of this complex retro peritoneal nodule with resection of vaginal tissue and also resection of rectum. And then afterwards, now the vagina is open, the patient is pain-free, she can have relations, and pregnancy is not going to be a problem any longer. This is another example, fertility sparing surgery. more or less the same situation, a complex case. And here, for example, we have a suture of the vagina. So when you open the vagina, of course, this means that the patient has to wait for a while before she can become pregnant. And then we do the rectal resection. And in these patients, of course, we have to discuss post-surgical treatment, for example, hormonal treatment with gestagenes, or also with the GnRH treatment for up to 3 months before she can go to reproductive treatments or become pregnant naturally. And just remember this image, because it starts like this and it might be complex like you have seen now. And this is the patient. I mean, this patient you can see now from inside. It's the second surgery. You see adhesions here. You also see that the bowel is attached. It's a complex case, and of course, it's a disaster when you have patients like that. But here you can see that we do the resection of the vaginal nodule by laparoscopic surgery. You have to be careful because, especially in patients with fertility desire, you have to be aware that when you resect too much, you will not be able to close the vagina again. And it has to be closed, and it also has to be attached to the uterus. And it's important for the delivery and the pregnancy, and of course for relations too in these patients. So this is the final image regarding the pelvis of this patient. And then we did a rectal resection, and the patient was pain related much better after the surgery. And I don't know exactly if she is now pregnant or not. Here you see the rectal resection. It's a very deep anastomosis. It's 5 centimeters, very deep. We do this without a stoma, in collaboration with our surgeons. And of course, there's a certain risk because you have the vaginal suture and the rectal suture, but we have very good results, and usually patients are happy and we do not have problems. And as you can see here, again, the ovaries are attached because otherwise it will not be possible to do this type of surgery. So then at the end, there is a control by with the rectoscope, and then the surgery is done and everything is fine. So it starts just with the finding, and then you have a complex surgery. Okay, I will skip this, and now just a few words about adenomyosis. I just want to say we have to consider adenomyosis in our patients with endometriosis. If you treat your patients, the patients with additional adenomyosis are a subgroup, and they might not have such a good result, because when you do resection of endometriosis and deep endometriosis and they keep on having their adenomyosis, they will have pain after the surgery again. So you need to think about adenomyosis and consider it and not forget about it. You can distinguish it from fibroids by Doppler, as you can see here. And we just not think about the uterus, but the uterus is the most important organ, and it's central. And if there is pain, it might be the uterus. And this is a 17-year-old girl, and this is the normal uterus, and this is adenomyosis. So this is also fertility sparing, because we just give her the chance to live pain-free. And of course, then later on, she will be able to become pregnant. And I will finish now because the rest of my slides is about adenomyosis, but Professor Zuppi will show you. So which is the take-home message? We need a patient-centered, personalized approach, avoid unnecessary surgery on ovaries, initial surgery should be complete. We should avoid repeated surgeries in our patients. We need to save the ovaries during surgeries by less energy use, by ovariopexy, for example. We should start with a pre-surgical assessment, as I explained to you. I would like to suggest to use the hashtag Enzian Classification, which is really nice. And then we all speak the same language wherever we are. And we need a close collaboration with specialists in reproductive medicine. This is different in every country, but for example, in Germany, in our department, we do not have a specialist in reproduction, but we have specialists around. So we have collaborations and we work together. And of course, surgery should be done in specialized hands, and please consider adenomyosis. If you like training and teaching in endometriosis, and hopefully in the next year we have the chance to travel even more than this year, then you are invited to join one of the European endometriosis masterclasses, which we organize all over Europe. And of course, it would be our pleasure to welcome you to our Congress next year in June in Bordeaux in France. Thank you very much for your attention.
Thank you. Thank you, Professor Harold Prantl, for your excellent and brilliant presentation, sir. It's really a crystal clear presentation, and you perfectly judge on your topic that the fertility preservation in case of when we are dealing with cases of pelvic endometriosis, because it's really a great challenge for the fertility specialists who are doing the surgery about the future fertility of the patient. Thank you very much. And we have many questions in our hand, and many questions from our mid-level doctors to you, Professor HK. I'm just going with that important question. First of all, one of the trainee doctor asked about regarding the pelvic endometriosis, there are sometimes the dense adhesion. That means alternation of the tube-ovarian relationship. So when we will do that type of the surgery, well, what is your suggestion regarding the surgical technique and also the instrument that we will use for this kind of surgery without damaging the fallopian tube? So what is your opinion, sir?
Yeah, thank you for your words and the good question. Yeah, it's really a difficult question. I mean, when you treat the fallopian tubes and the ovaries and you try to detach them from these adhesions, of course, it can be very challenging. And as we all know, sometimes the ovaries and the tubes are attached by deep endometriosis nodules to the pelvic sidewall. And a normal dissection, as we do it in healthy tissue, is not possible. So you need to take a scissor, or you need to take energy to detach the tissue and to open the tissue. And I would like to say that it is helpful when you start always in the healthy tissue. So what I recommend is that you open your peritoneum in the healthy part, and you try to show your ureter. Then you know where's the ureter, and then you can start to detach the ovary and the fallopian tubes. And I like to use scissors whenever it's possible, because I try to avoid energy. I mean, of course, you can use ultrasound scalpel on everything in endometriosis, but don't forget that the ultrasound scalpel causes a lot of thermal damage, and this might harm the tissue. So scissors are a good tool. Of course, you need to avoid bleeding. And I also like to use the monopolar needle, which is a very, very thin instrument, and you can use it for exact and very detailed preparation. And of course, yeah, sometimes it might be better to say, okay, I will not touch this because what you should avoid is to destroy it. And especially when you have a rectal and a deep endometriosis infiltration, we all know these cases. Please do not start with the ovaries, you know? I mean, the ovaries are attached to the rectum, to the pelvic sidewall. You think, this is too difficult, but I will resect the endometrioma. Then you open the ovary, it starts to bleed, and then you might lose control. So first, you need to try to detach it from all the adhesions. And when you finish that, then you can start to really treat tissue by tissue.
Thank you, Professor. I will take another important question for you. You said that, sir, you were doing the regular hysteroscopic surgery in case of the management of the surgical management of the pelvic endometriosis. So my question to you, sir, what are the common findings you usually get from this type of the patient when you do the routine hysteroscopic surgery?
In most of the patients in hysteroscopy, we do not find anything. In most of the patients, the uterus is perfect. And this is good information for the patient because they want to become pregnant, you know? And it's good when you can say, you know what, yes, you have severe endo, but we resect it and your uterus looks wonderful from inside and your fallopian tubes are permeable. So then you have a clear idea, a good message for your patient, and you can say, okay, you might become pregnant naturally, but you also can go to the assisted reproductive techniques, and then they have two ways. And for me, it's important to have all the information. It's like a complete checkup, you know?
Complete checkup, yes. Thank you, Professor HK. And another very important question regarding, you just mentioned that the natural chances of the pregnancy. So many of our participants ask that after the surgery, how much the chances of natural pregnancy and how long we wait for the natural pregnancy after the surgery. And one additional question with it, that is there any need of any suppressive treatment after the surgery, like GnRH analog, elagolix, this sort of the drugs, any need, do you think?
Yeah, good question. Yes, that's very important. I mean, I cannot give you numbers, but what we see is that the surgery has a good impact on fertility, and the literature shows that also. And it depends on the surgery and the extent of the disease. For example, if it's just a peritoneal disease, it's a quick surgery, of course, there is no need for any special time in waiting before becoming pregnant. But for example, when you do resection of vaginal tissue, you have a suture of the vagina, then of course it's recommendable that the patient waits for a while, for example, for 3 months of wound healing before she's going to be pregnant. And in that time, it is recommendable to have a hormonal treatment by oral contraceptives or by gestagenes or GnRH or elagolix, which is still not available in Europe. We cannot use it because it's still not available here. But yes, there should be a treatment after complex surgeries when pregnancy is not possible directly after surgery. But just today, for example, there was a patient and I just talked to her because I did the surgery for 2 days ago. And she asked this question and I said, yeah, we didn't resect any vaginal tissue. We didn't open your vagina. We didn't do bowel resection. We just resected deep endonodules in pelvic sidewall. We detached the ovaries. The fallopian tubes are fine. The uterus is okay. And I said, just wait for your menstruation and then you can become pregnant. And if it happens by nature, perfect. If not, please make an appointment in the reproductive center and you can use both ways. Yeah. And now my last answer here is I don't have any clue about the time window. I mean, nobody knows. Yeah. You can say, okay, what if after 6 months she's not pregnant? I don't know. I mean, people ask that. Yeah, they always ask, okay, how much time do I have? And I say, I'm not sure. I don't know. Because some patients after 6 months again have symptoms, but you cannot do any treatment because they want to become pregnant. Yeah, it's difficult. It's still difficult, but yeah, I think this is my answer to your question.
Thank you, sir.
And maybe as an addition, you have to think about adenomyosis, of course. If the patient has also adenomyosis, then her chance is lower. And this is an important information too.
Okay. And the Elagolix is newly derived drug that is now available in Bangladesh, and we are just start to giving it to our patient.
Yeah, and I'm sure you will be very happy with that.
My last question to you, sir, and it's a very common question. Many of the participants wants a guideline from you, a simple guideline that when we are dealing with this sort of the patient, their age is increasing with their ambition, with their career. So many of them will marry after the age of 35 years. And sometimes this aged patient will come to us with bilateral chocolate cyst or endometriotic cyst, and the size will be more than 7 or 8 centimeters. At the same time, when we evaluate the AMH level, the level is less than 1 or less than 0.5. That is the poor ovarian reserve. So when the mid-level specialist or doctor get this sort of patient, what is your guideline or what is your instruction for dealing this sort of the patient?
Yeah, it's a good question. And usually those patients not just have ovarian endometriosis. I mean, what you describe is an extensive disease. And usually we say that an ovarian endometrioma does not come alone, especially when they have a size of 7 centimeters and both sides. Then we talk about kissing ovaries probably, and this might be just one sign of the disease, which might be a frozen pelvis with additional deep endometriosis lesions. So what I recommend is that first you need to check if there is additional deep endo, if there's a rectal vaginal endometriosis, if there is adenomyosis, maybe by ultrasound or MRI. Of course, you need AMH. And then when you have all the information, then you can talk to the patient about her chances, about the risks of surgery, about the chances in assisted reproduction. And in this case, I think I would recommend a surgery because this looks like a severe situation and her chance to become pregnant just by reproductive techniques is low in this situation too. So I think surgery does make sense. I would go for surgery, a complete surgery, because when she has 25, 26 years of age, then it's time and it's the last chance. So there must be one good surgery and then you have all the chances afterwards. And of course, the ovarian tissue preservation is of very, very high impact in these patients. We also have many, many patients of this age. And yeah, I mean, there are some that we send to the reproductive centers, but most of the time when the ovaries have such a large endometrioma, the reproductive colleagues also say, okay, please first do the surgery and then we can do our job. Yeah.
Thank you. That means the first surgery should be the best surgery. This should be the strategy. Thank you, Professor Khalid Krantel, for your excellent presentation and excellent question answer session. And many participants from our country give the salute and respect and gratitude to you for your presence in ESB pre-conference workshop. And I am just mailing again and again to you and to Shravi. I'm sorry for that because your presence is very precious to us. And thank you very much for joining with us. Now I am going with a panel discussion session, and I'm requesting you, Professor HK, just join with us in the panel discussion session. My first question to our panelist, Professor Maliha Rashid, Madam. Madam, what is the importance of assessing pre-operative and post-operative AMH level in fertility sparing surgery of pelvic endometriosis? And if you prescribe to do it post-operatively, then how long after the surgery? Professor Maliha Rashid.
Thank you, Dr. Sharmin Abbasi, for the nice question. Honorable chairpersons, respectable speakers and panelists. Endometriosis, we know, is the most common cause of infertility and most distressing non-malignant disease of fertile women, but behaves like malignancy. The cause of the disease and modalities of treatment is still unclear. Anti-Mullerian hormone, that is AMH, is a glycoprotein structurally related to inhibin and activin from growth factor beta superfamily secreted by the granulosa cell in the female and the Sertoli cell in the male. Their male function is the growth differentiation, folliculogenesis, and sexual differentiation. In the female, AMH is secreted from the granulosa cell and it starts at the birth and up to the menopause. Though plasma level is barely detectable at birth, as AMH cannot be detected in resting primordial follicles, but expression rapidly increases once the follicle reaches the preantral and antral stages, and maximum when the size is more than 4 millimeter and minimum when it is more than 8 millimeter in diameter. AMH seems to be a strong suppressor of both initial cyclic recruitment and arresting the premature depletion of the follicular pool. Serum AMH concentration correlates with the number of small follicles and is impacted by the ovarian reserve. Various surgical treatments have been suggested for endometriosis, and significant differences of surgical outcome have been reported among the therapeutic procedures of these methods. However, the preference of most surgeons and patients have shifted from open operations to laparoscopy. And it is due to the fact that this is less aggressive and treatment is much more accurate. And there are some conservative surgeries in case of fertility preservation surgeries in endometriosis. They ranges from cystectomy, cyst drainage, and also sometimes it is required for a radical treatment, but which is not fertility sparing treatment. These surgeries may substantially lead to loss of normal ovarian tissue, and thereby reduction of serum AMH level. The magnitude of the decline was more evident for women operated for bilateral endometriomas and women who have prior poor AMH level, that is ovarian reserve. Yet surgeries are required for first growing endometriomas to exclude malignancies and to collect eggs in cases of big endometriomas. Some amount of ovarian tissue is lost with striping of the cyst walls, and if the ovarian tissue is ablated with the electrocautery, and also by the inflammatory process of the disease. It was seen that ovarian tissue was present in cyst wall in 65% of those who underwent laparoscopic surgeries and 80% for those who has laparotomies. This may be due to the fact that the laparoscopy helps in a better dissection and less loss of ovarian tissue when compared to simple cyst. In the simple cyst, the presence of ovarian tissue in the cyst wall is 31 to 40%, whereas in case of endometriosis, it may be up to 65%. Now, in the recent studies, it was seen that AMH decreases significantly at 6 months postoperatively after the surgeries, and it begins to decrease more in case of bilateral, that is 67%, than in unilateral, that is in 57% of cases. Basal AMH level was only independent factor affecting the AMH decrease. So AMH level should be estimated before surgery to detect the basal AMH level, that is the ovarian reserve, and also after the surgery, it is better to measure after 6 months, and some Sometimes it is said that it should be measured after 1 month and also 3 months after the surgeries. Thank you very much. Thank you.
Thank you, madam. Thank you for your evidence-based answer. Now, my next question to our next panelist, Major General retired Lisa Chodri, madam. Madam, what should be the surgical strategy to reduce the chances of recurrence? And when we need to control the bleeding, which is proper options from your point of view, cauterization versus suturing? What is your opinion? Just unmute yourself, madam. Yeah.
Thank you, Dr. Shamin, for your very important question. And this it is to the organizing to make me panelist and in this August session. The first part of the question, that is the should be the surgical strategy to reduce the chances of recurrence and keeping ovarian reserve in proper. And next part is whether cauterization versus suturing, which option is best to tackle the bleeding. The benefit of all surgical interventions to endometriosis must be weighed against the potential of the ovarian injury. And we can do ovarian injury by extirpation, that is stripping of the ovarian tissue in a big portion, or to injury to the vascularity of the ovary. Studies shows that the AMH that our Professor Maliha madam told, the AMH of up to 30% after excision of unilateral endometrioma and 44% after bilateral endometrioma. So minimizing the effect of surgery or on ovarian reserve, several strategies can be adopted. Number one, during laparotomy or laparoscopy. Certainly the laparoscopy is superior to that of the laparotomy. During laparoscopy, meticulous surgical techniques should be adopted. Number two, we should spare use of electrosurgical instruments. And several surgical approaches for management of ovarian endometrioma, we do excision, that is cystectomy, ablation, or combination of excision and ablation. A Cochrane review shows combined ablation and excision results higher rate of spontaneous pregnancy. Our guest lecturer, and it's so deep endometriosis, deep pelvic endometriosis after operation, there is chance of spontaneous pregnancy. And there is very lower rate of recurrence, but decreased ovarian reserve. And in alteration with excision, we can do only ablation. And ablation can be done by monopolar or bipolar electrosurgical techniques, or with carbon dioxide laser or plasma energy. Among the ablation method, carbon dioxide laser and plasma energy may results minimal thermal injury, and it improves the ovarian reserve. Some authors describe there is 3-stage approach. That is, first laparoscopic cyst drainage and to take biopsy to confirm the diagnosis. And next, treat for 12 weeks by GnRH analog. And then again do laparoscopy to ablate the cyst wall by carbon dioxide laser. But it has a clean drawback, that is repeated surgery. It needs repeated surgery, and it needs repeated surgery, and there is it is not cost effective, and it causes more time. And combined excision and ablation is a suitable and experienced hand. The excision up to 80 to 90% peripherally, and 10 to 20% of the cyst wall near the hilum, where bleeding and decortication due to are most likely occurs, where the carbon dioxide is near the hilum. We can do carbon dioxide laser ablation, and there is a very less chance of recurrence, that is only 2%, some studies shows.
Thank you, madam.
To optimize the fertility during excision of the endometrium, there is a dilute vasopressin we can use, and it is reduced blood loss, and it causes very good separation during stripping. And bleeding point is better to do suturing. We must avoid electrosurgical procedures. Suturing is better. And some study advocate the hemostasis sealant, that is rather than bipolar cauterization, that is gelatin mattress and thrombin like Closil, and use adhesion barriers like interseed, expanded polytetraethylene, that is Gore-Tex fibrin sheet, and it can be suitable to stop bleeding and avoid next chance of adhesion.
Thank you.
Finally,
Thank you.
Finally, the surgeon's experience. It appears the major role for fertility preservation. It should not be done by junior one, where fertility preservation is normal. Thank you very much. Thank you for patience.
Thank you, Professor Lija Chodri. Madam, I just want to ask Professor Harlit, what is your opinion regarding cauterization or suturing? Which one is preferable? Your point of view, and vasopressin, do you use in your country? And just give me a short answer.
Yes. Well, for example, Professor Keckstein from Austria, he's using vasopressin for many, many years, and the results seem to be very good. As you use the hydrodissection technique, and of course the effect on the vessels. Then we have very good results by laser, as for example, Professor Nizol from Belgium is using. Well, we mostly do a stripping of the ovaries. And when you use graspers to do the stripping, you can do it very, very carefully, and you can coagulate just the vessels in very, very small spots if necessary. But this means that you need irrigation in one hand, you do the stripping, and you do the coagulation after every step. I think this could be a good technique, but of course it's important that you use as low energy as possible, and you avoid to burn all the ovarian tissue. So you shouldn't just strip off the endometrioma and then start to coagulate wherever it bleeds, because this might harm the ovary a lot.
Thank you. Thank you very much for your nice answer. And Professor Keckstein will join in our next session, because Dr. Jupi is not present. He will give the question answer session. Thank you, Professor Hunt.
Okay.
Now we are at the end of, Professor Keckstein, you just joined with us. Welcome, sir, for joining with us. Now I'm just taking the comments from the chairpersons. First of all, I'm taking the comment from Professor Rashida Begum, one of the pioneer fertility specialists in our country. Madam, what is your opinion from your side?
Thank you, Sharmin. Thanks, organizer, for inviting me to chair this session. Respected audience, Assalamu alaikum and good evening. Actually, everything is covered, and thanks, Professor Harold, for your nice, elaborate discussion. You mentioned fertility sparing, fertility enhancing, and symptom relieving procedure, all covered, and the rest of the covered by two panelists, Lija Chodri and Malia Rashid. I just want to say, along with T.A. Chodri's statement, that we have to select the patient very meticulously before going for surgery. Before surgery, from the reproductive endocrinologist perspective view, I want to say before going for surgery, we must do the MS level. And if MS level is less than 2.1, we have to think if for unilateral endometrioma, 2.1 is satisfactory for going for surgery. For bilateral, it should be 3, because for, after bilateral cystectomy, it will drop out. And we have to judge the case, select the case properly, and we have to think about the limit of the surgery. That is how far we need to go for meticulous surgery. And we have to judge the limit of our skill. This is very, very important. We have to judge the limit of our skill. Just 2 days ago, I got a patient from a very renowned public hospital. She did laparoscopy, in the month of August. And actually she has deep endometriosis. She did nothing with that. And even unilateral endometrium is retained as it was. And she put her on suppressive therapy. But for fertility, it will not work at all. So we have to judge our limit, and we have to do the surgery very meticulously. If there is nodule, rectovaginal nodule, then and patient has a symptom of dyspareunia, until and unless you don't remove the nodule, the symptom will not relieve. So you must have to remove the nodule, but it is very difficult job. For every surgeon, it is not possible. Yeah. It needs very finest skill. That is the question. And about AMH, there is one thing. First 3 months, it drops, but after 3 months, after 6 months, it is seen that it will increase a bit. There is a disparity that a level of AMH in endometriosis always does not go side by side with ovarian reserve, because TNF, that is T1 necrosis factor, it reduces the AMH level. So most of the time it is seen that AMH level is low, but when we do IVF, number of egg retrieval is not so less according to AMH. And if patients are younger, then it is also good. And about fertility sparing surgery, already Lisa covered everything. And about suturing and coagulation, there is very recent publication is published in the month of this year, month of March. And it was shown that among hydrostatic sealant, suturing, cauterization, among all, suturing is the best. If someone is expert in giving suture, it is the best. And about recurrence on information, you need to know that if you do surgery in secretory phase, the chances of recurrence is more. Okay. In secretory phase, not only chances of recurrence more, but also there is, if you damage corpus luteum, then there is excessive bleeding along with bleeding of cyst stripping. Corpus luteum also begins to bleed. So there is more chances of cauterization. So always do surgery in follicular phase of cycle. Thank you so much.
Thank you, madam. Your expert opinion always guideline for us, madam. And you just guide the mid-level and the junior doctor always with your knowledge, then how can rationally we can manage the infertile patient in our country. Thank you, Professor Rashida Begum. Now I'm just running with this session and last moment of today's session. I'm taking another expert opinion from Professor Parveen Fatima. Professor Parveen Fatima has a huge experience with dealing of infertile patient in our country and the legendary fertility and ERT specialist in our country. Professor Parveen Fatima, just giving your opinion regarding the thoughts of presentation and today's topic. Just unmute yourself, madam, please.
Thank you very much to the organizer as well as Dr. Sharmi. The lecture given by Dr. Harold was wonderful. And whatever he has shown us today, actually he has shown us his credibility and what we have seen. This is severe degree of endometriosis management. And today, we are thinking about the fertility sparing endoscopic surgery also. So fertility, in this region, the Southeast Asia, the endometriosis is very high. And these patients, when they come to us, some of them are asymptomatic even, but when we check them, we find them that it's huge endometriosis in the pelvis, and there are severe adhesions. So we have to manage them. But when we think about the fertility, we have to take into consideration about the facts that how to preserve as much as possible the ovarian tissue. And not only that, the thing that the vascularity that is there, if we cauterize too much, the vascularity will be impaired, and that will also indirectly cause ovarian reserve to be poor. So whatever we do, initially it was discussed that the surgeons must be an expert who wants to do this sort of surgery. That is very true. whoever wants to be a laparoscopic endoscopic surgeon, they by doing repeated surgery, their skills are improving, and this will take some more time. With 1 month training, 2 months training, it will not work out. There must be a long time, and we have to be surveillant that we will be doing this for our people, because endometriosis is a huge problem for this region, patients of this region. So I welcome you all for this preservation surgery for our women become we give them the good skill, and so that their fertility is there. But to our concern, the thing is that fertility is very much lowered in this group of patients. Even the mild endometriosis patient also will not conceive all, but some will conceive, but they also need some management. And not to say about severe endometriosis, whatever type, we have to be very cautious. We have to give them, and the awareness creation is a must, because they must not take it as a pain for menstruation. They must come forward, as well as we must also come forward to give them the service what they need. With that, I thank you all for the wonderful session that has been done today by our Society of Endometriosis and Adenomyosis Society of Bangladesh. Thank you all.
Thank you, Professor Pervin Fatima, the Honorable Vice President of our society, for your excellent addition. And you told about the awareness creation. And we are, Madam, you know, with our society, we're doing lots of work all over our nation for the creation of the awareness. So it's an excellent interactive session. I'm thankful to the speaker, panelists, and the chairperson, and give a big hand for this excellent session. Thank you very much. Now over to the session 3, to the moderator, Professor Shahnara Chodri, the Honorable Executive Member of Easb. Over to Professor Shahnara.
Sharmin, 1 minute. Adhan is just about to finish.
Okay.
Sharmin, for moderating the wonderful session on fertility sparing surgery. Now it's my turn to continue with the other side of the coin, adenomyosis, from extrauterine to intrauterine. Respected ladies and gentlemen, participants from home and abroad, and Assalamu alaikum and good evening to everybody. I am Professor Shahnara Chodri. Welcome you all to the most awaited conference workshop on first international virtual scientific conference of Endometriosis and Adenomyosis Society of Bangladesh. Now, we would like to continue with our third session of the workshop. And this session will be on surgery for adenomyosis, a newer challenge for the patients and for the physicians. And in this session, we have a topic of discussion on what to do and not to do in adenomyosis surgery. You will be happy to know that, dear audience, that the speaker of this session is Professor Eric Juppé from Italy and former treasurer of European Endometriosis League. The session will be chaired by our two honorable chairperson, Professor Saleha Begum Chodri, Secretary General, Easb, and Professor Mariam Faruqi, Secretary General, Fertility Preserving Society of Bangladesh. We have also two expert panelists with us in this session called panel discussion. Professor Samsun Nahar Laki, Organizing Secretary, Easb, and Dr. Monwara Begum, Organizing Secretary, Gynecological Endoscopic Society, Bangladesh. Dear participants, there will be 30-minute presentation from our learned speakers, Professor Enrico Jupi, followed by a short question answer session. If you have any question, please put them in the chat box, and hopefully the answer will be from, we are expecting the answers from Professor George Kestin. He just joined with us. Well, I feel honored to welcome Professor George Kestin within us. It's my great pleasure to introduce the speaker, Professor Enrico Jupi, Professor of Obstetrics and Gynecology and Research Fellow, Unit of Reproductive Surgery and Infertility, University of Connecticut. He is also the past president of Italian Society of Obstetrics and Gynecology and former international vice president and present advisor of American Association of Obstetrics and Gynecologists. He is the author of 164 international scientific publications in different reputed journals and books. He was the editor-in-chief of the Journal of Endometriosis and Pelvic Pain Disorders, and also the reviewer of many reputed journals like Fertility, Sterility, AJOG, and Journal of Minimally Invasive Surgery for Gynecologists. It's my great pleasure and I feel honored to request Professor Enrico Jupi to continue with his presentation. And dear audience, he will be talking on what to do and not to do in adenomyosis surgery. Over to you, Professor Jupi, sir.
Good morning. Thank you very much for involving me in this pre-conference talking about adenomyosis surgery, endoscopic adenomyosis surgery. And before we start to detect the opportunities we have today in treating surgically adenomyosis, I wish to introduce this topic with a detail around this very important pathology and also the way to detect and to have a good diagnosis of this expression, intramyometrial expression of endometriosis. I have nothing to disclose, and we can start talking about adenomyosis, and you can understand from this slide how difficult it is to have data about adenomyosis. I mean real data, prospective randomized studies that are very few, because if we have a pathology in which the prevalence is reported to range from 1% to 70%, you can understand about the lack of standard diagnostic criteria, both by imaging modalities and pathological analysis. But before we start in the evaluation of the ways we have today to have a non-invasive diagnosis, we have to underline which are the symptoms, clinical symptoms of adenomyosis that we have to consider when are referred by the patients. Abnormal uterine bleeding, dysmenorrhea, dyspareunia are the more common symptoms we know from the patients. And then we have to also detect the relationship between adenomyosis and possible infertility. Another point we have to underline is the classification of adenomyosis. The FIGO group underlining the importance of individualized adenomyosis in this so-called Palm-Cohen classification. After that, the MUSA statement in 2016 refined sonographic diagnostic criteria. And this is very important because the combination of both clinical symptoms and imaging, we will see, can give to us the chance of a right non-invasive diagnosis. The preoperative diagnosis of adenomyosis remains challenging. And another important point is the evaluation of the potential association of adenomyosis with different but very often associated pathologies, like deep infiltrating endometriosis that ranges between 40 and 70%, and also leiomyomas. That is a confounding factor if we have to decide to operate women with clinical symptoms and suspicion of adenomyosis. We have to be more than sure that the suspected leiomyomas are not adenomyomas, because the surgical approach is completely different. So, as we said before, imaging up today is the way we have to follow to obtain a very reliable diagnosis in both MRI or transvaginal ultrasound. It depends on the skills, because it's not so easy to obtain a transvaginal evaluation. But the most important thing is following the clinical symptoms, the way to reach the presence or not of adenomyosis, to better define what we have to do, especially if the way we have to follow is the surgical one. Today, we know, coming from different studies published in few years, that adenomyosis is not like the ones we had in the past, in which the age was considered between 55 and 50 years. We spoke about multiparity, and also we spoke about short menstrual cycles. Today, we know that also young women are potentially affected by adenomyosis, and so this is the way, because the surgical approach is considered important and definitive for giving to this young patient the chance to have to become pregnant after that. In these two different papers we published in 2015 and 2021, the association of some clinical symptoms we already defined is related with adenomyosis in young nulliparous women and adolescents. The management of adenomyosis, the medical treatment is well known. Non-surgical alternatives are some news without a deep level of data. And we go to speak about the uterine-sparing surgery, the role of endometrial ablation, and also the role of hysterectomy. Because at that time, when we considered only patient over 40 years old, the only way was to remove the entire uterus to obtain the remission of the clinical symptoms. Up to today, considering young patient, we have to consider also the chance to save, to spare the uterus, and to do endoscopically or not, we will discuss about that, this kind of adenomyosis sparing surgery. The desire of pregnancy is the most important point in young women, in which we have to consider, after a right diagnosis, the sparing surgery we mentioned before. So the treatment option in this presentation is just considered about the surgical treatment. I repeat, it's important to detect the association or not, or the presence or not of a leiomyoma, because as you see from this slide, that leiomyoma is not so easy to do a right differential diagnosis with adenomyosis. But in terms of surgical approach, is completely different. The treatment and also the difficulties are completely, the level of difficulties is completely different. The adenomyomectomy is the resection of adenomyotic tissue from the uterine wall and the reconstruction of the uterine wall to prevent rupture in potential pregnancy subsequent. The procedure resulted in a dramatic reduction in symptoms and allowed to conceive without uterine rupture, even if you will see in some of the next slides, we have obviously an higher percentage of rupture during or at the end of the subsequent pregnancy. The papers published on the characteristics and efficacy of modified adenomyomectomy in treating uterine adenomyoma. This was published from Lang et al. Because they underlined how important is the technique for both the removal of adenomyoma and the preservation of the recreation of the integrity of the uterine wall, because the goal is to give the chance of a subsequent pregnancy. In this review coming from Grimbitzis et al., they said that uterine sparing operative treatment of adenomyosis appears to be feasible and efficacious. Control of dysmenorrhea is achieved in more than 81% and menorrhagia in 50% of patients. Obviously, we have to consider also the age of this patient, talking about the subsequent potential pregnancy. In fact, in 2014, Kishi et al. Underlined that obviously less or more 40 years old is the level, the cutoff to have better results in terms of pregnancy, I mean spontaneous pregnancy or IVF treatment failures. Other papers have been published in this review coming from Tolandis group considered that the pregnancy rate after conservative surgical treatment vary widely. And this is what I said before. We have to inform in our counseling patients that had a fertility sparing surgery and the subsequent pregnancy, that the percentage and the risk of uterine rupture related to the pregnancy after removal and adenomyosis is more than 1% compared to the 0.26% in pregnancy following myomectomy. So it's important to inform the patient because of the risk of this kind of complication after removal of adenomyosis. Another important step is the consideration of the subendometrial localization of adenomyosis. And this could be removed by hysteroscopy. If we have a good diagnostic way, I mean a good imaging that is able to detect the presence of adenomyosis in this part of the uterus, I mean the subendometrial portion, we can obtain an excellent success, and we don't have to open the uterus in a right and very fast way through resectoscope. There are also other treatment options except the medical one, and not talking only about surgery. If we consider the non-surgical techniques like the uterine artery embolization, that is very effective, but is not suggested for people that is on the way of a subsequent pregnancy, is effective to remove some of the symptoms related to adenomyosis, but is not suggested for women that are looking for a pregnancy. Another option is the magnetic resonance guided eye focus ultrasound surgery, but we don't have enough data at this time to establish that this is one of the options, the effective option. Duol et al. Published about the possibility to treat this kind of pathology through this magnetic resonance guided eye focus ultrasound, but studies with a large cohort group are needed to establish if this is an effective technique or not. Another point we have to consider is the relationship with some obstetrical complications with adenomyosis, and this is one of the reasons why probably a surgical, sparing surgery is important, but also this has to be considered in counseling our patient affected by adenomyosis. The risk of preterm delivery, the risk of the reduction of growth of the fetus, and also fetal malpresentation are higher in the adenomyosis than the control group, as in this paper has been shown in 2015, showing uterine adenomyosis to be associated with poor pregnancy outcomes. And this is one of our papers in which we hypothesized the possibility of a strict relationship of adenomyosis with the postpartum hemorrhage. And this is another way because we have to suggest an adenomyosis surgical approach in young women that are looking for a pregnancy. So there are several other points. Adenomyosis is associated with a lower clinical pregnancy rate and higher miscarriage rate after ART, especially after short protocol of down regulation in ART. And we have to insist about the diagnostic criteria for adenomyosis. That is the only way to inform our patient about all I said before. I mean all the possibility and the numbers related to the possibility of a pregnancy, and overall also which are the complications related to the surgical approach, especially the fertility sparing surgery, as I mentioned before. At the end, another great diagnosis and also improving our research and integration of medical and surgical treatments, and infertility and obstetrics complication as we have to report to our patient. And overall, the individualization of treatment is our focus. I just want to underline the difference we have on the endoscopic approach to adenomyosis, I mean surgically, and the open approach of this pathology when we have to reduce the number of lesions. In my opinion, through endoscopy is not an easy intervention, and the risk of bleeding and the risk of a potential hysterectomy in a young patient that is with us because of the need and the tentative of a subsequent pregnancy is very high. My suggestion is still related to a mini laparotomic approach and the possibility to do a right and very strong seizure to reconstruct the wall of the uterine wall and to give more chance to the patient to conceive and to have a right pregnancy. That is the goal of this kind of approach in young patients. Thank you very much.
That's an excellent time-honored presentation on adenomyosis surgery. Thank you very much, Professor Jupi, for your wonderful presentation. You rightly pointed out that there is a paradigm shift of incidence from multiparous to nulliparous, from adult of 40 to young star of 30 years. Now they are coming for desire of a pregnancy, which is a pressing challenge for all the OBGYNs, for fertility specialists, as well as for fertility conserving societies. We have to concentrate on the three pertinent issues while treating a patient with adenomyosis. The number one, symptom control. Number two, fertility preservation. And number three, uterine conservation. So I thought our youngsters all will concentrate before decision for going to operate in any adenomyosis patient. That is, you should have by this time grasp the idea of what to do and not to do. Now it's my great privilege to welcome Professor George Christen. He will be with us for the Q&A session. He has a keen works and lots of work with Enzian Classification. And my question to Professor Christen, do you think the presence of adenomyosis will alter the classification, or how adenomyosis will be incorporated in the Enzian Classification? Thank you, sir.
Yes, hello. Thank you very much for inviting me to be part of your very good Congress, and also your course, which is so intensive and informative. And I would also thank the organizers to invite me as a discussant. And I enjoyed also the lecture of Enrico, and he's a real expert on endometriosis and adenomyosis. And he clearly focused on the individual treatment of the endometriosis. What means individual treatment? Individual treatment means I have to identify all adenomyosis, and this is sometimes very tricky, very difficult. With the new ultrasound probes and with a better MRI, we are able now to identify and to localize the lesions. But with the ultrasound, we're still struggling if the alteration of the myometrium is due to adenomyosis, or is it something different? We are on the way to have more information, but at the moment we have a problem to always be correct. There are clear signs, clear patterns which are 100% adenomyosis, but there are many which we are not sure. For example, the thickening of the uterus sometimes is a contraction, and it's only a transient phenomenon, and we should be very careful giving the diagnosis to young patients, because if you do the ultrasound a few months later, it disappeared. So that's just for the introduction to tell you that before we classify it, we have to be sure that our tools are very, very accurate. And this is the problem we are facing at the moment. For that reason, we did not include a differentiation in the adenomyosis. Adenomyosis is included in the Enzian Classification, but probably, let's say, in 2 or 3 years, when we have got much better information about which signs should be included and how. And this is something which we have already, the MUSA criteria and other classification, especially for adenomyosis. The ESGE at the moment works on a special classification. So this is something which I think is under progress and under process. And for that reason, I do a lot of adenomyosis surgery, and we still have to be very careful by the indication of surgery, by the way how we do it. This is something which we will discuss probably in the next few minutes. And for that reason, classification, you should identify it. You should name that there is something strange or there's something not normal, but in fact, we have to work on it. That's clear. Thank you for this question.
Thank you. Because many a time while approaching for myomectomy, we many a time found that it is not myoma, it is actually focal adenomyosis. My question to you, how to assess because we are now in the era of lap surgery, laparoscopic surgery, so we are out of our manual palpation. So how to assess the depth or limits of excision during laparoscopic adenomyectomy or during debulking excision? Please give some tips to our audience.
Yes, okay. First of all, this is a very, very important remark that with the endoscopic or even robotic surgery or robotic assisted surgery, we lost our sense of our hands and fingers. Yeah. This is very bad because this is so informative, having the tissue within your fingers to judge where is the adenomyosis. This is a very, very important issue. You can, if you have a focal adenomyosis, which is clear circumscribed, which you can identify by ultrasound clearly. So I think it's not a real problem because with your instruments, you can feel it indirectly by touching it and by pressing it. What I sometimes do, because in most of this surgery, I make 12 or 10 millimeter incision suprasymphytic, and I remove in not too fat patients, but I remove the trocar and I use my finger and I go through the incision into the abdomen to feel the uterus. I make a digital normal control. This is one thing which is important. The next thing is, what instrument do you use when you excise it? And Osada, he clearly showed that if you use energy, for example, ultracision or monopolar or some other thermical surgery, you destroy the sublying tissue, which may cause a healing defect. So if in cases for pain, this doesn't make any difference because the patient doesn't want to become pregnant. But in patient with infertility or young patient, you have to be very careful because you have to know that it's in contrast to the myomectomy. When you do myomectomy, you don't lose any myometrium at all. If you do the adenomyomectomy, that means you also remove part of the myometrium. So you lose a substance of the uterine wall. That means the closure can be much more difficult, can be very tricky. And for that reason, you have to be aware that suddenly you have a defect which you hardly can close. And then you have to have a strategy for that. And you should know this in advance. So let's come back. So if you excise with electricity, you don't feel the tissue. I mean, you can see indirectly the effect of the electricity. How is the dissection procedure going on? Is it fast or not? You can see the structures of the tissue. You can touch it with the cold instrument. But I sometimes, in that cases, use also through this trocar or through the pure incision, I use a cold knife. And I do the excision only with a knife, with a scalpel. So the scalpel is a very, very fine instrument. That means you can feel scratchy or if it's a smooth tissue. This is something which you have to experience. And I personally believe you should still think, and you know, I do laparoscopy since 1983. So I'm addicted to laparoscopy, but there still remains one indication where I do open surgery. And this is sometimes in adenomyosis, because I have only one chance. I talk about diffuse adenomyosis. If you have a local focal adenomyosis, this is no problem. You can do the excision laparoscopically, no problem. But let's talk about the severe cases. And these are these cases which probably are really related to the infertility. So then you have, if you want to repair something, it's not a question what you do, how you do it. It's a question, what do you leave behind at the end of the surgery? How does the uterus look like? How is the surface? Is there any suture on the surface for adhesion prevention? Did you close the wall properly in 2-3 layers? Yeah. No hematoma, yeah. No defect, no necrosis. And this is microsurgical approach. And this is something which I insist very much that you have to be experienced. And if you never have the possibility to have a uterus in the hands during surgery, how can you imagine during laparoscopic surgery?
Thank
and
you,
this
sir.
is something you should be very important.
Thank you, sir. My last question to you, in short, in brief, what is the role of uterine artery occlusion or use of vasopressin? A short comment,
yes.
Because we are running short. Okay. A short comment of uterine artery occlusion and vasoconstricting agent before adenomyomectomy.
Yes, okay. The occlusion of uterine artery, I never did it. It's not necessary. I use vasopressin, 20 units diluted in 100 milliliters saline. I inject it with a spinal needle through the abdominal wall, and I never used a clipping of the uterine artery.
Thank you, Professor John Kestin, for your wonderful and excellent and confident answer to all my questions in the question Q&A session. I think our audience will be immensely benefited from your answer and what to do and what not to do. So thank you again on behalf of Easb Society and on behalf of me and our session. Thank you very much for joining us. Now, thank you very much. Dear audience, now this is the time for taking expert opinion for our eminent panelists. Our first panelist is my friend, Professor Samsun Nahar Laki. She is a laparoscopic surgeon and doing fertility sparing surgery for many years. My question to you, madam, a 33-year subfertile woman presented with severe dysmenorrhea. She conceived twice, but both ended with miscarriage. Pelvic scan shows the definite features of adenomyosis. My question is how to plan for fertility sparing surgery in her case. Over to you, madam. Please unmute, madam. Please unmute, madam.
Thank you. Respected chairpersons, learned speakers, panelists, and audience, good evening and take my salam. Actually, I'm very much glad to be a part of this scientific discussion. The questions to me, adenomyosis with infertility or recurrent pregnancy loss or recurrent implantation failure or unsuitable for long-term medical treatment are definitely a challenging management for the gynecologist or fertility specialist. So considering its surgical management, planning is necessary, either it's focal adenomyosis or multifocal adenomyosis or diffuse adenomyosis. The surgical options are either laparoscopically or open adenomyomectomy with or without myometrial resection, or resection with the double clamped method repair, or hysteroscopic endomyometrial resection, ablation, electrocoagulation. Now, the fertility sparing surgery, what's about the pregnancy outcome? So here I am discussing the systemic review studies, that about 27 studies, over 1,398 adenomyomectomy surgery women, that showing over 3 to 4%, overall 3 out of 4 of women with experienced symptomatic relief after conservative surgery. The pregnancy rate after conservative surgery was varying widely, and 3/4 of them became pregnant without adjuvant medical treatment. So depending on the duration of follow-up, recurrence rate differ from, that may be 0 or may be a half of these patients. Besides this, there is again risk of first trimester, second trimester abortion, preterm delivery, scar ruptured, and also I explained the recurrence already. So actually pregnancy rate is higher in focal adenomyosis than the diffuse adenomyosis. The best method of surgery is yet to be seen. So fertility specialist glad to take the challenge, but patient's fertility achieving depends upon the blessing of the God. Thank you very much for asking me. Thanks.
Thank you, Professor Samsun Nahar, for wonderful explanation of the need and assessment of the patient before embarking on fertility preserving surgery and its consequence and subsequent success. We have another panelist with us. Now the question to Dr. Manwara Begum, a 36-year-old multiparous woman presented with heavy menstrual bleeding with severe dysmenorrhea. She was treated with oral hormones for many years and tranexamic acid, and she was infused with 5 units of Paxil. Ultrasonography reveals adenomyosis. My question to you, madam, she is a multiparous woman, and how our juniors will going to manage her case? Because we by this time know that what to do and what not to do. What are the options available for her? Because she doesn't want to be uterus resected. Thank you very much.
Thank you, Professor Chanadara. Respected chairperson, learned speaker, and dear participant. Good evening. We know that adenomyosis is a common benign gynecological condition And still, now it remains as a clinical challenge to the physician, especially about the treatment. Throughout the year, we gynecologists manage it either by medically or surgically. Until recently, hysterectomy has been the only definitive treatment for the patient with adenomyosis who have completed their family. More recently, there are second line of treatment option has been considered in between the medical treatment and surgical treatment. In this case, as this patient is young and she is only 36 years old, multipara, and does not want hysterectomy and did not respond to the medical treatment, so for her, second line of treatment option can be considered. But every option has pros and cons, so proper counseling to the patient should be done regarding the risks and benefits, and consent should be taken before the treatment. First choice of second line treatment is the levonorgestrel releasing intrauterine device. It releases 20 micrograms of levonorgestrel per day, and its potential mechanism of actions are endometrial desitualizations and atrophy, reducing endometrial blood flow, and decrease in the number of estrogen receptors in the endometrial glands and stroma, and thereby reduces excessive menstrual blood loss. Average blood loss could be reduced by 75% after the administration of levonorgestrel. This may further prevent estrogen stimulation of myometrium by adenomyosis, causing the lesion to atrophy. However, its efficacy in the treatment of larger uterine adenomyosis is not clear. In clinical practice, an enlarged uterus greater than 12-week gestation is one of the main causes of spontaneous expulsion of IUD with excessive bleeding and blood clot. Second option is the uterine arterial embolization. This is an angiographic procedure whereby an embolic agent is injected through the femoral catheter into the uterine arteries to induce ischemic infarction of adenomyotic foci. Uterine artery embolization is an established treatment option for uterine fibroids and has recently gained ground as a safe and cost-effective method for treatment of adenomyosis with promising results. Significant improvement in presenting symptoms and in quality of life is associated with reducing bleeding, decrease in uterine size, and junctional zone thickness. Uterine artery embolization has been proposed as a less invasive alternative to hysterectomy to treatment adenomyosis. Third option is the hysteroscopy dissections or ablations. By hysteroscopy in two-way endometrium dissections or ablation can improve the symptom of excessive menstrual bleeding, but often fails to relieve the dysmenorrhea, and for that, patient can be treated with NSAID. Another is, as it is possible to remove intramural myoma with refined hysteroscopy technique, hysteroscopic adenomyosis may also be possible in selected cases, especially when the adenomyoma is less than 5 centimeters and when it protrudes into the uterus. However, hysteroscopic adenomyomectomy should always be carried out under ultrasonograph guidance, and pre-treatment with 3-month course of GnRS agonists beforehand can help reduce the vascularity and bleeding during the operation. And fourth option is the high-intensity focused ultrasound. High-intensity focused ultrasound is the use of intense ultrasound energy directly targeting abnormal tissue and their vascularity through heating and cavitations, sparing the normal surrounding tissue. This process can be guided and monitored through the MRI or ultrasound. High-intensity focused ultrasound has been used since 2008 for the treatment of adenomyosis. Since the literature has shown promising results regarding symptom relief and uterine preservation with few reported complications, namely pain, numbness, vaginal discharge, fever, skin burn, or contact dermatitis. And fifth option is the radiofrequency ablation. Radiofrequency ablation of adenomyotic lesion is another promising uterine preservation option for focal adenomyosis. And lastly, the sixth option is the recently trained of the uterus sparing surgical approaches were developed for the treatment of adenomyosis. And these methods are primarily based on the removing the diseased tissue to decrease the uterine size and improve clinical symptoms. And this treatment of adenomyosis has been gradually increasing with delay of the woman's childbearing age. And there a strong desire to retain uterus. And it has been discussed earlier, learned speaker. And so this uterus sparing surgical approaches can also be offered to this patient if above second line of treatment are failed. Thank you. Thank you very much.
Thank you, Dr. Monwara, for your wonderful answer and to this question. And my special thanks to both the panelists because you have guided you have given a guideline and recommendation for what to do in case of young and in case of multiparous women after 40 or at the later age of the reproductive phase. If any of our seniors want to say something on these issues because they have a long years of experience, I would happy to give the floor to any of the seniors. Madams are there, all the madams and sirs are there. If they have any question or comments or queries from your long years of experience. Otherwise, I will go to George Kestin again because I don't like John Kestin to give up.
Madam, important question in our chat box. You can take that one.
There is one question in the chat box that they want to know to just Kestin. Our audience want to know how to prepare a patient for adenomyoectomy. Is there anything preoperative preparation before going for surgery?
Yes. Thank you for the question. First of all, the indication must be correct. This is the main preparation, that you have to be sure that you have tried all other options before, because surgery is the last step, except what I would say in clear focal adenomyosis, cystic or solid, which can be removed easily or without any big danger or risk. So that's good. For the other thing is, I do not prepare the patient with GnRH analogs, which I think is not necessary. We did it, but we stopped it because sometimes it is more difficult to dissect the tissue because it becomes much more fibrotic and you do not feel anymore the border to healthy tissue. And that's the only thing what I do. And what I sometimes, which is important, some technical tricks I use, for example, by laparoscopic surgery, I do hysteroscopic before anyway, and then I put I place a balloon, a Foley catheter or a special uterine manipulator with a balloon on the tip, which helps you to inflate the uterine cavity. And then while you are dissecting, you can feel the balloon, especially when the adenomyosis is underlying the endometrium and you do not want to open the cavity, which is, you should avoid. Sometimes you cannot avoid it. But this, with the balloon in place, you inflate the cavity and you get a different shape of the uterus, which helps you to identify the borders and the structures adjacent to the adenomyoma. And I inject vasopressin. This is clear what I do. And for me, it's also important sometimes what I do is during surgery, if I'm not sure, I do a simultaneous surgery and transvaginal sonography. So I'm guiding my incision while I do a sonographic scan, and you can follow your instrument on the scan and you know if you are in the right plane. This is sometimes also very, very helpful. And for the preparation preoperative, there's nothing else.
Anything on postoperative follow-up? Any drugs like GnRH, or do you prefer how long she will embark on pregnancy?
That's a good question. we used before, many years ago, we used to use GnRH analogs, but now we put them on contraceptive pills to avoid the bleeding. And I think the surgical approach is the most important. Closure of the wound, perfect closure of the wound, multi-layer, to close the serosa properly to avoid adhesion formation. And what I do is I do ultrasound follow-up when the patient leaves the hospital, and a few weeks later to see if there's any hematoma formation.
Thank you very much for your involvement in this a wonderful question answer session. Thank you all the panelists, and thank you Professor George Keston. Now, dear audience, I feel honored to call upon our chairperson for their remarks. May I now first call upon Professor Mariam Faruqi Madam for overall comments on these regards, the chapter of adenomyosis, what to do and what not to do, because you are fighting with the fertility preserving surgery for many years. Over to you, Mariam Madam.
Thank you, Professor Shahana, my dear friend. Respected chairs and panelists and presidents of Easb and all members and speakers from abroad, good evening and assalamu alaikum. I found it an excellent seminar and very informative and very timely, demanding seminar. And my heartiest thanks to Dr. Zupi. And from all the speakers, I came to understand that we follow a proverb, think before you ink. What does it mean? It means before doing anything, I will make my plan, make my diagnosis correct before entering into the actual situation or operation. So it came very much true for this seminar, and everyone speaker, especially Dr. Kanstein, Dr. Zupi, told us that diagnosis may be challenging, operation may be challenging, but we will make diagnosis correct, then we will enter and we will think. And I think so for every patient, I think we will take some time for the patient, not only few minutes, for 15 minutes, 20 minutes. We'll take time to give them actual treatment, especially in fertility preservation, when in the past we thought little about fertility preservation. Oh, this is this, remove this, otherwise she will suffer. But now we think, no, we have to consider their follow-up throughout their hormonal replacement, their fertility preservation. And Dr. Zupi also gave much emphasis on proper diagnosis, although it's challenging, and the different types of treatment, radical, medical, surgical, and non-surgical treatment, and also the adenomyosis and its association with myoma, which we frequently met with. And after he mentioned the adenomyoectomy after result is good for relief of symptom, but for fertility and carry-on pregnancy may be difficult, and many patients may need IVF treatment, ERT treatment. And regarding one thing to my speakers, I attending one seminar in Rome. They say the UAE, uterine artery embolization, was banned in Europe because the embolization drug went through the uterine artery and to internal iliac artery, and there was necrosis of the superior intestine. So I don't know what is the situation now regarding uterine artery embolization, and regarding fertility sparing, it could not be done. I think it should not be done because it may cause harm to the uterus or other ovaries. And regarding preterm obstetrics, they told me about the preterm delivery.
Madam, unmute Karen, madam. Please unmute yourself.
Throughout unmute now.
Yes. Now, just for 1 second, you are unmute.
Oh, thank you, Shahana. Sorry. And regarding Dr. Lucky, she said very much about the, although we are doing fertility preserving surgery and treatment, but regarding the recurrent pregnancy loss, still there are preterm delivery, IUGR, and Dr. Kansen also showed the preeclampsia. These are much more with adenomyosis. But one thing, and Dr. Manwara, she narrated very narrated very elaborately about the medical, intermediate, and surgical treatment. And regarding surgical treatment, she told us about the LNG, IUCD, Mirena, or now Elora is available for the patient who wants to conserve uterus but multipara, not for fertility, and also UAE hysteroscopic removal of the submucous type adenomyoma, HIFU, and radio frequency ablation. And finally, she also told us about the excision of adenomyomectomy tissue. But one thing which Dr. Kanstein told us, we are getting familiar with the use of very much with the balloon of Foley's catheter. You know, Dr. Shahana, we are using in PPH, and although after submucous myomectomy or adenomyomectomy, which is submucous, to prevent uterine adhesion, it works very good. You can keep this for a few
after hysteroscopy.
4 to 6 weeks. Yes, after 4 to 6 weeks. No, in the uterus to prevent uterine adhesion, and OCP to avoid bleeding, immediate bleeding after this type of surgery in the uterus. So it was an excellent, and it is a very thanks to all. I give thanks to all and all the moderators, speakers, and also Dr. Shahana, you.
Thank you. Thank you, Professor Mariam Faruqi, for your wonderful comments and guidance. Now, I am requesting our second chairperson, Professor Saleha Begum Chodri. She, with her team, fighting for combating endometriosis and also the adenomyosis for a long time now. And also, I think they are fighting for reducing the hysterectomy rate in adenomyosis. So over to you, madam, for your valuable comments. And
thank you, Professor. Thank you, Professor Shahana, for your kind words. Good evening to everybody.
Yeah.
In fact, wonderful sessions, a series of sessions. We are running with series of sessions, and in our session, in fact, Professor Eric, he could not attend the session, but we have had a very, I think, very wonderful and very thoughtful presentation. And everything has been described in the presentation. And we are also lucky enough that we have got Professor George Kakistin. He is very much familiar to us because of Enzian Classification, you all know. And answered confidently many questions, problem-oriented questions. So in fact, adenomyosis is a big challenge to the gynecologist as well as infertility specialist. And as pathogenosis is still not clear. And we also heard that. And in case of diffuse adenomyosis with enlarged uterus infertility, still the logical approach is open surgery, because by palpation we can recognize healthy myometrium adenomyotic tissue. So the main surgery actually we done in our practice, that is adenomyomectomy in case of adenomyoma. And though it is very often done in open surgery, but who has expertise should do it should do it by laparoscopy. But one thing is very important, that is prior to surgery, one has to define the border of the adenomyoma. So as the goal of surgery is complete excision, though it is not always possible, but through 3D ultrasonography as well as MRI help much. So that is one point. Another thing that is another point that we have heard from George Kakistin, that even by laparoscopy, using finger and scalpel, we can recognize the adenomyotic tissue. The important thing is that is complete excision or debulking, but reconstruction is very important. And fertility sparing surgeries, we know that though in a patient who do not have desire for pregnancy, the hysterectomy is the standard treatment for cure of the disease, for symptom relief. And those women who do not desire pregnancy, medical treatment fail, we should avoid, and we should consider hysterectomy for cure of the patient. But for patient who desire pregnancy, we have an option, fertility sparing operation. And that is, though you already know that bilateral uterine ligation, uterine artery ligation, that is effective for symptom relief, but may be associated with premature ovarian failure and iatrogenic infertility. So we have to think twice. This is one. And high intensity focused ultrasonography is effective. And also there is many reports of pregnancy, but it is not very suitable for diffuse adenomyosis. So in fact, hysterectomy, where a diagnosis, and you have mentioning that how we can avoid hysterectomy, that is, and we must know about the adenomyosis. And we must diagnose, though diagnosis is still difficult because there is no standard criteria by imaging or pathogenesis. Still, you have a scope to do MRI and to 3D ultrasonography for proper diagnosis. So that is important for all gynecologists as well as fertility specialists. And another thing that is important, in case of repeated implantation failure, one should go for doing 3D ultrasonography MRI, and sometimes adenomyosis is missing. So even that, and another, we can avoid hysterectomy because I think the vasopressin, use of vasopressin already mentioned by George Kakestein, and transient uterine artery ligation is not actual, very few report. So not very popular or not very evidence-based. So in that case, by using vasopressin, we can minimize the bleeding, we can arrest hemorrhage, as well as patient may be in a stable condition. So in that case, most of the cases we avoid hysterectomy because of severe bleeding, and that is transformation of adenomyotic to hysterectomy. We can avoid. This is one. And awareness of the people, gynecologists, and most of the patients, when they are in fact not improved with medical treatment, many gynecologists without, and that is Diagnose, that is progesterone, 4th generation progesterone is a very effective drug in case of adenomyosis. So in that case, we have to go for the first, now you should select that drug, and we have to try to use the drug for treatment, those who have having symptom, menorrhagia as well as dysmenorrhea. So I think this is a wonderful session, and we have been benefited. There is a lots of question comes, and very confident answer we got, problem-oriented question as well as answering. And I express my sincere thanks to Professor Eric Tupi as well as Professor George Kakestein for wonderful contribution in our session, and we have been benefited a lot. At the same time, I like to thanks to moderator for excellent moderation and articulated to make the session articulated throughout the session. And we have a expert panelists who were already a very known laparoscopic surgeon and answers many questions, and also mention tips and tricks that can be used during surgery. Thanks to our panelists for their excellent answer. And I must congratulate scientific committee for their hard work and continuous effort, and also all endeavor that given to make this today's session, pre-conference session, that is a very practical session, and we have got many answers what to do, what not to do in adenomyosis surgery. I think this is a wonderful contribution from them. Thank you. Thank you,
Madam, for your nice and wonderful remarks. Dear audience, our session number 3 is, we are at the end of session number 3 of this pre-conference workshop. And before saying goodbye, I would like to appreciate and thanks our honorable speakers for his excellent presentation, and which was enriched our knowledge enormously. And I would like to extend my special thanks to our honorable chairpersons, both of them, and our respected panelists to make this session so successful. Finally, last but not the least, our participants for their attention and patience for the session throughout the time. And now it's time to hand over the session moderation to Professor Parveen Akhtar Surobi. She is the General Secretary, Society of Endoscopic Surgery, Society of Bangladesh, for conducting the next session number 4. Over to you, Parveen. Thank you very much. Goodbye to everyone.
Thank you, madam. Thank you. Thank you, Professor George. With a short notice, you joined with us, sir. Thank you very much, sir. Our respect and gratitude to you, sir. Thank you.
Assalamu alaikum. Thank you, Professor Shahnara Chodri, for your nice moderation. Ladies and gentlemen, participants from home and abroad, Assalamu alaikum, and good evening to you all. I am Dr. Parveen Akhtar Shamsun Nahar. Welcome you all to the pre-conference workshop of first virtual International Scientific Conference of Endometriosis Adenomyosis Society of Bangladesh. This is 4th session. Our session topic is deep infiltrating endometriosis. Dear audience, in this session, we have our eminent speaker, Dr. Alan Stephen Constantin from Germany. We are honored to have Professor A.H.M. Tauhidul Alam, President, Society of Surgeons of Bangladesh, and Dean of the Surgery Faculty of Bangabandhu Sheikh Mujib Medical University, and Professor Saiba Akhtar. She is the past president of OGSB and now is the president of Female Pelvic Medicine and Reconstructive Society of Bangladesh. And we have 2 expert panelists, Dr. Dilruba Jeba, Executive Member, OGSB, and Professor Begum Hosneara, Organizing Secretary, OGSB. The speaker will have 30 minutes for presentation. If you have any question, please give it in the chat box, which will be discussed at the end of this session, if time permits. It is my pleasure to introduce the honorable speaker, Dr. Alan Stephen Constantin. He is the founding member and General Secretary of the Adenomyosis Academy. Dr. Alan Constantin is an endometriosis specialist and is a consultant and head of the Endometriosis Center in the Hamburg, Germany. He is a member of the European Endometriosis League and also the founding member of the Endometriosis Academy. He has large number of scientific works, voluntary works on endometriosis. Now I am welcoming Dr. Alan Stephen. Dr. Alan Stephen.
Hello, and thank you very much for the kind invitation, for the kind presentation. Of course,
welcome.
It would have been more interesting to meet you all face to face in Bangladesh, but due to the COVID situation, that's unfortunately not possible. So I'll start my topic regarding the endoscopic surgical therapy of deep endometriosis. And I think the first thing we need to acknowledge is that we still have an unacceptable delay regarding the diagnosis of endometriosis, somewhere between 4 to 11 years. This is the data that we have from Europe. And this is, of course, unacceptable, and we need more awareness and we need more proper diagnostic regarding endometriosis. Now, before talking about the surgical therapy of endometriosis, we need to talk about diagnostic, because without a proper diagnostic, we cannot have the optimal surgical outcomes. And there are 4 pillars of diagnostic, and we'll take them one by one, and then we'll start talking about the therapy. So the first one is the medical history. And what we did in our clinic is that we started to use questionnaires, which saves us a lot of time, and it's easy to do the follow-up on the patient. Then the second point is the clinical exam, which should always mean that we have to perform a vaginal inspection with a separate speculum in order to evaluate the posterior vaginal fornix, because that's one of the most typical localization for endometriosis nodules infiltrating the vagina, as you can see in the image in the video in the middle. Then the vaginal inspection should be followed by a bimanual and rectovaginal palpation in order to evaluate the rectovaginal space, the rectum, and the uterosacral ligaments, and also the mobility of the uterus. Then the third pillar of the diagnostic is the imaging. And the first question that arises is, do we really need imaging to treat surgically? And the answer is definitely yes, if we're looking for the optimal outcomes. Now, one thing we need to understand when we talk about deep endometriosis, we have to think about the iceberg. And this iceberg is actually representing the uncovering of the ignorance, because if without imaging and just performing the clinical exam and the laparoscopy, we would be able to see just the tip of the iceberg, everything that's above the sea level. And that means nodules that would infiltrate the vagina, and then lesions that are infiltrating the peritoneum, lesions that we see when we perform the laparoscopy. That's why imaging, it's important if we're looking to diagnose deep endometriosis nodules infiltrating the bowel, the bladder, the rectovaginal space, or even deeper, the nerves. And the first line imaging technique should be the ultrasound, and only in specific cases should be used the MRI. And there are important reasons to use imaging in diagnosis and staging pelvic endometriosis, because these patients need an adequate surgical management, counseling, adequate management of pain, and of course, an adequate management of infertility. So the diagnostic workup that we're using in our clinic, and probably in most clinics in Germany, or in the German-speaking countries, is the medical history, the vaginal inspection, the bimanual and rectovaginal palpation, and the ultrasound. And that means the transvaginal ultrasound, and very important for each patient with the suspicion of endometriosis, a kidney ultrasound. And this workup is actually sufficient for most patients. So further diagnostic like MRI or other investigations should be performed only in selected cases. Now, the transvaginal ultrasound has a lot of advantages. First of all, it's a tool in the hand of the gynecologist. It's a faster exam, it's cheaper, has less contraindications, it's repeatable, it's a dynamic examination, and it doesn't require any preparation at all. So this should be the first line imaging diagnostic, and it's mandatory for all surgery. And if the surgeon doesn't do any ultrasound, then the findings from the ultrasound should be demonstrated to him by an ultrasound specialist in endometriosis. And this guarantees a reduction of unnecessary repetitive interventions, because this is actually a big problem. Performing an insufficient intervention which causes more adhesions and makes the next surgery, which should be a complete surgery, more difficult. Now, this is a case of a patient who came in our clinic last year in September. She had a previous surgery 10 months before. And the doctor who did the surgery documented that he removed all the endometriosis nodules from the ovaries, from the rectovaginal space, from the uterosacral ligaments. But the problem was, after 10 months, the patient still had pain and she couldn't become pregnant. She was 29, and when she came in our outpatient clinic, she was crying. And when I performed the vaginal inspection, I saw an endometriosis nodule infiltrating the posterior vaginal fornix. And then when I performed the ultrasound, I found this diabolo-like nodule infiltrating the posterior fornix, the rectovaginal space, and the rectum. And this is something that's unacceptable. Yeah, 10 months of pain and 10 months of not being able to become pregnant, and furthermore requiring another extensive surgery. So this is what we found during the surgery. As you can see here, the posterior vaginal fornix was infiltrated. It had to be excised, and we also had to perform a segmental rectal resection due to the extensive infiltration of the rectum. So situations like this cause a significant impair for these patients, and they affect physical, mental, and social, emotional well-being. So that's why we have to admit that the best surgery is the first surgery, but we only see what we look for, but we only look for what we know. So in order to have the optimal surgical outcomes, we need a proper diagnostic. And for the proper diagnostic, language matters. And these are two important papers from the IDEA group and from the Musa group. They're open access, and I'm recommending it to everybody to read them if they're dealing with endometriosis, in order to speak the same language when it comes to the diagnostic of deep endometriosis and adenomyosis. Then language matters also when we have to document and diagnose endometriosis, because as you've heard before from Dr. Krentel and from Professor Kekstein and from Professor Tsupi, it's important to stage the disease. And this is something we can do before the surgery and after the surgery, even if we're doing ultrasound or performing MRI. And if we have the staging, it is easier to plan the surgery and say the surgery is going to take 2 hours or 4 hours, and the informed consent that the patient is going to sign is going to be strictly directed to the preoperative diagnostic. So declassification, it's important, and it was published in February, as you've heard before. We've been using it for more than 2 years, since when Professor Kekstein presented it in the EL Congress in Prague, and I'm recommending it to everybody to use it. Now, I won't be talking too much about adenomyosis because it was previously discussed by Professor Tsupi and also by Dr. Krentel. So I will skip this part regarding the adenomyosis and the Osada procedure and the reconstruction of the uterus. Now, talking about the surgical or the endoscopic surgical therapy of deep endometriosis, one thing we have to acknowledge is that the laparoscopy is the gold standard, and we'll take them one by one and discuss them. Now, the ovaries and the surgical therapy for the ovaries, we have mainly 3 techniques. The classical one is the stripping, which was very nicely presented by Professor Banu in our first session. So I will be skipping the videos presenting the technique. Then the second possibility would be the ablation using the argon beamer or the CO2 lasers. The latest study have proved that the CO2 laser has better outcomes. And the third technique would be the sclerotherapy, and everybody's looking forward to the papers that are going to come in the next years from France regarding the sclerotherapy using alcohol for the big endometriosis cyst. But until then, I think the stripping technique using as less energy as possible is at the moment the standard. Then when it comes to the diagnostic and surgical therapy of endometriosis cyst, quite often I've heard the saying, this is just an endometriosis cyst, but it's quite seldom that you're going to find just an endometriosis cyst. And this is a very nice paper from Caterina Exacustos from Italy, showing that in less than 50% of the patients from this group who had an endometriosis cyst didn't have any other ultrasound signs of endometriosis. Then there's another paper from Charles Chapron saying that in less than 1% of their group, there were patients having an isolated endometriosis cyst. So in my opinion, and not only the term isolated ovarian endometrioma is a myth and it's not a reality. So whenever you get to deal with an endometriosis cyst that you've diagnosed, you need to look further because the surgery might be more complicated. And this is a video showing how we perform the ablation in our clinic for the endometriosis cyst. The indication for using the ablation is different from patient to patient, but we usually use it for small endometriosis cyst, and especially for patients who had a previous surgery on the same ovary in order to reduce the risk of reducing the ovarian reserve. Now, moving further to the anterior compartment involving the bladder and the urinary tract. The bladder is best scanned if it contains a small amount of urine. So the endometriosis nodules infiltrating the bladder wall are easy to diagnose. Here are a couple of examples from ultrasound and from a cystoscopy demonstrating a 2 centimeters endometriosis nodule. This is another example from our clinic. And one thing we need to know when it comes to bladder surgery is that the bladder is the most forgiving organ. So as long as you saturate the bladder after removing the nodule and keeping a bladder catheter for 1 week, then you shouldn't be expecting any complications. So it's an organ that's healing very well. Now, when it comes to the ureters, they're also easy to visualize in the transvaginal ultrasound. And this is important because when it comes to endometriosis nodules involving the ureter, you need to know what's the distance between the ostium in the bladder and the nodule in order to plan the best surgery. And using the transvaginal ultrasound, you can follow the ureter up to the crossing with the uterine artery. And if there are any nodules, like you see in this case, involving the bladder, then you can see there's a distance between the nodules and the ureters. So in this case, you wouldn't expect that you have to perform a psoas hitch or a Boari flap. Now, this is a case of a patient who came in our outpatient clinic with 2 endometriosis nodules on the bladder dome. And this is a small video showing how the surgery was performed. There are surgeons who prefer to excise the nodules after filling the bladder with 150, 200 milliliters in order to visualize better the nodules. But as you can see in this video, if you manage to see them and you pull, and then you won't have any problem removing the whole disease. One thing that's important when it comes to the suture of the bladder, especially when you have to perform an extensive suture, you need to mobilize the bladder in order to have as less tension as possible in the suture involving the bladder wall. Now, regarding the technique each one uses to suture the bladder, you can do it in one layer with a barbed suture, in 2 layers or 3 layers, depending on your experience and how you prefer it. We usually do it in 2 layers, and after each layer, we check the bladder to see if there is any leakage, and we usually test it with 200 milliliters. So it's usually a running suture with Vicryl or PDS, which is the cheaper version. The other way would be with the barbed suture, but as we know, they're a little bit more expensive. Now, this is another example of a patient with urethral endometriosis, which is about 2 centimeters far away from the bladder ostium. If you do not manage, or if you're not able to see the endometriosis nodule transvaginally using ultrasound, as I said before, it's very important to perform for each patient with the suspicion of endometriosis a kidney ultrasound, because hydronephrosis can be an indirect sign of urethral stenosis. And in each of these cases, probably it's better from a forensic point of view also to perform near scintigraphy in order to see how is the function and have the preoperative value and then repeat it after the surgery. Now, this is an example of a patient with an endometriosis nodule infiltrating the urethra. As you can see in this case, the excision of the nodule is performed using cold scissors. Energy should be avoided at all costs when you have to perform surgery on the urethra due to the vascularization of the urethra in order to avoid a late thermal damage that could cause a leak or a stenosis. This is let's say, a fortunate case where the endometriosis nodule could be completely removed using cold scissors. If the endometriosis nodule is infiltrating the urethra deeper, then of course a segmental resection of the urethra with an end-to-end anastomosis has to be performed, and the double J catheter has to be placed for at least 6 weeks. Now, moving further to the other compartments, when it comes to vaginal and rectovaginal space endometriosis, as we discussed earlier, the vaginal inspection is very important in order to visualize nodules like these ones, and then it should be followed by the bimanual and rectovaginal palpation, and of course by ultrasound, in order to be sure that the nodule that we're seeing over there is not just the tip of the iceberg. So whenever we have to deal with the nodule that's infiltrating the vagina, there are 2 possibilities. The first option would be to start the surgery transvaginally, and that's actually what we prefer. And in this case, we mark the nodule with a thread. We do a hydrodissection, and we start to do a circumcision of the nodule, which by going about 7-8 millimeters in depth, which makes the dissection easier when we move to the laparoscopy. And this allows us to do a limited resection, but at the same time be sure that we will be removing completely the endometriosis nodule that's infiltrating the vagina. And the other possibility would be, of course, to perform the whole surgery laparoscopically, and then with a finger in the posterior vaginal fornix, touch the nodule and see how is the anatomy and perform the excision. Now, one thing we don't have to forget when we deal with endometriosis nodules that are infiltrating the vagina is that we have to do something with the uterus. And there you have two possibilities, either using a uterine manipulator not to lose gas when the vagina is opened, or perform a uteropexy and suspend the uterus and then place a catheter, for example, in the vagina, not to lose gas when you open the vagina. Here are a couple of examples of endometriosis nodules infiltrating, as you can see here, just the posterior vaginal fornix. This is another case of an endometriosis nodule infiltrating the posterior vaginal fornix and the rectal vaginal space, but not infiltrating the rectum. And this is a short video showing how this endometriosis nodule infiltrating the posterior vaginal fornix and the rectal vaginal septum, as well as the uterosacral ligaments, was excised. And down there, you can see there is a written "so sure." This is something I heard from Shaheen Kazali from UK. This is actually standard procedure, what you should perform for each surgery. So sure stays for sigmoid dissection, as you've seen before, followed by ovariolysis, by mobilizing the ovaries. In this case, there is a small endometriosis cyst, and the ovary was attached to the lateral pelvic sidewall and to the uterosacral ligament. In this case, because the endometriosis cyst was small, under 2 centimeters, we performed just an incision and a lavage. Then suspension of the uterus, of the ovaries and the uterus, if you don't have a uterine manipulator. As you can see in this video, we use a straight needle with a PDS thread. And we suspend the ovaries, depending on what kind of surgery we are performing on the ovaries, for 2 to 3 days. Then we perform the ureterolysis. Maybe what would be interesting to discuss regarding ovariolysis, because earlier we discussed the surgical therapy of endometriosis cyst. As everybody said before, we should try to use as less energy as possible when we're dealing with endometriosis cysts. And something that we're doing in our clinic in order to do the hemostasis is that after removing the endometriosis cyst and stop the bleeding, we perform the ovariolysis, but at the same time, with the same thread, with the same needle, we're going 2 times or 3 times through the endometriosis cyst, through the ovary actually, and we reconstruct it. And then we leave it for 3 days, and after 3 days, we just cut the threads. And now, as you can see, dealing with endometriosis nodules infiltrating the posterior fornix or the rectal vaginal space, it's quite helpful to place, as you've seen before, a gauze on a clamp in the posterior vaginal fornix in order to get some distance between the posterior vaginal fornix and the rectum. Now, having to do surgery in places like this, it's very important to find and develop the rectovaginal space. And the safest and easiest way to do it, as you can see here, is to start doing it from laterally by opening the pararectal space. And as soon as the rectovaginal space has been developed, then it's easy and safe to dissect the rectum from the posterior vaginal fornix and free the rectovaginal space completely. And as soon as the rectum is distanced, then the surgery, it's easy and the excision can be completed. Now, in this case, I try to remove the lesions unblock. I didn't want to remove first uterosacral ligaments and then the lesion infiltrating the vagina. So as you can see here on the left side, it looks like an epsilon. Now here you can see after performing the colpotomy, that's the thread with which I marked the lesion infiltrating the vagina. And there you can see the dissection that was performed first exclusively through the vagina. And after removing the whole tissue and the disease and placing it in the vagina, the vagina can be closed in a standard procedure with a double layer running suture with PDS or Vicryl, depending on the material that you have in your clinic. Now, as we've seen earlier, the patient also had 2 small endometriosis lesions on the diaphragm, which were superficial, and they could be completely be excised. Of course, there are situations when the endometriosis lesions infiltrating the diaphragm go deeper, and the diaphragm has to be opened. In this case, new trocheries have to be placed. The colleagues from anesthesia have to take care of the right lung and not insufflate it. At the end of the presentation, we'll get to see also a small video from the colleagues from thoracic surgery performing that procedure. What we always do when we have to do extensive peritonectomy in Douglas, we started to use a couple of years ago some adhesion prophylaxis substance, and until now we have very good results. Now, moving further to the bowel, the deep endometriosis surgery of the bowel is one of the biggest challenges from a surgical perspective. And that's because of the complications that may arise, because the deeper, or let's say closer to the anal orifice the lesion is, the more problems may arise. And the problems that usually arise are the anastomotic leak or a rectovaginal fistula when the vagina has to be opened and when the suture lines are close to another. Now, in more than 66% of patients, or let's say more than 80% of patients, the endometriosis nodules infiltrating the bowel are localized at the level of the rectum, rectosigmoid, or sigmoid colon. So the appendix and small bowel are actually rare locations. On the other hand, there are in up to 50% of cases multifocal lesions, and a very nice paper from 2020 from Horace Roman and Nancy Martin shows that in 25% of cases, there are other bowel nodules that can only be identified by palpating. So this is another thing that we need to consider, and we're looking forward to have new papers to see if these other nodules that can only be palpated have any clinical consequences. Now, when it comes to the treatment of colorectal endometriosis, we have 2 possible approaches depending on the size and localization of the nodules. So first, we have a conservative treatment. And in this situation, we have the shaving and disc excision. The shaving can be performed in a traditional way or a reverse technique. Then we have the disc excision when the shaving is not possible, or let's say not enough. And in this case, there can be performed an excision and then a suture of the bowel, or disc excision using a circular stapler, or the run technique from Professor Roman using the contour star stapler. Now, when it comes to multiple endometriosis nodules or big endometriosis nodules, which cannot be excised using the conservative treatment, then radical treatment has to be performed. And radical treatment means a segmental colorectal resection, which can be performed in a conventional way, or performing an exclusively minimal invasive natural orifice specimen extraction surgery with an end-to-end or a side-to-end anastomosis. The facts are that hormonal treatment does not eradicate endometriosis. It just relieves symptoms only during treatment. So quite often surgery is necessary when it comes to endometriosis involving the bowel. Now, the rectal shaving has few complications. Few patients have new symptoms after the surgery. There's a minimal improvement. On the other hand, regarding constipation, the recurrence rate is higher than disc excision or segmental resection, 5 to 10%. This is actually the first-line treatment for small nodules without infiltration of the submucosa, and the nodules that are limiting infiltrating the serosa and muscularis, usually nodules under 2 centimeters. Now, this is an example of a shaving of the rectal sigmoid tip nodule. This is a technique that each one should be able to perform it because it's part of the disc excision technique. In our clinic, we're not big fans of this technique because what does shaving actually mean? How deep do you go, and how sure are you that you have removed everything? Then the disc excision or the full thickness excision has a couple of advantages. There's no section of the mesorectum, there's no reduction of the rectum, there's no stenosis of the rectum. So compared to the segmental resection, has a lot of advantages. Now, here are a couple of drawings from Professor Hans Tinnenberg showing the disc excision technique. So after the bulk of tumor has been removed by performing the shaving, there's a small remaining endometriosis disease on the anterior wall of the rectum. After performing the shaving, this nodule can be marked with a thread. We usually perform a running suture from side to side in order to be able to push the lesion in the circular stapler. So using 2 needle drivers, the nodule is pushed, as you can see here, in the circular stapler, and is going here in this cape, which can carry or host about 10 milliliters. So even big nodules find their way there inside. And what's actually removed is just like a, I don't know if you're familiar with the Italian pizza. This is a pizza calzone. And that's actually what's being pushed inside of the circular stapler. That's actually the tissue that we're going to see after performing the excision. So here is such an example of a patient with an endometriosis nodule infiltrating the torus uterinum, posterior vaginal fornix, and posterior cervix wall. As you can see here, the ovary is attached to the pelvic side wall. So of course, we start with ovariolisis and mobilization of the ovary, performing the suspension. And then moving forward and mobilizing the rectum from the posterior cervix. But first, as I said before, in the previous video, the pararectal space has to be opened because this is an avascular space. It's lateral to the rectum. There aren't any big vessels or important nerves that may be affected. So first, it's important to remove the nodule from the posterior cervix. and start from ventral to dorsal, and do a shaving of the posterior vaginal fornix, opening the vagina or not, depending on how deep the nodule infiltrates that. And as I said before, we usually place a gauze on a clamp in the posterior vaginal fornix in order to understand the anatomy better. So after removing the nodule from the posterior cervix, then we managed to isolate the nodule on the rectum. Here you can see that the rectovaginal space has been further developed. So that's the rectovaginal space, and up here you can see the gauze on a clamp placed in the vagina. So now starts the disc excision procedure, and the first step is the shaving. And the shaving has to be as deep as possible in order to have as less volume on the rectum remaining in order to be able to get everything inside the circular stapler. So this is the shaving using the ultracision. We're lucky enough to be able to perform surgery with a harmonic scalpel for all the interventions involving deep endometriosis. Now, after performing the shaving, you can see there is a residual area here on the rectal wall, which still has to be excised in order to perform a complete surgery. So this is the area that has to be removed, and then the traction suture using Vicryl is placed on the lesion. And depending on the size of the lesion, you can perform a running suture or just two simple sutures and then just push them dorsally. Now, this is the circular stapler, which is being introduced, and it's open. Here you can see the oral part of the circular stapler over here, which is being pushed in the rectum, and then using two needle drivers or two clamps, as you can see in this situation, the area from the rectal wall, which has the remaining disease, is being placed inside. And up here you can see the lesion that was excised. Then after removing the circular stapler, we perform a leak test, and depending on the quality of the suture, if we have the feeling that there's too much tension in the suture, another suture can be placed over the staple line for more, let's say, security. And then we do the leak test. And if everything is fine, we leave it like that. Now, moving further to bigger endometriosis nodules that cannot be removed surgically using just disc excision. In this case, segmental resection has to be performed. So as we discussed earlier, there are more possibilities. There's the conventional technique, and then there's also the possibility to perform a nose procedure that I'm going to show you in detail. Here are a couple of examples from ultrasound demonstrating multiple endometriosis nodules infiltrating the rectum. This is another example of a diabolo-like nodule infiltrating the posterior fornix and the rectum. Here is another one. This is the typical image of the iceberg. the picture that we've seen earlier. So here you can see that the A compartment, according to the hashtag Enzian Classification, is involved, and also the C compartment. Now, the segmental resection has to be performed when the shaving or the disc resection are not adequate due to the depth of infiltration, the size, and the number of lesions. So in this case, segmental resection is performed, which can be done using the conventional laparoscopic bowel resection, which is a well-established procedure and is being used in most centers. A couple of years or more, we started to perform a natural orifice specimen extraction, segmental resection of the endometriosis nodules in order to avoid the mini laparotomy during the laparoscopic procedure. And this is a technique that I'll show you step by step. So one thing we have to understand is that as endoscopic surgeons, we should try to avoid even a mini laparotomy. So this is a picture from the conventional method where the incision from a trochary is being enlarged in order to get the rectum out through the abdominal wall and resected outside of the abdominal cavity. Here are a couple of pictures from Professor Tinenberg, a couple of drawings from him. So whenever the shaving or the disc excision is not a good option, then the tumor can be excised laparoscopically. Then the anvil from the circular stapler can be introduced via the anal route, and at the same time the tissue can be removed. And after that, the aboral part can be stapled. The oral part can also be stapled, and the anvil can be placed in the oral part in order to get an end-to-end anastomosis or side-to-end anastomosis, depending on a couple of aspects that we're going to discuss further. Now, the nose approach starts in a standard procedure by performing a nerve and vessel sparing, or let's say respecting tubular dissection, staying as close as possible to the rectal wall in order to preserve the meso, which is important because it's carrying vessels and nerves. Then the second step is the intentional excision of the endometriosis nodule and the opening of the bowel. And this technique offers the advantage of performing a limited resection because we're just excising that part of the bowel that we can palpate using our instruments, and we can do a limited resection. Now, after excising the endometriosis nodule, through the rectum, transanally, the anvil from the circular stapler is being introduced, and at the same time, with the same clamp, the endometriosis nodule or nodules that were excised can be removed also transanally. So in this way, a mini laparotomy is being avoided, and the operation can continue exclusively minimally invasive. Then, depending on the distance from the anal verge and the endometriosis nodule, whenever the nodule is under 15 centimeters, then we perform a side-to-end anastomosis. And as you can see here, the anvil is placed on the antemesenterial side of the bowel. After placing the anvil, then the surgery continues with the stapling of the oral and aboral part. For that, we usually take the 60 millimeters endogia with the violet color, which has 3 lines of stapling. which is fine for the oral part. For the aboral part, sometimes just 60 millimeters magazine is not enough. And then we have to use another 30 millimeters magazine, as you can see. Yes?
Dr. We have already up the time. Will you please finish it in 2 minutes?
Yes, I will do my best. So after stapling and performing the circular stapling, leak test is being performed. And when everything is fine, then a protective ileostomy is not necessary. So this is something that we perform very rarely, only in cases of nodules that are very, very deep and very close to the anal verge. The other possibility would be to perform a segmental resection using performing an end-to-end anastomosis, and this is something that we do whenever the sigmoid colon is involved. So the technique is more or less the same. It's just that on the oral part of the bowel, we're performing a purse string suture, and then we place inside the anvil, as you can see in this case. And then the surgery continues as you've seen before, and we do an end-to-end anastomosis. There are also cases with multifocal colorectal endometriosis, which can also be performed using the same technique. So this nose approach for rectum and sigma resection is safe and burdened with few complications. It avoids a mini laparotomy and wound-related complications. It avoids a transvaginal approach for the specimen retrieval and also avoids extensive mobilization of the sigma. And it's using only 4 trocaries, which is also has a paramount importance for the patients, given the fact that everybody's looking for the aesthetic nowadays. There's also the possibility to open the vagina and pull the rectum through the vagina, resect the part of the rectum that's not healthy. This is a technique that the surgeons usually prefer. But opening the vagina, it's another risk factor for developing an anastomotic leak. So then I guess I will skip the part involving the nerves, and I'll move to my conclusions. So deep endometriosis is often surgically challenging, and preoperative diagnostic with the transvaginal ultrasound in the first line can improve the planning of the surgery as well as the surgical outcomes. The need of the patients direct the surgery, and therefore a plan must be done before the surgery. We should be prepared to deal with urinary and also digestive tract involvement. And last but not least, we should also need an interdisciplinary team with the colleagues from urology and general surgery, which are specialized in this disease. And I also like to take the opportunity to invite you to our EL masterclasses that are coming still till the end of the year and the beginning of the next year, to the EL webinars. Next one is going to be on the 19th of October. And next year, I'm looking forward to see you in June in Bordeaux for the 6th European Endometriosis Congress of the European Endometriosis League. Thank you very much.
Thank you, Dr. Alan Stephen. This was a wonderful presentation. I'd be very happy if we could have enough time to show your presentation. And normally, endoscopic surgery is done all surgeons, but in case of deep infiltrating endometriosis, it needs mastery in the anatomy and the surgical techniques. I have 2 questions to you.
Yes.
Do you need patients with deep infiltrating endometriosis should be referred in other specialized centers for the surgery? Because normal gynecologists who are doing simple laparoscopic surgery are not able to do this type of surgery, and also we need the training. What is your opinion?
Thank you for the question. I don't think there is simple surgical treatment for endometriosis. I think each patient with suspicion of endometriosis should be referred in an endometriosis center. What we started a couple of years ago here in Europe, we started to have a system that certifies endometriosis centers given different standards. So in this way, the patients are referred strictly to these centers in order to improve the quality of the treatment. So it's not just a question of performing a good surgery for deep endo. It's the whole concept, because we all know that endometriosis, it's a very complex thing. And as I said in the beginning of my presentation, of course, surgery is important, but in order to have the optimal surgical outcomes, we need to have the proper diagnostic. So nowadays we have good surgeons, or let's say surgeons who have the best circumstances to develop their skills towards deep endo. But what's actually missing at the moment, we don't have a proper diagnostic. And the solution, it's in front of our eyes, and that's the transvaginal ultrasound. We use the transvaginal ultrasound on our first day when we start our training, but there is no training for the ultrasound diagnostic for endometriosis. And I think that's the key point in order to diagnose better these patients. And after having the proper preoperative staging of the disease, then we can refer them to those doctors who can perform good quality surgery for deep endo.
Thank you, doctor, for your nice demonstration, and kindly keep giving your best to the world.
Thank you.
Now, I'll take expert opinions from two eminent panelists. My first is Dr. Begum Hosne Ara. The question is to Professor Dr. Hosne Ara: how can we avoid the complications during surgery of deep infiltrating endometriosis?
Thank you, Dr. Shurubi. Respected chairperson, participant from home and abroad, Assalamu alaikum. Good evening. Thank you, Dr. Alan Stephen, for his nice and elaborative and informative presentations. Thanks, Dr. Shurubi, for your nice question. Deep infiltrating endometriosis is a highly invasive form of endometriosis. Endometriotic nodule in the rectovaginal septum, uterosectal ligament, bladder, ureter, and bowel, and also in the uterovesical fold. Full assessment and proper preoperative history, examination, and mapping of anatomical site and depth of lesion by accurately precision, and transvaginal sonography and MRI, cystoscopy, IVU, rectosigmoidoscopy. Lastly, the laparoscopy is the gold standard for diagnosis and management of deep infiltrating endometriosis. Can you hear?
Yes.
Okay.
Yes, madam.
Okay. And also counseling the patient and advantage or complications of surgery. Before surgery, bowel preparation and bilateral ureteric stent, if hydronephrosis, for prevention of complication during surgery. Main principle of surgery is radical excision of deep infiltrating endometriosis, can be time demanding. Surgeon should be balanced her skill and expertization against the anticipated difficulties and duration of surgery. In deep endometriosis, surgery is challenging and complication prone. To avoid the complication during the surgery, the good visualization of the pelvis and adequate instrument and uterine manipulator must, and also the plane of cleavage between the bowel from lateral wall and also freeing the ovary. Nodule in the ischial spine, carefully dissect can be because of massive hemorrhage, which can be difficult to control. Dissection of the vagina to remove the endometrial nodule through the posterior vaginal fornix. Already Ellen Stephen showed this. Both ureters should be identified and endometriotic nodule being dissected after the ureteric stent. Bladder endometrioma removed as a full thickness of resection followed by suture of the bladder and the catheter for 7 to 10 days. The perioperative, if there is a perioperative diagnosis of injury in the bowel, bladder, or ureter, should be repaired at the same time, and postoperative strictly follow up the patient. Postoperative strictly follow up the patient. Sometimes urinary retention and bowel dysfunction due to injury of the parasympathetic nerve. So nerve sparing surgery must be done. Peritonitis, and also develop 2 to 3 days after develops the peritonitis, which is maybe due to the bowel perforation. Sometimes deep dissection may cause the rectovaginal fistula, vesicovaginal fistula, and ureterovaginal fistula that can be removed as postoperatively. The deep infiltrating endometriosis is a complex condition requiring the multidisciplinary approach in tertiary center. Full preparation and planning and counseling of the patient about the advantage and complication of this surgery. And this is the radical excision of deep infiltrating endometriosis involving both bladder and bowel appears to have a good success rate, low recurrence rate, improvement of fertility, and improvement of quality of life. Thank you, Shurubi.
Thank you, Professor Begum Hosniara, for your elaborate presentation and answering. Now, our second panelist is Dr. Dilruba Jeba. Our question is, what should be our follow-up protocol of patients with deep infiltrating endometriosis after the surgery? Madam. Dr. Dilruba Jeba.
Madam, unmute yourself, please. Sheba, madam.
Okay.
Yes.
Okay, can you hear me? Okay,
yes.
Thank you.
Yes. Now
Respected chair, distinguished speakers from home and abroad, and a learned audience, Assalamu alaikum. Through this session, we have learned about the deep infiltrative endometriosis a lot. And now the question is about the postoperative care and the follow-up. Before going for the postoperative follow-up, we should keep in mind the immediate and remote complications. Immediate complications are basically related to the difficult surgery like excessive hemorrhage, urinary leakage, and anastomotic insufficiency of gut. So in early follow-up, we should keep in mind these complications and related complaints. And for the long-term follow-up, the things to be evaluated, that is the relief of the pain, the recurrence rate, and the fertility rate. To assess the pain relief, we should keep in mind about the question regarding dysmenorrhea, chronic and the cyclical pelvic pain, dyspareunia, and the dysuria and dyschezia. And we know we are using the visual analog scale and the numerical rating scale usually to assess the pain relief. It is a question whether the postoperative hormone therapy is mandatory or not. European Society of Human Reproduction and Embryology guideline shows that there is no benefit of hormone therapy to relieve the pain, but we can use the hormone therapy to improve the fertility rate and to reduce the recurrence rate. For assessing the recurrence, it is usually showing that 5 to 25% of the recurrence is following after surgery within 2 to 3 years. And the patient must be kept in follow-up like 1 month, then 3 months, and 6 months, and then up to 2 to 3 years or more if it is needed. And each follow-up, we should go through the detailed history of the patient, and we will go for the investigations, and before that for the clinical examinations, especially to see the pouch of Douglas and the involvement of the rectovaginal septum and the infiltration of the rectum with the transvaginal ultrasonography. And if needed, we can go up through CA125 or MRI. The fertility rate and the various studies shows that different studies shows that the fertility rate is about, it takes about 2 to 3 years, most of the fertility. So those patients who are concerning for the fertility, they should go or they should try for the fertility immediate after surgery. Another thing is that the menopause, because many of the patients are going to the surgical menopause after the hysterectomy, and these patients should take the hormone replacement therapy. And the clinician should be kept in mind that this hormone replacement therapy should be either estrogen or progesterone containing or bitimolone. Unopposed estrogen, it should be avoided after surgery of, that is the hysterectomy after endometriosis. Finally, throughout the postoperative care and the follow, psychological aspect of the patient and their family should be cared with empathy. Thank you, Dr. Shruvi. I think my learned teacher can add something more if I missed some important points. Thank you so much.
Thank you, Dr. Dilruba Jeba. You elaborately said about the follow-up, which we usually ignore. Now, I am requesting our chairpersons for their remarks. Our first chairperson is Professor A.H.M. Tawhidul Alam, sir. Sir, you are with us.
I'm with you.
Sir is the president of Society of Surgeons of Bangladesh and also the Dean of Surgery Faculty of Bangabandhu Sheikh Mujib Medical University. Sir, you are always with the gynecologist. When we are in problem, we always get your help. What is your experience about the deep infiltrating endometriosis surgery in women?
Thank you, Dr. Shruvi, for your kind introduction. First of all, I'd like to thank to the Society EASB for giving me the chance to chair this session. Actually, I enjoyed this talk by Dr. Ellen. I was thinking that I am enjoying a session of colorectal surgery or urological session, because this is an area where there is overlapping between gynecologist, urologist, and colorectal surgeons. So it is my humble request to our gynecologist, if you want to develop this area, because I think it is a very difficult area, as you have already mentioned, the safety, question of safety. So other surgery, laparoscopic surgery in gynae, you can do very well, but there is overlapping between different 3 subjects. So if you want to develop this subject in this country, please start with urologist or colorectal surgeon first. Then definitely it's not a tough job. I think everybody will be able to do it. With these few words and remarks, I again thank to the other 2 panelists, because they have already mentioned the details about this preoperative, perioperative management, preoperative management, everything. And Professor Begum Pustera has also already narrated everything. Dr. Dilruba also mentioned everything in this respect. So I don't want to waste your time. And I thank again to my co-chairperson, Professor Saib Akhtar, and Professor Dr. Parveen Akhtar Samsun Nahar for conducting this session. And very good wishes to everybody. Thank you very much. Thank you. Thank you.
Thank you, sir, for your short presentation. Now, I am requesting our second chairperson, Professor Saib Akhtar. She is the president of Female Pelvic Medicine and Reconstructive Society of Bangladesh. And she is also very known for vesicovaginal fistula and other fistulas in the females. Madam?
Thank you,
Madam,
Shruvi.
are you with us?
Yes.
Madam, please say something about this session.
Thank you, Shruvi. First of all, I like to thank the organizer for inviting me and giving the opportunity to be with you in this session. This is a wonderful session and definitely a very challenging problem for the gynecologist, for the urologist, and also for the surgeons, any endoscopic surgeons. I like to thank Dr. Allen because he has gone through very elaborately about the diagnostic process, what are the steps you should take for the diagnosis, and how the transvaginal ultrasonogram can help not only in the diagnosis, but also during the surgery. His lecture was really excellent and it was so elaborative, and he has shown through his videos how a endoscopic surgery so meticulously can done this challenging deep infiltrating endometriosis, can manage this deep infiltrating endometriosis. It will be good if we can get more time and to hear from him. My only concern, as Professor Tawhid also told, that this is really a challenging issue. You know, we always work in team. So this is a place where teamwork is very important. Team between the urologist, gynecologist, and also colorectal surgeon. And so that's very important. And my request to the young endoscopic surgeons, you please continue your effort to learn more, but not to be over enthusiastic, seeing Ellen to go and manage these difficult cases without the help of your other team members. I also like to thank our panelist, Dr. Begum Husniara. She nicely described about the how to prevent the complications and how to manage, and also Dilruba, not only for the follow-up, but also supplement some of the ways how to prevent the complications and then how to manage the complications. Thank you, Dr. Shurovi. I can't remember your proper name. And thanks the organizer once again. And it was my opportunity to be here. Thank you very much.
Thank you, Madam. You have already started Female Pelvic Medicine and Reconstructive Society of Bangladesh. I think this will be a very good platform from the young gynecologists to be with the other discipline and to be the surgeons of the pelvis. Thank you, Madam.
It will be my great pleasure.
Now, thank you, Madam. We are come to the end of this session. My thanks to the speaker for his excellent deliberation. Thank you, Dr. Allen Stephen, for your elaborate presentation. If we had more time, we will be very lucky to have your presentation.
Thank you.
It has enriched our knowledge enormously. I would like to thank the honorable chairpersons and the panelists to make the session so successful. Now over to the next session. Our next moderator is Dr. Samina Tanjim Chodri. She will moderate the 5th session.
Thank you. Thank you, Dr. Allen. Thank you for joining with us. Thank you very much.
Thank you, Dr. Nahar. Thank you, Dr. Shamsul Nahar. And honorable participants from home and abroad, a very good day to all of you. I'm Dr. Tanzim Samina Chodri. Welcome you all to the session 5 of the pre-conference workshop of first virtual international scientific conference of Endometriosis Adenomyosis Society of Bangladesh. The topic of this session, as you can see on screen, is how to approach laparoscopic hysterectomy in the frozen pelvis due to severe endometriosis and the options of robotics. Dear audience, in this session, we are honored to have with us Dr. Hafiz Rahman as our speaker. We also have two very eminent personalities, Professor Kohinoor Begum, who is an eminent obstetrics and gynecologist and national advisor of EASB, and Professor Shraddha Naim, President, ACLSB, and a renowned laparoscopic surgeon as chairperson of this session. And we also have with us very renowned laparoscopic surgeons of our country, Professor Abdul Qayyum, Organizing Secretary, EASB, and Professor Shamshad Jahan Sheli, Vice President, ACLSB, as expert panelist of this session. Welcome to both of you. Before the presentation, I just want to add that the speaker will have 30 minutes for his deliberation. If the audience has any question, they can send it to the chat box, and so that it can be discussed at the end of the presentation if the time permits. And I'm sure there will be more questions coming up. So without further delay, I would like to start the session by introducing speaker, Dr. Hafiz Rahman. He actually does not require any introduction. He is one of the most renowned surgeons in the field of endoscopic surgery. He is very well known to all of us in Bangladesh. His CV says he is the head of the Department of Obstetrics and Gynecology at Sunrise Hospital, former Vice President Images, former Honorary Joint Secretary FOXY, Vice President Indian Society of Minimal Access and Gynecological Societies of India, former Chairman, Young Talent Promotion Committee FOXY, Honorary Secretary, Indian Faculty of Endosonography and Endoscopy. And the most important thing is that he has performed laparoscopic surgery all over the world. And till now, he has successfully performed over 35,000 laparoscopic hysterectomies all over the world. So it is today my great honor and great pleasure to invite him for the presentation. The topic is how to approach laparoscopic hysterectomy in the frozen pelvis due to severe endometriosis and options of robotics. Over to you, sir.
Can you hear me now?
Yes, we can hear you.
Yeah. First of all, let me thank the Bangladesh Society for giving me this opportunity to be with you once again. Professor T.A. Chodri, I can see you. So nice to see you again. And I was seeing Saiba Akhtar and all officially also. So it was so nice to be back with you again after quite a long time. I think almost 2 to 3 years because of this COVID and other things. Now let us go to the topic. Let me just share the screen. Can you see the screen?
Yes, sir.
Okay, so this is basically, we will be today talking about laparoscopic hysterectomy and endometriosis. But before going to this topic specific, we should understand that hysterectomy in endometriosis is at times much more difficult than what we usually do in oncosurgery, that is the radical surgeries in the pelvis, because this is all stuck and completely altered anatomy, and it is more so difficult in cases of infiltrating type of endometriosis, because these are the cases where we ultimately land up in half-done surgeries. We'll just remove the uterus and keep the large chunk of infiltrating endometriosis, and the patient continues with the same symptoms even after removing the uterus. So before going into the endometriosis hysterectomy, I thought it will be better that we understand normally how hysterectomy is performed. We usually have the trocar at the palmar's point or little medial to the palmar's point, and we usually have 3 trocars. This is a very large uterus, I think something like 30, 34 week size uterus. So 3 trocars depending on the towards the lateral side, so that we 3 trocars depending on the size of the uterus and the attachment of the ligaments as such. So here you can see that this is a very large uterus. I'll just go through this little fast. You can see how the bladder is dissected. This method, we call it as a sunrise method of hysterectomy, where the entire manipulation is done with the myoma screw. Today, you will see that in our OT, no manipulation is done with the intrauterine manipulators. There are different types of intrauterine manipulators. and you will find that absolutely no manipulation is done with intrauterine manipulators. It's all done with the myoma screw. I know many of you in Bangladesh also are using the myoma screw, like Shelly and all of you. And you can see how nicely the bladder can be dissected. So once the bladder is dissected down, you can see there is a beautiful plane. And many times in endometriosis, this bladder plane will be the only plane which will be there in endometriosis. You can see the plane between the cervix and the bladder. And then you go taking the ligament. It's very simple to do hysterectomy in a normal uterus. We usually use the ligature. You can just go ahead taking the cervix and the this is the uterosacral ligaments. Before the uterine, we take the uterosacral ligaments so that the ureter will go a little more laterally. And this is where we take the uterine arteries. You can see how the uterine arteries can be nicely taken even in such a large uterus. We can combine with the harmonic and ligature, and then we go medial to the uterine artery. We go medial to the uterine artery like this. We stick on medial and we reach the Mercandor's ligament, as you can see here. Once we reach the Mercandor's ligament, cut it, and then you will find that you are on the vagina. You should understand the tissues. Once you understand the tissues, it becomes very easy to do it. You can see that we are opening the vagina. That's where you open the vagina. Once you open the vagina, put a grasper into it and lift it up so that you can take the posterior part of the vagina. Posterior part is taken like that, and till the other uterosacral. That is the beauty of sunrise method of laparoscopic hysterectomy. We take it till the other uterosacral ligament. As you can see, we take it almost to the other uterosacral ligament, and then we take anteriorly also, as you can see, and then we go to the other side. After completing fully on one side, then only we go to the opposite side, as you can see here. Now, points to be noted when you come to endometriosis is that number one, make the pelvis completely avascular. Number two is that most of the cases anterior will be free until and unless you have the bladder also involved. Number three is that three organ safety, the bowel, ureter, and bladder. These are the three organs which you have to keep safe when you approach a case of endometriosis. Number four is the lateral space is mostly available unless she has a rectovaginal infiltrating kind of endometriosis. Lateral space is not only for the bladder, but for the rectum also. I'll show you the lateral space of the rectum. Posterior lateral space, which will dissect the rectum very easily, even when you have severe adhesions on the fundus of the uterus. Now, infiltrating endometriosis needs resection, and adherent areas in endometriosis, when you do, has to be taken in the end. Most of the time you find that the anterior is completely free. So dissect the anterior completely and then go to the posterior in endometriosis. I will go to a hysterectomy case. As you can see, can you see the video? Can you see the video?
We can see. Yes,
okay.
We see, sir.
Now, this is a case with severe adhesions. As you can see, initially you cannot see the uterus. So in these cases, one of the most important thing I said is to render the field completely avascular. So how do you render the field completely avascular? Number one, injecting vasopressin. Inject vasopressin into the uterus with 20 units of vasopressin in 100 ml of dilution so that you have a completely avascular field. Number two is that you can go and clip the internal iliac vessels on both sides, which will also make it completely avascular. Here you can see, but at the same time, you cannot see the uterus as such. So we are dissecting down, you can see a large cystic organ there. And you can see that there is a large cystic organ. This is actually a dermoid cyst. where she had actually a diverticulosis of the rectum and a fistula into the dermoid cyst, which was producing again more amount of pelvic abscess also other than endometriosis. So we are just dissecting the, you can see the fallopian tube there. That is the infundibulopelvic ligament. So you are dissecting slowly the bowels down, as we can see here. And that is where we are injecting. Once the uterus has come into vision, we have started injecting the vasopressin, as you can see here, to make it more avascular. Then we start dissecting again. And this is where we are clipping the internal iliac or cutting the internal iliac. That's the internal iliac vessel with the uterine origin of the uterine. Due to the paucity of time, I'll go a little fast. That is where we are clipping the uterine artery. We are actually cutting the uterine artery, not clipping the internal iliac, and this is done on both sides. That is on the right. You can see here, you can see the ureter. That is the internal iliac on the right side. So once the internal iliac is clipped on both sides, it becomes much more easier to operate. The second thing is you take the, if you are removing the ovaries, you take the infundibulopelvic ligament. So internal iliac or uterine taken, vasopressin injected, infundibulopelvic ligament cut. These are the first steps which you can do after you see the uterus. We did the additional lysis initially because we could not see the uterus at all. Now, after this, the pelvis is rendered completely avascular and it becomes much more easier for you to operate. This is the infundibulopelvic ligament on the left side. Now here you can see that now it becomes much more easier to operate. Now the next step is to safeguard the ureter and the bowel and the bladder. That is where you need to do the dissection carefully. As you can see, we did the anterior first. You can see the anterior dissection is done first so that you can push the bladder down. That is the bladder being pushed down, and most of the time endometriosis doesn't affect the anterior. It mostly affects the posterior, so it will be much easier to push down the bladder. So once the anterior is done, then you can go to the posterior bowel dissection. You can see the entire bowel is plastered onto this with diverticulosis of intestine, and there is also a fistula of the intestine going into the ovarian cyst. Fistula diverticulosis producing fistula into the ovarian cyst is quite a rare case, but you can see that here. You can see that we are dissecting. You can see the endometriosis here, and this is the fistula. You can see how we are dissecting it down. You can see the fistula is opening here. Later on, we resected this part of the bowel also because it's a fistula with diverticulosis. But you can see how nicely it can be done laparoscopically. You can see the bowel dissection, and this dissection obviously is done with scissors. And that's the dermoid, and you can see the nice fistula here. Can you see that this is the bowel opening here? And we are dissecting it. This is not a fresh opening. This is a fistulous opening which was there previously also. And you can see the material, infected material in the dermoid. That's a fistula. Can you see that? We will close it later, but then we'll proceed with the additional lysis, as you can see here. And you can see that the additional lysis is much more easier when you do with a complete vascularity of the pelvis. A large part of this taken care by the vascularity of the pelvis. And then we are almost down posterior. As you can see, now you can see the uterosacral ligaments being taken as in the first case. You can see the cervix, and that is the uterine artery. We can straight away go with the harmonic in these cases of taking the uterine artery. You can see here, that is the vagina, which is open now. And once the vagina is open, you can catch on the cervix and pull it upwards, and then take the vaginal cuff, and then go to the opposite side and finish the procedure. You can see that. You can finish the procedure on one side completely, and then only we go to the opposite side because it has obvious advantages. As you can see here, I can see the cervix opening here. I can see the cervix here. So I just have to connect it here. It will become much more easier when you go from the opposite side and do the connection. As you can see here, that is the end of the procedure. After doing this procedure, obviously we need to understand, we need to see whether the infiltrating endometriosis is more there, and inspection of the pelvis is just hold on a moment. Now we'll go to the next, which is the posterior lateral window. This is very important. Once you have dissected the anterior and you have the entire, once you've dissected the anterior and you have the entire bowel stuck to the posterior. See here you can see the entire bowel is stuck to the posterior uterus. This is the lower part near the cervix actually. I just dissected the ureter. And this is the posterior lateral window. Usually we call it as the anterior lateral window in previous cesarean. So here you have something called as a posterior lateral window. That is the rectovaginal area. You can see that. See, that is the opening. Can you see that? The rectum will go down very nicely, and you can see the vagina there. So once you see the vagina, then we can go ahead and open the vagina, and you can do something called as a retrograde hysterectomy. A retrograde, you can cut the, it will be much easier. Once you open the vagina, it will be much easier for you to go ahead and do a retrograde procedure. As you can see in this case, we have not done the additional-lysis, we have not done the additional-lysis in the upper part. We are just concentrating on the cervix and detaching the cervix from the vagina, and then the uterus is delivered from the additions in the bowel. So this is how you take the posterior lateral window, and then you can see that how the vagina is open, as you have of course seen in the other cases. See, now it is much easier. Once the vagina is open, it is much easier to cut around and then take the uterus upwards like an antegrade procedure. Now, in some cases, you will find that the ureter is also extremely stuck to the uterus. In such cases, it's very important to do the ureteric dissection also. Can you see the ureter? See, that is the ureter which is completely stuck there. So you can dissect the ureter down, as you can see here. If it is not infiltrated with endometriosis, you will find that it will go down very easily. That is the uterine vein which is going down. You can see how the ureter will go down. This is the ureter here. See that? If it is not infiltrated with endometriosis, this is how ureter can go down. This is the ovarian cyst actually, which was stuck to the ureter, and we are just dissecting it down nicely. And then we'll go in and do the ligation of the internal iliac. That is the internal iliac, as you can see here. This is the internal iliac. So we will dissect around the internal iliac and then clip it with the ligation. That's the internal iliac. So make it completely avascular. See how you can see how the entire iliac can be clipped, and then the entire dissection can be carried out. So this is where we dissect the ureter out completely. And the posterior, you can see how the ureter goes. Once you dissect the posterior and then the anterior, it will become much easy. To safeguard the ureter, it's very important to first cut the uterosacral ligament. When you cut the uterosacral ligament, the posterior part of the ureter goes away. When you dissect the bladder down, the anterior part of the ureter goes away. Then when you cut the mecanthroids, the lateral part of the ureter goes down. So it becomes much more easier to do a hysterectomy if you think like that. See here, you can see the ureter here. I'm just safeguarding the ureter with my left hand, and then we are just dissecting it down here. As you can see that, see, this is the ureter going and entering into the bladder here. You can see that very, very clearly, ureter entering into the bladder. You can see how much deep that cyst has gone actually and got stuck in the pelvis. This is the ovarian cyst actually got stuck in the pelvis because of endometriosis. And this is on the other side also. We are taking the ureter, and then finally we come to the bowel. We don't come to the dissection of the bowel until we take the anterior and lateral. Usually the posterior bowel additions are taken in the end, not in the beginning. Because if you take it in the end, it becomes much more easier. This is a case where you can see a post-hysterectomy. This is what happens if you leave part of endometriosis during hysterectomy. You can see that the pelvis looks pretty clean, but at the same time, you can see here, when you see here, you can see there is a large mass here near the bladder here. Can you see that? This is the infiltrating kind of endometriosis. We have just removed the ovary. Now we are dissecting that mass out. You can see that the ureter, that is a round ligament which you can see, the ureter is completely stuck to that mass and going into the mass. So in such cases, what you have to do is you may have to resect that part of the ureter. Yeah, see, this is the ureter, which is completely stuck there. Can you see that? That ureter is going into the mass. We are just dissecting the ureter, and we could not go further than that. So what we are doing is we are just cutting the ureter from that area, and we will later on anastomose the ureter onto the bladder in a different area. See, that's the ureter. We're just dissecting it out. And you can see we are just trying to dissect the bladder, but you can see the mass is completely infiltrating into the bladder. And that's the ureter which you can see there. So we will cut the ureter from that area. You can see that mild hydronephrosis. And this is the ureteric opening here. So we'll resect with the ureter and part of the bladder. This is the rectum which you can see. That's the rectovaginal septum which we are taking. And we are dissecting it down, excising the complete vaginal vault as such, with, of course, part of the urinary bladder also. I'll go a little fast because I know my time is getting over. That's where we enter into the lateral vaginal wall. That's the area where you have to be careful regarding the nerves. And that is the bladder, that's a ureter here. And what we will do is we will do a cystotomy and find out how much. This is the bladder. Can you see the bladder? This is the vagina and this is the pelvic mass here. Now to understand the extent of the mass, you can see that we will do a cystotomy. That is a bladder where we are open the bladder. Now, once we cut open that bladder, you can see the endometriosis deep down, almost up to the ureter. Can you see the bladder endometriosis? This whole area is endometriosis. See that? So we are just chopping out that area. That's a ureter, which is completely edematous. So we are just chopping out that area. And that's inside the bladder. That's the other side ureter, which I was showing. So we'll take it out completely as such. So this is the kind of lesion which can actually happen if you leave infiltrating endometriosis with or without the ovary. Infiltrating endometriosis, please understand, it can still grow even without the ovaries. Even if you are not leaving the ovaries also, there is some amount of intracrine production of estrogen, and which will help the infiltrating endometriosis to grow. And you can see that we are just excising the mass completely. Once you excise this mass completely, you can see the bladder being repaired. You can see it's almost gone up to the urethra on this side. Can you see that? Almost gone up to the urethra, and we are just repairing the bladder. VLOC is fantastic to repair the bladder in such cases. And we will put a ureteric stent on the other side. And after closing this bladder defect, what we will do is we will mobilize the bladder from above. We'll mobilize the bladder completely from above, and then anastomose the ureter onto this bladder. That is where the bladder is sutured and taken in 2 layers. Then we will mobilize it completely from above. That's a bladder mobilized, and that's a ureter. Now we will take the ureter on top of the bladder. You can see the ureter clearly, and then pierce into this thing, pierce the bladder, as you can see here, and then anastomose the ureter. After fish mouthing, we are anastomosing the ureter there. And then take the posterior and then put a stent, and then we are taking the anterior sutures. That's where the ureter is anastomosed onto the bladder. It's very important to have a complete resection of endometriosis, otherwise it will keep on lingering on to you. It will never go away. Whichever organ is involved, you need to really resect that organ and take it out, whether it be bowel, bladder, or the ureter. You should always judge how much you should do. It's very, very important to judge how much of resection you should do. But as by principle, you should always resect it completely. This is how we wrap the bladder onto the ureter, so that the intravesical course of the ureter, inside the myoma, inside the muscularis of the bladder, you can see that how the bladder is wrapped on top of the ureter, so that you will find that the ureter actually goes through the bladder as such. Do I have time?
Yes, sir.
How much time?
5 to 7 minutes, sir.
5 to 7 minutes. Okay. Yeah. So this is another case where it's a lateral endometriosis. As you can see here, we are just dissecting. It looks like a very small endometriosis externally, but you can see a very large hydroureter, as you can see. I'll just go fast. That's a round ligament. You can see the ureter, which is there, completely adherent there. So these type of cases, you find that the ureter is gone hydronephrosis, hydroureter, because of the infiltration of endometriosis into the ureter. In those cases, don't try to save that ureter. You have to resect the endometriosis from that area. You are going laterally. Can you see that up to the pelvic side wall, dissecting it out? Here, what you see, this is the ureter. So we will dissect it maximum down and then cut the ureter from that area. See, that is a ureter here. Dissect it maximum down. And then we are doing it anteriorly also, see. So that's where we are ending with the ureteric dissection and cutting the ureter from there. We will fish mouth it later on. And you can see that now, see, this whole area is endometriosis. So this has to be taken completely when you are doing the hysterectomy procedure. You can see how much depth it goes. It goes down, that is the rectum, and this is the rectovaginal endometriosis. So resect it completely, as you can see. And laterally also, it's going almost half to the vagina. And that is a bladder dissected. And this is the ureter from the bladder, which we are detaching the ureter from the bladder, because only the part of ureter, the endometriosis was there, which was completely constricted. Then we'll go down here. See, this is here you can see the ureter going into the endometriotic mass. That's the ureter going into the endometriosis mass. See that endometriotic mass completely, and that's a vagina. Now we will open the vagina. See, we are shaving it on to the vagina. Now we are opened the vagina, and you can see how much of endometriosis is there in the vagina also. See, that mass is completely excised now. So this kind of an excision is needed in most of these cases of deep infiltrating endometriosis, or else you will find that it will just recur again. That is where you can see the vagina is also getting excised. You can see the involvement of the endometriosis into the vagina. So this complete has to be excised while you do this procedure. Even if you leave a small part of it, you will find that it keeps recurring. It keeps coming back again and again. And the second excision can be more difficult actually in many of these cases. So approaching this kind of endometriosis, it is always important to understand that it has to be taken out completely. If at all you are dealing with an infiltrating kind of endometriosis, it's important to understand that it has to be completely taken out or else, especially in cases where you are going to preserve the ovaries, it is going to come back again, and it is going to create more problem with infiltration into the bowel as well as the bladder. So when you go ahead and do a radical surgery on infiltrating endometriosis, be sure that you are always prepared to resect the ureter, rectum, or bladder with the uterus. Otherwise, you are going to get into problem. Just taking out the uterus and ovary and coming back doesn't actually solve your problem. So thank you so much for your patient listening.
Thank you, sir. We are just amazed. This was amazing surgical technique from you. Thank you, sir. It was a very wonderful deliberation, and it was a great learning experience for all of us. But their questions are coming up. So I'm coming up with 2 or 3 questions for you. Number 1 question is that after bladder resection, is the bladder capacity reduced after operation?
Yeah, bladder capacity definitely reduces, but it doesn't create much of problem with the patient. If at all the bladder is too much involved, it usually doesn't happen with endometriosis, but if at all it is too much involved, it can be augmented with small intestine. Okay. We can take part of the small intestine and augment it always at the dome.
Okay. There's another question is that if there's a large endometriotic nodule near a very large vessel, what do you do? How do you make it avascular?
Very large vessel, you mean endometriotic nodule onto the external iliac vein?
Yes.
Yeah, endometriotic nodule onto the external iliac vein. We have even gone and taken out part of external iliac vein. You can see external iliac, these large vessels like common iliac, external iliac are very large veins. So you can actually resect even small part injury occurs. It's okay. You can suture it very easily laparoscopically because it doesn't bleed that much like an artery. The problem is if there is an arterial involvement, artery involved, the large arteries like common iliac, external iliac, internal iliac is fine. You can clip it and take it out, but common iliac, external iliac, if it is involved, it's going to be a big problem. But it usually doesn't get involved up to the arterial intima. It just gets involved outside. But even taking the arterial musculature outside can lead to pseudoaneurysms. This is a big problem if you dissect the arteries very close in endometriosis. So even if you are dissecting it, don't forget to suture that artery. The outside of the artery, you have to reinforce. Like when you have a serosal injury to the bowel, you are reinforcing the bowel. Same way, you need to reinforce the arteries also if you are shaving the endometriosis from the arteries, or else you can land up in an aneurysm of the artery, not pseudoaneurysm, aneurysm of the artery.
Okay. Thank you, sir. And there's another question from Professor Laila. Is there any need for preoperative hormonal treatment to reduce the endometriotic lesion before surgery?
No, we do not want to give preoperative hormonal treatment in these cases because number 1, hypoestrogenism is not effective in infiltrating endometriosis. Because when you give any hormonal treatment, you are reducing the hormones from the ovaries. You are actually attacking on the hypothalamo-pituitary ovarian axis by any of the hormonal treatment available right now to reduce the estrogen. But this is not the estrogen which is actually with infiltrating endometriosis. Infiltrating endometriosis, even if you take out both the ovaries, infiltrating endometriosis will still grow because of the intracrine production of estrogen from the cells of the endometriosis itself. So hypoestrogenism doesn't actually work with endometriosis. It will still grow infiltrating. If it is the non-infiltrating kind of endometriosis, that is where hypoestrogenism can really work. So in those cases, of course, but in those cases also, if you give hormonal therapy, you will find that there is a lot of fibrosis which is occurring, basically healing. So we do not want it to heal like that and produce problems for our surgery. So we do not give any preoperative hormonal treatment. That is one reason. Now, second reason is preoperatively, we do not have a complete diagnosis. You need to have a proper diagnosis to give any hormonal treatment or any medical treatment. Endometriosis even today is a tissue diagnosis. How do you know it's not a malignancy? You are having a mass in the pelvis. You're not having a clear-cut endometriotic cyst. You are having a mass in the pelvis which is infiltrating into the ureter, bladder, rectum, and all those areas. So without having a clear-cut diagnosis, you cannot harp on a medical treatment. This is very, very important. So I feel there is absolutely no role for preoperative hormonal therapy in endometriosis.
Sir, in this type of patients, do you do preoperative cystoscopy and ureteric stenting?
Yeah, see, endometriosis, one of the most important things we need to do is a proper preoperative analysis, which is usually done by MRI when you deal with infiltrating kind of endometriosis. I'm not that comfortable with ultrasound because ultrasound anterior and posterior is okay, but lateral endometriosis is little difficult to understand. So in those cases, preoperative analysis is done. And if you see that there is loss of fat plane between the vagina and the bladder, definitely not preoperatively, during the surgery, we can go ahead and do a cystoscopy. And if you need to put in a ureteric stent, you can do that. But for ureteric dissection, we never put in a ureteric stent. Ureteric stent is put when you want to resect part of the bladder and you want to save the ureter as such, not for dissection of the ureter. Ureteric stent, illuminating ureteric stent, what you have like in the Stryker cameras, you can use the illuminating ureteric stent if you are not well versed with ureteric dissection to understand the course of ureter.
Okay. And so last question is that you have vast experience in laparoscopic surgery in different parts of the world, in different scenario, even in low resource setting. So what is your message to the beginners who want to do an endometriosis surgery laparoscopically? What is your message for the beginners?
No, see, there is no different surgery for beginners and experienced people. Surgery is the same for beginner as experienced people because patient is a patient. So it is not that the patient goes to a less experienced person, he or she does a different surgery. Patient comes to me, I do a different surgery. So we are doing surgery for the patient, so there is no difference in the surgery. Now, if you are approaching infiltrating endometriosis, I don't think it's like a locally infiltrating malignancy. Like if you are approaching an onco person, I don't think in a low resource setting it should be done at all. If you are approaching infiltrating endometriosis, you have to be a proper pelvic surgeon. Pelvic surgeon means you should be able to deal yourself with the bowel, bladder, ureter, and the genital organs. Then only approach infiltrating endometriosis. Or else what will happen is you will have one urologist with you, you will have one gastrosurgeon with you, and it will be actually a big mess. The gastrosurgeon doesn't know endometriosis, you don't know gastrosurgery. Urologist doesn't know what is endometriosis, but you don't know what is urology and ureter. So it should be a pelvic surgeon. So we are trying to create this kind of pelvic surgeons basically to deal with these kind of endometriosis. So it all works in one brain, rather than getting into three brains.
Thank you, sir. Thank you. Thank you for this wonderful presentation and very interactive question answer. So we'll come to you again. Now we'll go to the next part, which is the panel discussion. So now I'll take expert opinion from our two eminent panelists. Let us start with Professor Abdul Qayyum. Sir, how to compare robotic surgery from laparoscopy surgery in frozen pelvis?
Assalamu alaikum. Am I audible?
Yes, yes, sir. We can hear you.
Thank you. Last half an hour, we observed our great teacher, professor, and senior fellow of Hafizur Rahman. Learn more from, but hand of Hafizur Rahman is more than the robot surgery from conventional laparoscopic surgery in a frozen pelvis. First of all, we like to know what is the frozen pelvis. Frozen pelvis is the most challenging situation for a gynecological surgeon. The reproductive organ adjacent structure are distorted by extensive pelvic adhesion, fibrosis, which obscure the normal anatomical landmark and surgical plane, ultimately making the dissection more difficult and increasing the risk of damage of the vital organ. There are the few causes of pelvic adhesion and frozen pelvis. These are the infection past history of surgery, benign conditions such as fibroid, endometriosis, adenomyosis, malignancy, radiation therapy. The inherent advantage of the robotic surgery permits the intricate dissection that help to avoid the intraoperative complication from injury to the critical structure such as the colon, iliac vessel, bladder, ureter, etc. But conventional laparoscopic surgery has inherent limitation for the treatment of advanced endometriosis from frozen pelvis because the adhesiveness of the disease and obliteration of the surgical plane in one hand. On the other hand, variability of the surgical skill and normal mechanics of the human hand. That's why robotic assist overcome some of these technical limitation of the conventional laparoscopic surgery. The most widely used system is Da Vinci surgical system. The advantage of this system include the three-dimensional image articulated instrument that allow 7-degree movement like mimic our human wrist. It also filtered the human hand's tremor at the console level and eliminate the fulcrum effect of conventional laparoscopic surgery. The camera of the robotic instrument also enable the surgeon to operate very little assistant, not having to roll assistant expertise. The advantages are more than the conventional surgery, laparoscopic surgery. So there's more the shorter hospital stay, such as the less pain, scarring, etc., etc. So the ultimately the Da Vinci robotic assisted laparoscopic hysterectomy in advanced laparoscopic endometriosis is more safe and accurate and precise.
Sir, unmute yourself, please. Yes.
Hello.
Yes, sir.
Yes, we can hear you. Dr. Qayyum, we can hear you.
Yeah. So the advantage is more than the conventional laparoscopic surgery. Ultimately, patient become shorter hospital stay, less pain and scarring, the less risk of the infection, less blood loss, fewer transfusion, and faster recovery. Ultimately, quick return of the activity than conventional laparoscopic surgery. So the Da Vinci robotic assisted laparoscopic hysterectomy in advanced pelvic endometriosis, even with frozen pelvis, is a safer, more accurate and precise. And it is an attractive alternative to the conventional laparoscopy or laparotomic hysterectomy. Thank you all for the listen here.
Thank you, Professor Qayyum. Can I have some opinion from Dr. Hafiz regarding robotic surgery in these cases? So do you think robotic surgery is better than laparoscopic surgery?
Robotic surgery is same as laparoscopy. There is actually no difference in the procedure, but the difference is the surgeon. See, if you don't have enough skill in laparoscopic surgery, that's a conventional laparoscopic surgery, robotic surgery is a very good tool. Because in robotic surgery, it's much more easier to develop the skill because it mimics open surgery in a laparoscopy setting. The advantage of laparoscopy is the vision, the bowel-less pelvis. All those things are advantages of laparoscopy. So you can actually do a open surgery in that advantage. This is what is robotic surgery. But in our settings, we are doing all onco surgeries laparoscopically. We don't find much of benefit in our setting for robotic surgery in gynecology. Robotic surgery can be used in settings like ours in cases of Whipple's surgery, or in cases of thoracic or bypass surgeries, or in cases of radical prostatectomy. These kind of cases, it may be useful, but not at all in gynecology if you have a good, skilled laparoscopic surgeon.
Thank you, sir. Thank you for your opinion. So let me go to the second panelist of this session, Professor Shamshad Jahan Shelly. My question to Dr. Shelly is that, is there any advantage of using fluorescence camera when robotic surgery is chosen for deep infiltrating endometriosis? Professor Shamshad Jahan.
Thank you, Dr. Tanjim Samina Chodri. Assalamu alaikum, respected chairperson and dear audience. Let me express my gratitude to the organizer for having me in this fascinating session. It was a magnificent presentation by Dr. Hafizur Rahman, who has been my mentor in endoscopic surgery for the last 20 years, more than 20 years. Thank you, Dr. Hafiz. Deep endometriosis is probably one of the main indications for robotic surgery in gynecological practices. The surgical treatment of deep infiltrating endometriosis present intrinsic distorted anatomy of the pelvis, which make it difficult to recognize and isolate the pelvic structures, and they need to be as radical as possible to improve the life and fertility. In this scenario, the role of robotic surgery may present an indispensable tool to achieve an optimal surgical target because of the advanced visualization, wristed movements, 3D magnification of the operating field, tremor filtering, and ergonomic positioning. Robotic surgery has no added value for the treatment of early stage of endometriosis. Just Dr. Hafiz said, and we know all who are working on this. Robotic surgery has considerable advantages in complex endometriotic surgery, like involvement of the rectum, bladder, ureter, rectovaginal septum, and other pelvic fibromuscular structures, ligaments, even vagina. Robotic surgery seems to be even safe in management of extra-critical conditions like diaphragmatic endometriosis. The question is whether fluorescence camera is helpful in diagnosis deep infiltrating endometriosis. The use of fluorescence camera preset to robot to visualize the deep infiltrating endometriosis can bring surgical advantages, like the ability to highlight the transecting line of rectal resection, a good control of vascularization after bowel anastomosis, and a better visualization of rectal nodules, limits during shaving technique. Thank you very much. I had one question to Dr. Hafizur Rahman. Are you using fluorescence camera now during robotic surgery?
No, we are not using the fluorescent cameras now. Not now, we have not used it.
Thank you very much.
Thank you, Dr. Shamshad, for your valuable remarks. I have one last question to Dr. Hafiz. A lot of our attendants are asking about training at your center. Post-pandemic, have you started your training sessions, and how can they go and things like that?
You can see all of them here. I cannot be with trainees, you all know that.
Okay. Thank you, sir. Thank you for your
I cannot be without trainees.
Thank you, sir. Thank you for joining.
Yeah, thank you, sir, for those for sharing with us those amazing surgeries and your very interactive and informative question-answer session. So now I'm requesting two eminent chairpersons of this session for their valuable remarks about this session. Let us first invite Professor Kohinoor Begum for her valuable remark. Madam.
Thank you, Samina. Thanks to the organizer, and many thanks to Professor Dr. Hafiz for his excellent presentation to speak a complicated topic in a simplest way. So there are three things. What is frozen pelvis? What is the surgery? What is the role of robotic surgery? First, the frozen pelvis is a condition meaning the organ of the pelvis are densely adherent to each other, mainly due to infiltrating endometriosis, and the organ involved are rectum, bladder, ureter, uterus, and even large and small bowel, ovarian tube also. As the adhesion grow deeper, the soft tissue and the organs of the pelvis becomes more hardened and become rock-like. So it is difficult to approach in surgery, for surgery. How serious is the frozen pelvis? A frozen pelvis or deeply infiltrating endometriosis is an end organ disease. It is characterized not only by the pain and infertility, but it is also associated with serious dysfunction of the organ of the pelvis involved in adhesions and obliteration of the normal anatomical space. So next treatment, surgery is the method of choice for the frozen pelvis treatment, whether laparoscopy or laparotomy. Previously, it was taught that the frozen pelvis was a contraindication for the laparoscopic approach, but now it is time to say that a laparotomy is contraindicated in a frozen pelvis. One can depict the tissue plane required for restoration of normal anatomy without the fission and magnification that laparoscopy offers. So compared to laparotomy, minimum invasive surgery has shorter operating time, smaller scar, faster recovery, decreased adhesion formation, decreased hospital stay, and decreased morbidity. Then who should do the surgery for a frozen pelvis? As it affects the numerous organ system of the body and requires a holistic approach to treat the disease, therefore, advanced endometriotic surgery must be dealt with at an endometriosis center with a multidisciplinary team, because sometimes they're sometimes necessary to remove to dissect the gut, to dissect the ureter, to dissect the bladder. So every time the respective and effective surgery team should be available there, whether robotic surgery or conventional surgery. We believe that robotics assisted laparoscopy is advantageous for large complex masses in the presence of dense adhesion in the women's desire, if the women desire to preserve the fertility. There are some advantages of robotic surgery also. The 3D view with deep perception, high magnification, higher range of movement, and better instrument stability. But these features and pathology around the vital structures such as internal, external iliac vessel, ureter, bowel, which would be more difficult to perform using conventional laparoscopy, even at the hand of an experienced surgeon. Now, at the conclusion, I can say, in the correct hand, a frozen pelvis should be preferably be treated laparoscopically, and an open procedure should be avoided. Endometriosis with the frozen pelvis is truly difficult surgery due to distortion of the anatomy, constant oozing by the newly formed vessels in the surgical field. Unfortunately, many surgeons feel that they should just do as much as possible they can and then hope that medication will cure rest of this. But we advocate that if one stumbles upon this pathology, it's better to do nothing and come out and refer the patient to a specialist rather than create further surgical insult and undertreat the disease furthermore, makes it significantly difficult. Thank you.
Thank you, madam. Thank you for your valuable remarks. Now I'm asking Professor Shardar Naim for his valuable comments of this session.
Thank you. Thank you very much, Dr. Tanzim Samina Chodri, my co-chair, respected Professor Kahinur Begum, the panelists, Dr. Shelley and Abdul Qayyum. And I can see Professor T. Chodri here, and I really do offer my sincere respect to Professor T. Chodri, who has really shown us the laparoscope in this country. He is the person who brought laparoscope in this country, and during our students' life, we could learn about laparoscopic procedure from Professor T. Chodri. My deepest respect for him. And definitely here I can see Professor Samina Chodri, Professor Laila Ajiman Banu, and many other senior faculties and teachers, rather teacher of the teachers. And I had the opportunity to work with them since I was a laparoscopic surgeon from my very early stage of my career. And I just had the opportunity to bring laparoscopic surgery in this country back in 1991. So I'm so delighted and I'm so happy to be here in the first virtual conference of the EASB. And that's a great privilege for me to be here. And well, Dr. Hafiz, and he's a gifted surgeon. He's a master surgeon. I had the opportunity to see his surgery in many workshops, even on some occasions in the workshops which were organized in my own hospital, Japan Bangladesh Friendship Hospital. I do believe Hafiz remembers that very well. And it was really always, it is really great to see his work and his master maneuver, master manipulation of, and master, well, it's really very hard to describe his capacity of doing surgery, even in such difficult situations. The surgeries we have seen today are really not only gynecological, this is totally urogynecological procedures. And these are really masterworks, and even for the senior surgeons in this field, it should be very difficult. And well, as the present president of the Society of Endolaparoscopic Surgeons of Bangladesh, I feel very strongly that it is very important to have extensive and intensive training among the gynecologists to go for such surgeries. Nothing is impossible. Our gynecologists, many gynecologists are really very gifted, and I'm sure Hafiz is doing a lot for the surgeons of this country, especially the gynecologists, and he is training our gynecologists for quite a long time. And I really do appreciate Dr. Hafiz's endeavor and his intention to train the people around this part of the world. And thank you very much, Hafiz. And I'm really telling you, and one thing really I want to let you know, Hafiz, and all of you probably know it, that Society of Endolaparoscopic Surgeons of Bangladesh was really formed by these general surgeons as well as the gynecological surgeons. And the gynecologist is having almost 1/3, not more than 1/3, 30 to 40% of membership of our society. So we love to work together, and we have been working together for a long time, and we will keep on working together. And I really congratulate EASB for organizing such great session of pre-Congress workshops. And definitely in this COVID era, a difficult time, what you are doing is just amazing. I'm sure quite a good number of gynecologists were tremendously benefited with these workshops, and hopefully we will keep it on in the future. And ELSB is always ready to work with EASB from now on. We can go for even joint programs in the future. Robots are knocking at the door. Eventually robot will come. When I started laparoscopy surgery back in 91, I never thought robot will come and might even replacing surgeons to some extent. Maybe AI, artificial intelligence is also coming up. We never know what is coming in the future. So everybody will have to be ready for accept the new things. And I can see Professor T. Chodri sitting here for long hours just because he also wants the juniors and the young generation to be acquainted with the latest technologies, and definitely we will have to accept those in time. Thank you very much, Tanzim Sabina Chodri. It was excellent moderation. I should congratulate you. And Hafiz, there is no word to thank you and congratulate you for your great work. Thank you very much. With this note, I really conclude my
Big hand to
remarks
Dr.
as the chair.
Hafiz.
And
Big
I'm
hand
really
to you,
privileged for being here. Thank you very much.
Thank you.
Hafiz.
Thank you,
Wow.
Professor Naeem, for your enthusiastic remarks. Now I'd like to request Professor T.H. Chodri to say a few words after Dr. Hafiz's presentation.
Actually, what can I say? The first important thing that today's presentations were mostly in advanced laparoscopy, and of course, advanced laparoscopy will be required if you do surgery in endometriotic situations, especially infiltrating type of endometriosis, as you have seen. But techniques can be learned by patience, by sincerity, and your desire to carry your experience or your working field a little larger every day. That means you go on running every day by looking at others, and even sometimes by encountering mishaps yourself. The important thing, I think, is endometriosis is not synonymous with surgery, as you all know. There are lots. The most important thing in endometriosis surgery is to know whether surgery is needed or not. I think that is the most important decision you have to make. Second is, you have to have a perception that what this patient might need and whether I or my institution is capable of providing the service. Incomplete surgery is always bad, and it makes subsequent surgery much more difficult. So and third, it may sound unpleasant to somebody that there should be a knack for endoscopy. You cannot write a poetry by reading books or something like that. Poems have to come from your heart. Endoscopy also, you have to have a knack for doing it. You cannot go on training for endoscopy unless you have that interest, perseverance, and your desire to spend your time and energy for this person. But I don't want to discourage you. Anybody can go up to the level of what I can say, a reasonable laparoscopic surgeon. But not everybody will be like Hafiz or some of the people who have seen the advanced laparoscopy. So know your limit. That is the most important thing. First is decide whether surgery is required. Second, know your limit. Don't overstep it. And last is, if you think that your perimeter is still short or still small, go on expanding it by learning, by training, by watching, and by encountering what I should say, difficult situations. So thank you very much. And a mentor is always a very helpful person to carry forward your training. It is not the videos which actually will take you very far. You will have to see this operation being done by masters and know their tips and tricks, and that will carry you further forward. So thanks for arranging this beautiful series of lectures, and I think it has benefited many of us. So don't despair if you think that this is too much for you, but you can progress, you can really make advancement if you devote time and energy. So I wish many of you will become good and very, very experienced laparoscopic in due course. And as you all have seen, endometriotic surgery is not just only laparoscopic surgery, it requires something more also. So keep that in mind, and hopefully our management of endometriosis will be better. We can think again before we go for our surgery. So thank you very much. for arranging this series of discussions on laparoscopic surgery and endometriosis. It may be eye-opener for many of us. Thank you.
Thank you, sir. Thank you for your very valuable and practical remarks. Now we have come to the end of this session. My sincere thanks to Dr. Hafiz for his excellent and amazing surgeries that has enriched our knowledge enormously. I would also like to thank the honorable chairpersons, the panelists for contributing to the session and making this a very rich learning experience. So unfortunately, this has been the last session of this workshop. Now I would like to hand over the microphone to Professor Samina Chodri to end the workshop. Thank you, everybody, and have a very good night.
Thank you, Dr. Samina, for wonderful moderation. Thank you. What to say, what not to say. I think this is a very power-packed pre-conference on endometriosis. And in this last 6.5 hours, we are together in a series of sessions where we have 6 resource persons, 12 chairpersons, 10 panelists, 5 moderators, and also most important is that more than 180 participants are directly with this session and more than 200,000 viewers in the social media. I want to say one thing, that you don't know what you have done today. And I think it creates a history. Because this is the first time in Bangladesh that Endometriosis and Adenomyosis Society of Bangladesh running a pre-congress and conference, Endo 2021. And I want to also invite you in the next, this is the pre-conference, but we have a conference on 15th and 16th October. And I think you will join there. One important issue I want to say that all the speakers, they have justified their topics. And about Dr. Hafiz's performance, only one sentence I can say, that I'm spellbound. And he is definitely gift of God. About this conference, for making a success of this conference, I need to say about Endometriosis Adenomyosis Society of Bangladesh team. They have worked hard for making a success of this program. Special thanks to scientific committee for their tireless efforts. And during these last 1 month, more than 1 month, we have started it since last 6 months, but the more intensive efforts we have given the last 1 month. And what I want to say last, that your presence and your contribution makes the program successful. I want to say congratulations to all of you. Thanks to our scientific partner, Mr. Naim and also Afroja. They are with us since a long time, and at any time when we have needed any meeting, they are with us. And last of all, I want to say, we'll meet again. We'll learn, we have learned from them. We'll continue our learning. Thank you very much. Thank you all. And thank you, Indo Bangladesh 2021.